करने के डिवाइस से यहाँ पे फोन में रहेंगे क्या बोल रहा था कि नहीं जब हम लोग अपना इससे टेलर कर लेंगे from that you have to obviously sit in the network area यहाँ वो अच्छा हुआ है इनका ये नहीं ये गैदरिंग आपकी कंसल्टिंग में नहीं होता है म्यूट माइक्रोफोन स्टार्टेड my computer is not on. You are on. Good morning, David.
Good morning. Nice to see you again.
Nice seeing you. And Domenico.
Ciao, Domenico.
Many friends are joining. We will go live exactly at 1:30. And just requesting everybody to keep time.
Okay.
So, welcome. Let's see. We have this screen. Excellent.
Good afternoon or good morning.
It's good afternoon in India.
How are you, Ash?
I'm fine.
What is the time in India now? It's
20 past 1.
Oh, okay.
And what's the time in your place?
Time is coming to 11 o'clock.
Come till 11 o'clock. Okay.
Yeah. Civilized. I have to ask somebody to cover me at the duty.
Right.
I'm seeing Andre and Keki. Keki is trying
Yes.
to, but he muted himself. Hi, Andre. Good morning to you.
Good morning. Well, here it is 8:45, so it is a very decent time.
Yeah, but it's cold outside, I'm sure. Yeah.
Oh yeah, absolutely. It is. It is. I can show it was freezing. It was freezing, cold, but nice and sunny weather, and that's always good. So it is not too bad. It is -5 Celsius. So that's.
Is it
That's
quiet on the street now in Amsterdam?
Yeah.
Holland?
Yeah, it is very quiet.
Settled?
We have a restraint. So after 9 o'clock in the evening, nobody is allowed to be on the streets outside the house. But that ends in the morning. So now, but it is a Sunday. So I know that in your place, the Friday is the more holy day.
Yeah, I understand.
Here, this is Sunday. So probably they will,
Take it
they
easy.
usually, they take it easy and they stay at home and or sleep longer on a Sunday, and especially in the winter. So no, I think this is this will be a very nice, pleasant day, also for a nice walk later on after we finished.
Keki, we are not hearing you. If you want to talk to us, you have to unmute yourself.
I'm preparing. I will prepare my coffee.
Unmute. Yeah. Now you're near. Yes. Okay. Unmuted now. Yes.
Better.
Hi, Keki. Hi there. How are you all? Everything okay?
Yes. All fine.
Yes, it's nice. It's actually now lunchtime in Bombay.
Good morning, everyone.
Morning.
Europe, and hopefully our American friends will join us in early morning their time.
Let's hope the best. Hi, Chandra.
Yes.
It was a wonderful day yesterday.
Yes, thank you.
Very well organized. Congratulations again.
We just went on a bit too long, but I think everybody stayed, so that is very, very important.
Today we have Keki with us, so he will control the time.
Absolutely. I was just going to say that if I can ask Keki to, make sure that nobody exceeds time.
Only my session I can control, not the others.
Even that would be nice.
Yeah, but Chandra,
Chandra, I'm worried about Keki. He is the one who is going to break the time.
and the biggest task he has is Atul is the first speaker.
Oh, wow. Okay. No, but listen, it is with all the live congress is the same. The schedule is so tight. There is no time to introduce somebody.
Yes.
If you tell somebody you have 15 minutes, and then the next one exactly starts a second later, that's tough. Or you have to say you have 10 minutes, and we will introduce you, and then we have 2 questions afterwards. But that's the point. If you've seen the schedule, that's 15 minutes. They will talk for at least 15 minutes, and most of them, especially webinars, they talk longer.
Actually, earlier we had written 12 plus 3, thinking that we'll have discussion after every paper, but then I think that becomes a little difficult.
Yes, that's right. Yeah.
I don't know how you're going to...
Yesterday, one speaker crossed 40 minutes. I won't name the speaker.
40 minutes. Oh,
yeah,
wow.
40. Yeah.
I think you should hammer him with respect to, they have to respect the time, I'm sure.
But I have to say, there were interesting talks, and I never really had the feeling that it's started to become boring or so, or that we really had to change anything.
It wasn't dragging, though there was overlap. It wasn't dragging. I think that was the biggest.
No, that was very good.
Yeah.
No. Well, I see the lunchtime in India doesn't prevent the others. I see Dr. Muthukumar has also joined. Hi, good to see you.
Hi.
Hi. No, that's so we will, well, we still have 10 minutes, so I take a coffee. Yeah, I mute myself so that you don't hear the machine.
Good morning. Moody joined us as well.
Hi, Chandra. How are you?
Great.
Hi,
Yeah, great day yesterday.
You are
I had to be
chairing
in
the
and
first-
out, but yeah.
Great to see you, Stefan.
Hi, good morning. Hi, Chandra. Sorry, I had to
Hi.
do an aneurysm to yesterday. I was on call. Still very tired. Okay.
I'm sure you will energize yourself by the first set of speakers.
Very good.
Yourself.
Yeah, it's going to be.
You are driving.
I am being driven, so I'm all right.
Oh, you are. Oh, this is the British system. I'm seeing you are in British system.
Yes, that Imad, that's Amir there. He's driving me.
Hi, Amir. Good to see you. Wonderful.
That's cool.
So we go live in another 5 minutes.
Yeah, it was a great day yesterday. So hopefully it'll be great today as well. Is Atul joined? Atul?
That's right. I have to call him.
So, Moody, there was a reason Atul was put first speaker.
Is that right? So all the controversies can be sorted out right at the start.
Oh, yeah. For the time's sake, I mean.
No, he's great, and so all the chairpersons will have to ask him to conclude, get to his concluding slide quickly.
Yeah. Of course, we have Kiki as on the moderator.
No, Keki is on the next one.
Oh, on the next one, I see.
Yes. So it's we'll see whether it's Henry who's coming. Henry's there? Not yet. How's the weather in Saudi, Imad?
It's a coolerish, relatively speaking, to the Vienna and Amsterdam. Okay, we have about on the range of 24.
Oh, 24 is good.
We call it cold weather. Usually we are used on the 50s, 48, 45.
Yes. So you have Nairobi type of weather at the moment.
Yeah.
Oh. Good.
So what kind of vaccine are you getting in Nairobi?
We're supposed to get
Welcome, Atul.
The AstraZeneca one.
AstraZeneca.
But that's some Pfizer ones. But I think we're going to have difficulty getting the Pfizer all across. So I don't know how they're going to manage with the logistics of having it at minus 70 or whatever degrees. Yeah.
What about you, Stefan? You have vaccine? You got the vaccine yourself?
Yes, I'm vaccinated since 1 week already. So Pfizer.
The 2 doses?
The next dose is in 10 days.
And 10 days.
Ah, nice.
Good.
But obviously, it seems that the second dose doesn't make a difference anymore. There's a good publication from New England Journal of Medicine where you see the curve is very flat, yeah, after you get the vaccination, and the second one doesn't change anything.
But
what
anyway,
are you
getting? Which vaccine did you get?
The Pfizer BioNTech.
Pfizer. Yeah, Pfizer, the first vaccination give you an 85% protection, and the rest would be 9% only.
Yeah.
Wonderful.
So, but we are running low on vaccine here, you know?
I think everywhere. The
Everywhere, everywhere.
They are not supplying, but they promise. I know
So
in Saudi
obviously
they
next
are
year.
going to the second dose, yeah.
Yeah. So how high is the vaccination rate with you? We have only
20%.
20. Well, that's good.
We achieved 20% meantime, yeah.
That's already very good, yeah.
Yeah.
That's super.
Yeah, they are doing good job with this, yeah.
No, I think we have only 7%. So
yeah, I think once the number one took the vaccination, all the society members start getting the vaccination. They were first in the conspiracy mood, and now when they see that leadership, they took it, they took it as well.
You were really good figures then. We have 0.15% vaccinated here.
Really, Andre?
It's
wow.
very low. And the only ones were, as I told yesterday, the seniors living at home, and only those 90 years or older. And those were 60,000. And we have about 200,000 vaccines, and it is very low. The strategy of vaccination is changing by the day. So it's odd. And the doctors will receive it probably, most will receive it April and May. And the elderly, let's say like me, and the end of the 60s, we will receive it somewhere September, October. At least that's now the strategy.
Wow. You know, we had some issue that one of the first ones were our mayors, the mayors of our cities.
Yeah, that
and the deans. Hi,
good morning.
How are you? Good to see you.
Andre.
That's very
they have
odd.
started with doctors and nurses.
No. And actually, the medical directors of the hospital, they have received the vaccine, not the doctors.
Yes. Same here.
That's administration.
Yes.
The whole
Same here.
Vaccinated. I mean, okay, that's
Andre,
practitioners. They are fighting now, and that they are protesting. They say we see the patients first, but they are not even in the whole schedule that they brought. So at least the whole from the 0.15.
Yeah, hello, morgen.
Hello.
Vaccination. That's all. Well,
Andre, we couldn't meet yesterday.
no, but
great.
I saw you.
Great to see you. Yeah.
Very good. No. You had you moderated, and you saw my question also. No, that's great. Good to see you here.
Yeah, great.
Morning, everybody.
We will start in about a minute, so we will also arriving. Very good.
This is for our Austrian colleagues, so they will feel home.
But you have to play now, Imad. You have to play.
This is the miniature.
Good afternoon, everybody.
You play a waltz. And then
this is Vikram Karmarkar here.
Hello, Vikram.
It is 1:30. Should we start?
Right.
Yes.
Is Atul there?
Yes, he is. So welcome everybody to the day 2 of the neuroendocrine symposium. We had an informative day yesterday. So getting to the next session straight away, we have session 5, and I have the pleasure of introducing the chairpersons. Professor Qureshi is the chairman of the Neurological Society and the co-chairman of the WFNS Neuroendoscopy Committee. We have with us Professor Schroeder, professor and chairman of the Department of Neurosurgery at Greifswald, Germany. Then we have by Dr. Suresh Sankla, who's the head of the Department of Neurosurgery at the Global Hospitals in Mumbai. And finally, we have Dr. Ashish Pathak, who's the director of neurosurgery at the Fortis Hospital, Mohali, Punjab. May I request all the chairpersons to sequentially introduce all our speakers? We start off with the first speaker. Thank you.
This is Mahmoud Qureshi. Good morning, good afternoon, everyone. We will I have the pleasure of starting with Professor Atul Goyal. who truly does not need any introduction, but I think for formality's sake, we will introduce him as one of the most illustrious neurosurgeons that contribute hugely to the webinars that have been held over the years, and has contributed a huge amount in all manner of publications, from brain to pituitary to spine. Of course, his name is linked to his work in the spine, but he is well known for everything else. I'll let Henry introduce our next speaker. Are we ready to start with Professor Atul Goyal, and then Henry will...
Yeah. I think
okay. All right.
We can start this talk.
Yeah. So Professor Atul Goyal, a pleasure seeing you again, and welcome to the inaugural talk on Sunday, 31st, at this neuroendoscopy committee.
Thank you.
Neuroendoscopy and neuroendocrine committee.
Thank you.
And we love your aneurysmal angiogram picture that you always show us. Great. Really
Thank you. Thank you.
Please go ahead.
Thank you, Moody. Now, you know what? You'll have to allow me to share my screen. Shekhar?
That's Krishna to do it?
Yeah.
Or Shekhar?
Shekhar, I am not able
ready to.
So please share your screen.
Please
I'm not able to. Unfortunately, I'm not able to share my screen. There is some issue here.
Could we sort that out from the central office?
It's clear,
there
it's
we
clear
go.
From this side. It's clear from our side.
Okay.
There we go. All right.
So, I am going to talk to you as per the wishes of the chairperson, Dr. Dev Pujari, on my classification of pituitary tumors. That is dural anatomy-based classification. And I introduced this classification in the year 1997. And I have given several lectures over the years on this subject. And I will repeat that lecture. Many of you have heard it several times. So pituitary gland is a very strange anatomical location. It is neither intracranial nor extracranial. It is located by the side of cavernous sinus in the region of sphenoid sinus, in the proximity of the chiasma, in the proximity of internal carotid arteries. So it has strange location, but illustrious companions, which make the approach to these lesions quite a tricky situation. Why this gland is located in this location is another very big enigma in neurosurgery. The relationship with sphenoid sinus is having fantastic functional correlation, which I have talked about on several occasions. Relationship with cavernous sinus has got great clinical functional implications. So this is a very wonderful subject. It has got great relationship with the dura, as you have seen, and we have discussed. The relationship of diaphragm, relationship of pituitary stalk are fantastic. And the thickness of this dura of the diaphragm celli is also a great subject to discuss and talk about. Relationship with the mucosa, relationship with various structures, as you see from the endoscopic and transnasal route, from the cranial route. So these are beautiful subjects. So I had talked about the giant pituitary tumors long back, about 22, 23 years ago. My current experience with pituitary tumors is nearing 5,000 tumors because of my very illustrious companions in endocrine department. And you have heard Dr. Nalini Shah talking about Cushing disease yesterday. We have got an experience of more than 400 cases of Cushing disease, more than 600 cases of acromegaly because of the very prominent nature of my companions in endocrine department. I have written on several occasions on anatomy of pituitary gland and pituitary tumors. And many of these papers are quite highly cited and in several books and several book chapters and several letters to editors. So giant pituitary tumors I have chosen as a subject to illustrate the anatomy of these tumors, which is very characteristic and very typical. And if you understand this anatomy, you can do surgery in a very definitive pattern. Cushing disease is a subject. Pituitary tumor in general is a highly result-oriented subject. You operate nicely, you give new life. You do not operate nicely, they die within 6 months. So it is dependent on your understanding of how to do these tumors. And you have to do them properly because there is a potential of giving brand new life. You see, these Cushing disease patients can be cured and they can be cured completely. Acromegaly, devastating disease for the patient. They completely demolish the person. They demolish the face of the person. They demolish the body of the person. You treat nicely, you treat beautifully, you give new life. So there is a potential in pituitary tumor surgery to give absolutely brand new life to these patients. How to remove pituitary tumor, functioning tumors, to remove them en masse, to remove them in the form of nodule. This has been propagated beautifully by Oldfield, our great friend. And the pattern of removal, the way to remove, the way to dissect is a fantastic chapter in the subject of neurosurgery. As regard giant pituitary tumors, they are dangerous, they are difficult, they come with visual deficit. If you treat them properly, you give them new vision. You give them absolutely new vision, and these tumors are not aggressive, not malignant in nature. Recurrence rates are high in specific forms of tumors, but not a great recurrence rate. So you understand the anatomy of these tumors, you understand the consistency of these tumors, you understand the pattern of extension, the dural relationship. You have the potential to give them a new vision. You have the potential to give them a new life, and you have a potential to get these patients out of the tumor and lead a tumor-free life. So these are complex tumors. Anatomically go here, go there, go here. They have a pattern which is absolutely, now I will give you my first word, they have an absolutely defined pattern of extension, characteristic relationships, and these relationships have to be understood if we have to remove this burden of tumor from the patient's head and make him not only visions normal, but body normal. So I have no hesitation to say, normally it is not good to say, but we have completely revolutionized pituitary tumor surgery. You will ask me how and why. First time in the literature, we said that the diaphragm celli is elevated by the tumor. Even Jules Hardy classification of giant pituitary tumor says that this supracellular extension of the tumor is subarachnoid in its location. When it is subarachnoid, you can imagine the relationships of the artery and circle of Willis, which can be quite tricky in that situation. But if it is entirely subdural, it is entirely under the diaphragm, it has got great clinical implications, and this was first described in our article on the subject. And you can see very beautifully the diaphragm celli elevated on the dome of the tumor. And this understanding that the diaphragm celli is going to be elevated has got great surgical implications, as we know. So diaphragm celli is elevated, arteries of the circle of Willis are elevated. The tumor is not in the subarachnoid location, and you can have a well-defined plane of dissection, thick enough to have a plane of dissection, and you remove this tumor, the diaphragm will ultimately land into the picture. It is as thin as arachnoid, but the tumor is not subarachnoid, it is subdural. So this is the diaphragm celli which is elevated, and I have got several patients with great kind of, you see, this is diaphragm. There is no artery within the confines of the tumor. And this has, surgical wise. tumors which just elevate the diaphragm cilia, which do not go into cavernous sinus, I have labeled them as grade 1 tumor. There can be lobulations of these tumors, but there is no encasement of these tumors. You can see this kind of nubbin of tumor. This is not subarachnoid. This is also a nubbin of dura. Dura is dura mater. Dura is encasing, loving, and hugging the child, but never squeezing or demolishing the child. This is my basis of my several publications. You see this tumor going into this region also has a dural cover, and this can form a beautiful defining border for this tumor. Going into the brainstem, all right, but a dural cover is present. So this is very going right beyond the corpus callosum, almost touching the convexity of the skull, but the dura is present, and this nubbin of dura is going to be your defining parameter. Subfrontal extension was a classical indication for transcranial root. All these tumors which I have shown were indications for transcranial root. And I am now saying, for now, not now, for 25 years, I am saying that you can remove these tumors by a transnasal route if you know that the dura is going to be intact and dura is going to be positively intact. Tumors which go into cavernous sinus, the lateral dural wall is intact, carotid artery is encased by these tumors, and you have to know that this lateral wall will never be transgressed by the tumor. Which tumors go into cavernous sinus? Knopf was discussing about this yesterday. The integrity of the medial cavernous sinus wall has been a subject of great interest for a long time, and I have also written on this subject. What is medial wall? How and why the medial wall is transgressed? So these tumors which occupy the cavernous sinus are involving the cavernous sinus, but they are compartmentalized. Medial compartment of cavernous sinus is a discrete clinical entity. Medial dural wall of cavernous sinus is a discrete clinical entity. Tumors in the cavernous sinus can go near the pituitary gland, but transgression, this is cavernous hemangioma, it will not transgress the dural wall of the pituitary gland. So anatomy, how the tumors involve the carotid artery can be displaced, can be involved, and you can design the surgery on cavernous sinus tumors. So tumors which go into cavernous sinus, elevate the diaphragm, are grade 2 tumors. So elevation of diaphragm, involvement of cavernous sinus, lateral wall is not transgressed. These are grade 2 tumors. So you please see the beautiful slides which I am showing about the defined pattern of extension of these tumors, and with understanding of this pattern, you can design your surgery. Elevation of the dura, elevation of the dura, grade 2 tumor. Now you see beautiful thing which I described 25 years ago, and a very consistent elevation of the dural roof of cavernous sinus. First time I described that this is not subarachnoid at all. This is under the roof of dura, without any question. You see elevation of dural roof of the cavernous sinus. When dural roof is elevated, I call it grade 3 tumors. Elevation of dural roof of cavernous sinus. Elevation of diaphragm, elevation of dural roof of cavernous sinus. You see beautiful elevation of dural roof of cavernous sinus, elevation of diaphragm cilia. These things have got great clinical implication, great surgical implication. My understanding is clear. If you do not understand that the dura is elevated, you just cannot remove these tumors. If you do not have the understanding that diaphragm is elevated, you just cannot remove these tumors, particularly of these giant size. You see, there is a madness in this tumor, but there is a defined madness. Elevation of diaphragm, elevation of dural roof of the cavernous sinus, elevation of dural roof, elevation of diaphragm, elevation of dural roof. You see, there is madness here, but there is a defined madness. There is elevation of dural roof. Understanding of this is absolutely crucial if you have to ever be able to define and resect these tumors. Elevation of roof, elevation of diaphragm, elevation of roof. So these tumors I call grade 3 tumors when there is elevation of dural roof of the cavernous sinus. You see this chiasma is being pressed not by the diaphragm, but the elevation of dural roof of the cavernous sinus. So these are some pictures. On rare occasions, the diaphragm is transgressed and these tumors can encase the arteries of circle of Willis. And if you say, I will remove these tumors by transnasal route, you do not understand these tumors. If you say, I can remove these tumors by transcranial route, you do not understand these tumors. These are aggressive tumors. These are dangerous tumors. And these tumors have to be properly understood. When the arteries of circle of Willis are encased, these form a malignant or aggressive pattern of pituitary tumor. So these anatomy, when the tumor goes into the sphenoid sinus, even then there is a dural cover. These tumors can rarely go and demolish the clivus. So these tumors are defined anatomically. So this was my classification. When there is elevation of diaphragm grade 1, when there is involvement of cavernous sinus grade 2, when there is elevation of dural roof grade 3, when there is encirclement of arteries of circle of Willis grade 4. And without any hesitation, I can say, even if it is not referred very elaborately in the literature, and particularly in various kinds of lectures that you even heard yesterday, that this anatomy has completely revolutionized surgical strategy for giant pituitary tumors. So I had written this paper on 265. Giant means more than 4 centimeters. You see, this is the diaphragm. This is the uterus, which is the most strongest muscle of the body. In the similar pattern, diaphragm is the strongest membrane of the body. You remove this tumor, the diaphragm will herniate into your field. You remove this tumor, most of them are cystic, soft, necrotic, no need for cauterization. Debulk, suck, debulk, and the whole diaphragm will come into the picture. And in the evening, the vision will completely become normalized. So this understanding of the diaphragm, critical, whether you use endoscope and whether you use that are minor issues. Those issues should never even be discussed. Diaphragm should be discussed. Diaphragm will come into picture. Even then there is a nubbin you can remove in quick time. Many of these tumors I remove in 15 minutes or half an hour. You see this, debulk these tumors. There is blood in this. You debulk, the entire tumor will come into the picture. And this tumor with a large belly here, debulk this tumor, the diaphragm will come into picture. So that is my understanding of diaphragm. And that, you see, large tumor, straightforward tumor, necrosis in the tumor, you remove this tumor in quick time. Controversy about endoscope, controversy about microscope, there are very flimsy controversy. You see, in 1998, I removed this tumor on the basis of understanding of the diaphragm. And I removed this tumor 22 or 23 years ago. And you see, patient, these are benign tumors. This is another I removed 20 years ago on the basis of understanding that these arteries are above the diaphragm, and you remove this tumor. Another tumor, you see necrosis, cystic tumor. This is another tumor. Inside there is some blood here. This is not artery.
Professor, we come to our concluding slides, please. We're now
okay.
On
So
time.
just, I will show you the slides. You just enjoy the slides because I can never conclude my lecture. In my history, I've never concluded my lecture.
Thank you. Thank you for your understanding.
So you see this tumor I removed 20 years ago. Just enjoy this tumor. And this tumor, some tumors recur, some tumors, which tumors recur are very big chapters in neurosurgery. This is another tumor. Cavernous sinus is another chapter. And how to remove cavernous sinus portion is a enigma. When to remove, how to remove, but understanding of the dura, understanding that the dural walls are intact are the basis of your surgery. Thank you very much, Moody. Thank you very much, Shekhar. And thank you, dear friends. I hope I have given my message, and I have given my message loud and clear. Thank you.
Thank you so much. Thank you so much. I mean, the hall would be applauding vigorously at this point, but that is something we shall continue to miss. And thank you so much for that very educational talk and the brilliant slides. We have the pleasure of asking Hemant Bhartia, Professor, who will talk next on the predictive factors in pituitary surgery. And then I shall ask my co-chair, Henry Schroeder, to then introduce the next speaker, that's Stefan and Sebastian. So, Professor Hemant Bhatia, please enlighten us with your talk.
Yeah, good afternoon, everyone. And I must thank Dr. Chandrasekhar Devpuzari and his team for such a wonderful conference. And what great papers yesterday. We learned so much on the neuroendocrine tumors. I'll be speaking on the predictive factors, just an overview about it, because these predictive factors are very important from the point of view of outcome of pituitary tumors. And let me, in the beginning, emphasize that there is no consensus about the predictive factors. The mortality and the morbidity can be evaluated by various factors. And these factors, in terms of different, like visual outcome, which depends on the tumor size, the visual deficits in the form of hemianopias, bitemporal hemianopia, or optic atrophy. When there is optic atrophy, it is said that the outcome is very poor. But in the early stages of visual field defects, the results are very fairly good. Then we have hypopituitarism, anterior pituitary dysfunctions, or diabetes insipidus, and hypothalamic disturbances, which depend on the size of the tumor, maybe. And some of the studies are there who have suggested that there is male preponderance about anterior pituitary dysfunction because of the biological behavior is different in male and female. Then there are some papers who have shared about diabetes mellitus type 2, which has the influence on hypopituitarism. And older age has also been said to be higher incidence of hypopituitarism. Then we have pituitary apoplexy with increased hypopituitarism due to either ischemia or necrosis of the adenohypophyseal cell, or there is sudden increase in the intracellular pressure. Then this, as I said about the size of the tumor, that the larger the tumor and the invasive nature, the incidence of hypopituitarism is reported to be high because of the damage to pituitary stalk or because of the damage to pituitary tissue and hypothalamic involvement and hypoprolactinemia. But as per NOSP, there is no significant difference in the prevalence of anterior pituitary dysfunction between invasive and non-invasive tumors. Then there is CSF leak after surgery, perioperative or post-operative, in infection and hydrocephalus. These are all interlinked, that you develop meningitis, you may have hydrocephalus, you can develop hydrocephalus. Then mortality has been evaluated with reference to age, sex, radiation therapy, and pituitary hormone deficiency. The standard mortality rate has been reported to be high, up to 3.6% to 1.70% in some of the series. And if we consider age, the age has been taken as an independent predictor factor. The older age has been shown to have higher mortality, but some series have shown, like Olsen, that in younger people there is high mortality. But most of the series, they agree with the older the age, the mortality is high. In spite of the standard mortality rate being shown to be higher in women, it has not been taken as an independent factor when we consider all confounding factors into consideration. Radiotherapy has not been taken as independent factor, and mortality has been found to be same in patients who have been radiated and non-radiated patients. Growth hormone deficiency is not an independent factor after adjusting the confounding factors, and separately growth hormone deficiency has high mortality, which those who have been treated with growth hormone had diminished risk. Similarly, gonadotropin deficiency, the mortality has been higher in gonadotropin deficiency, but not taken as an independent factor. ACTH deficiency has higher mortality if the total dose of treatment of has been high glucocorticoids, the hydrocortisone of more than 30 milligram daily dose. So the optimum dose which has been recommended is between 10 to 20 milligram daily. Then again, TSH deficiency, the risk of death has increased in patients who have been given levothyroxine in deficiency of less than 100 microgram daily dose. Vasopressin deficiency also not been shown to be a predictor of mortality. Dr. Atul Goyal just said his experience of more than 5,000 cases of pituitary adenoma. We have a peanut in front of him with the experience in private of 300 cases, with most of them operated by endoscopic surgery. And I'll have few cases just to show you that this case had acromegalic features with diminished vision and bitemporal hemianopia. It's a large tumor, and post-operatively total excision has no recurrence so far after 10 years. This is another patient with a 62 years male with acromegaly and headache, progressive diminished vision, and he had diabetes and hypertension. This is large tumor with going in the anteriorly, and the angle is just opposite to what we go in transsphenoidal like this, an obtuse angle here. So we decided to operate this case transcranially, and post-operatively you can see this is a CT scan, and this is an MRI after 3 months, which does not show any residual tumor. So this was a gross total removal in this. Another patient with painless progressive visual loss, urinary incontinence. You can see this was in the axis of the transnasal approach. This was the previous case. This is the present case. And so this was removed through transnasal approach. But there was some residual fecal hemorrhage. And this is the scan, MRI scan after 4 months. The patient improved in vision and bowel and bladder, but there is a small and is under our follow-up. We have not irradiated the patient. The complications have a direct relationship with the outcome and the predictive factors. So the complications have been divided as perioperative within a week, early within a week or 6 months, and delayed. But Caldwell et al. Have early before 48 hours. These are some reported complications of pituitary surgery. In our series, we also had these complications which are seen usually, and death in 1.3% of cases, 4 cases, because of hemorrhage and meningitis, mainly, which I would like to emphasize. So I'll just quickly show the mortality cases. That this was a patient with headache and diminished libido and lethargy, with hypertension and diabetes and acromegaly, macroadenoma. This was operated transnasally, had a arachnoid tear and some hemorrhage with CSF leak. Patient developed meningitis with 1800 cells, and patient died of meningitis. This is second case of recurrent pituitary adenoma, was operated in 2006, and then came back in 2012, operated by the transsphenoidal approach, had arachnoid tear and had massive hemorrhage and could not survive. This is another patient who had tumor operated in 2005, then in 2011, and then again in 2017. This was 2005, transnasal operation was done. Then 2011, again re-surgery was done. And then in 2017 came back. One can see the enhancing this capsule sort of thing or here. So the duration is important, that the capsule may get vascularized and the size of the tumor also. And this is important if the tumor capsule get vascularized. So how important it is to preserve the arachnoid so that even if there is hemorrhage, it does not go within the subarachnoid space and cause vasospasm and the related complications of vasospasm. So this patient, after third operation, developed massive subarachnoid hemorrhage and intraventricular hemorrhage, which was treated. The patient started responding again, you can see. Then we did a shunt on this patient, started following commands, fortunately. Here, up to 21 days, it was fortunate, but then unfortunately, he rebled. And then we could not save this patient.
We have 2 minutes.
Yeah, just these are the protective factors which we have discussed, and the mortality. So I said about the duration of symptoms, which may increase the tumor capsule vascularity, the size and the consistency of the tumor, because it may be difficult to remove firm and hard tumors. And if you are aggressive too much, then you can damage the arachnoid. And you may cause, even if you are scrapping too much, the pituitary hormonal deficiencies could be there, particularly in growth hormone secreting tumors. When you have to remove the tumor radically, then recurrence and redo surgery have impact. This I have already talked about: subarachnoid hemorrhage, vascular injuries, and CSF leak meningitis. Hydrocephalus may develop. Then bleeding in tumor bed in basal cistern and vascularity. So these are the predictors: age, women, and high dose of corticosteroids. These are relatively independent factors. You need more multivariate trials on these. Now, this I am just showing you that what the importance of preserving the arachnoid is. This is the large tumor operated, excised totally. There was hemorrhage, but the arachnoid was intact. In previous cases which I showed, the arachnoid there was tear and there was subarachnoid hemorrhage. Here, in spite of the hemorrhage, the arachnoid is intact. This is in the tumor bed. Patient was absolutely fine and discharged. Second, similarly, this large tumor totally excised but had some bleeding. Arachnoid was intact, so the patient was intact. So with various protective factors have been analyzed and discussed, there is no consensus. The importance of preserving arachnoid cannot be underestimated and is an important predictor factor in pituitary surgery. That's what we feel. Thank you very much.
Thank you very much. Concluding on time, and brilliant messages given. I will ask my co-chair, Henry Schroeder, to introduce our next speaker. Henry, please go ahead.
Good morning. Can you hear me?
Yes.
Yes. We can hear.
So it's a great pleasure to introduce Stefan Wolfsberger, who is a good friend of mine. He is a very active surgeon interested in endoscopy and neuronavigation, and he is currently, I think, the chief of the clinics of pituitary diseases in Vienna. And he has a great experience, and we are happy to hear you. And beside of being a great neurosurgeon, he likes skiing and photographing and flying the drones. Thank you, Stefan, for being with us.
Yeah, thank you very much. I hope you can see my PowerPoint presentation. Do you? Do I share my screen, Henry?
Yes.
Please share it.
Yes.
We see you.
Okay, perfect. So you can see my first slide, pre-surgical planning and navigation for endo and suprasellar surgery. You can see that?
Not yet.
Not yet.
No.
Okay.
All is black.
Then, sorry then. And I have to
Now we see you. That's good.
Okay. Sorry for that. Then let's try again and switch off the second desktop. So PowerPoint. Interesting. Okay, so this is an Apple issue. I try again. Can you see it now?
Oh.
No.
Not yet.
Yeah.
We have too many screens.
Yes, that's true. Yeah, so this is Apple security issue. I really apologize for this, but I cannot change it at the moment. You know what, Henry? Can you go to the next speaker? I don't know how to solve this at the moment.
Okay, we can do. Sebastian will
Thank
not
you.
join us. I hope Joachim is with us already. Joachim, are you here? Good morning.
Yes.
That's good. You are awake. That's a good sign.
Let's see if I have a better option, my presentation. Should I go ahead or?
Yeah,
what
you
is
can. Go ahead.
what is the idea now?
In the endoscopy scene, he
You want
has a
Sebastian or Stefan to, or Joachim? Is it? Oh, you want to, Henry? You want to get Joachim and then Sebastian?
Yes. No, Sebastian is not with us.
Okay.
We have Stefan. Stefan has problems with his laptop, so Joachim goes ahead. He does not need any introduction. He is the endoscopy guru, intraventricular, skull base, and spine. And Joachim, please go ahead and tell us our secrets about pituitary surgery.
Thank you for the introduction. I hope I do better with sharing my screen. Let me see.
Good.
You see my screen?
Yes, everything good.
Okay, so thank you. Yeah, I want to present a presentation. This day today is more focused on surgical technique. So I want to present our data on mono versus binostril technique. I have to acknowledge Dr. Linzler, who prepared, well, most of the data, and Giovanni Mizzoli and Dr. Case for preparing case. I still do those, although currently I have no really active consultant contract with Storz, but I was in the past very active and in collaboration with Storz to develop further endoscopic techniques. And this is where I'm from. So Henry, I guess, is sitting somewhere here. Thank you for the introduction, but I'm here, so in the center, and well, some of you know it, 1 hour from Frankfurt, Luxembourg, and Strasbourg. The department has a long tradition in development of surgical techniques, and there's still a fight whether Dr. Kasper did the first microdiscectomy here in this department, or it was done by Yeshagil in Zurich, and the Kasper system was developed here. So when we talk about endoscopy, and we usually talk about smaller craniotomy of surgical trauma of the approach and additional information at the target. Well, the indication for endoscopy in endonasal transsphenoidal techniques is a little bit different because we have a preformed cavity of the nose, so we can use both nostrils or one nostril to approach the lesion. So when we come back to the usual indications for endoscopy, we don't have a real role of the craniotomy. We will not reduce the surgical trauma of the approach since we use just the nasal cavity. So basically, a little bit we are lost. We're left with the additional information at the target using the endoscope and endonasal techniques. adenoma surgery, there's a vivid discussion whether you should use the microscope, whether the endoscope or the endoscopic assisted approach. And there's a discussion, can you use a speculum or do you use no speculum? Does it make sense to use a wide resection of the endonasal cavity to have enough space to manipulate, or is it rather preferable to have a very minimally invasive mucosa saving approach for the endonasal technique? And then, do we need additional information at the target by the endoscope? So, although differences, well, it seems to many of us that it's very clear what we have to do. I think it's in the technique which is currently brought to the patient, it's less obvious, and there's a vivid discussion what is the preferable technique. Well, we have done a small study with actually 20 cases mononostril, 20 cases binostril. It's was done because I entered a new department, and then the tradition was do a binostril approach with microscopic approach, and then we switched to a speculum-assisted shear approach, but using a mononostril approach. So this is an example for the mononostril approach, just a right-sided approach. You see here the floor of the sphenoid sinus, then opening of the sphenoid sinus through the ostia. The posterior part of the septum is resected, and then you see the cellar floor, opening of the adenoma, and closure of the situs. An example of how we did this binostril technique. The standard actually so retinoids and nasal decongestant to give enough space, and then with the binostril approach, the posterior voma was resected, and the sphenoid sinus was resected and opened, and then with the forehand technique, the intracellular lesion was resected. So this is these data which have been published. I will get back to this later in the journal years ago, and you see that when we randomized these patients 20 to 20, there were 10 male, 10 female. There was a subjective deficit in 10 and in 9. So these numbers are pretty. In our series, what was that we needed more time to use a binostril preparation. Everything else, the standard deviation was 39 to 28 minutes. So it's about a little bit more than 30 minutes more was needed with the binostril technique. All these techniques were done without ENT surgeon, I have to admit. So everything, all the steps were done by a neurosurgeon. Everything else, there was no significant difference. We evaluated the endoscope, the use of a tamponade, CSF fistula, and so on. There was no significant difference in these groups except for the surgical time. There's another evaluation of the results. See a visual deficit improved in 7 out of 8 in binostril, 5 out of 6 in a monostril approach, and so on. But basically, the take-home message was that in our small series with 20 to 20 cases, there was no significant difference when we used a binostril or mononostril technique in the surgical results. So then, actually, mainly Dr. Konrad von Mainz went back to the lab, and we did a cadaver study with the use our technique, the Wolf endoscope for the binostril technique, and the Storz endoscope for the mononostril technique. And you see here our results in the cadaver study. We evaluated what structures we could visualize with our standard approach in these 5 cadavers. You see that there was a little bit more limit in the mononostril approach when you want to look more lateral, so like the ICE, the optic canal, and so on. It was not possible to really visualize everything with the standard mononostril approach with a speculum. But when we look at the problems with we had no problems with the binostril approach and 3 out of 5, no manipulation in 2 out of 5. In the mononostril approach and the binostril approach, the approach was just difficult because of the stiffness of the fixed tissue in 2 out of 5. So overall, there was a limitation when you want to look in the more lateral extracellular space with the mononostril approach, but with regard to the cellar area, there was no difference. So this is the evaluation actually from the original paper and was published. You can look this up in the Journal of Neurosurgery, Binostril versus Mononostril Approach in the Endoscopic Transfemoral Pituitary Surgery series. So concluded on this technique, we use the mononostril approach in intracellular lesions because it's a shorter surgical time. Also, we preserve almost everything on the contralateral side. The nose is basically not touched. And the binonostril approach we use in extended approaches. It's superior for handling and manipulation. In our data, there's no data which values one nostril approach or binostril approach over the other. I just want to give you a typical example here where we use the mononostril approach. You see the typical zellar lesion. You see the distance is rather large. It's maybe 2.5 centimeters. So you have a nice sphenoid sinus, so it should not be difficult to approach this lesion, and it's not extending too much. It's just compressing the optic chiasm, but it's not really extending anterior or posterior behind the clivus, anterior to the behind the ethmoidal sinus. So this is a typical approach where we use the mononostril approach. Now we'll just forward a little bit and we can get an idea. So this is exactly what we saw with the other technique. Then we remove the midline septum and expose the sphenoid cellar floor. And then the cellar is open. And this case actually was a very firm fibrous tube here, the nice capsule, which is not always the case. I just show this case. Why do I show this case? Because there's always a discussion. Do we have to resect the capsule? And if resection of the capsule is needed, then is it easier with a binostril forehand technique? Well, I think manipulation is a little bit easier when you do a binostril approach, but actually it's also possible in these cases when you have a fibrous capsule to use the mononostril approach. So this is a post-op CAT scan. We haven't had any MRI yet since the case was just done 3 weeks ago. So what is our policy? Everything in the ethmoidal cells. If we really decide to basically done with a binostril forehand technique. Transclavus, well, transclavus, if it's just a biopsy, a very small lesion, then actually sometimes we go mononostril. But if we have to manipulate a lot, then everything is done with a binostril approach. Intracellular lesions, basically everything is done with a mononostril approach. Let's say 9 out of 10 endonasal procedures are done with a mononostril approach in our department. What is the the thing if we think about like craniopharyngiomas, so suprasellar extension? Then it depends. So if it's very easy, we don't expect a lot of manipulation. We try mononostril approach, but frequently also we use for craniopharyngiomas, for example, binostril approach. Or chordomas, for example, usually we use a binostril approach. So at present, all intracellular lesions are approached with a mononostril technique, and extended ethmoidal or transcribal approaches are mainly done with a binostril technique. And Dr. Linzer just put up here a compilation with the other mononostril approach results, and you see that our results with the radicality, with whether it's non-invasive adenomas, whether it's prolactinomas, whether it's growth hormone adenomas, are, but probably in some respects, particularly with the hormone secreting adenomas, rather superior than other published series. Complications, so much, we have almost no complications, and a very nice preservation of the nasal mucosa. So from my perspective, there's no strong data which values one technique over the other, and this also includes microsurgical technique. It's not, or endoscopic assisted technique. So I think probably right now the surgeon should just adhere to the technique he's most familiar with. There is some evidence for superior results with the use of angle telescopes, and we have published this in clinical neurology and neurosurgery. So when we use angled endoscopes in the end of the procedure, then there was a significant number of remnant tumor tissue detected, and a higher radicality was achieved, which does not mean that actually there was less recurrent surgeries or so, because this is difficult to show since the recurrence rate is so low in pituitary adenomas. Well, we will not show that the use of angled endoscopes really reduces the revision rate, but it gives a higher radicality to some degree. I think the most important part is the postoperative hormonal insufficiency. And I think there's a big advantage using the endoscope, because the identification and preservation of the pituitary gland is much easier. And this is just a slide from our series at the end of the surgery. Then only in 6%, so very, very low, we had hormonal insufficiency. If we were not able to identify the pituitary gland, then almost 50% of the patients had hormonal insufficiency. This is highly significant, and you see here that in more than 75% of the cases. So I think the high magnification gives you better intraoperative orientation and feedback, and this actually gives better results for the patient. So to conclude on my data, the optimum surgical treatment of cellular lesions depends on individual pathology and experience and preference of the surgeon. And just an example here, actually we treated very different. It's a very recent case. And you see it's a 29-year-old obese patient who gained weight in the last 5 years of 20 kilos. And he has this lesion here with a contrast enhancing pituitary stalk and visual deficit, very severe visual deficit. Patient was almost blind on one eye. And well, this you can discuss now, but I decided that we should do this with a supraorbital approach. So it turned out as expected. Let me see here. This is the optic, this is the pituitary stalk, and it turned out as expected to be a typical craniopharyngioma. And just to prepare the pituitary stalk out of this lesion, which was very adherent, and to decompress the nerves, I personally think that this is much easier still when you have the bimanual technique with a transcranial approach compared to the binocular approach when you also have a bimanual technique, but the distance is just much longer. So I would always prefer, if I want to really have the optimum intraoperative skills, to do a transcranial procedure. So then at the end, with the angled endoscope, we resected the tumor in the pituitary, in the cellar. Here, there was a small remnant in the cellar. And then actually we used taco seal to reconstruct the diaphragm. And this is the post-op MRI. So far, the patient is fine. And this is just an example that we talk about a lot of endonasal techniques, but I think the optimal techniques in the individual case has to be the reason for our decision. So I thank you for listening, and I hope that we can do the 10th Hamburg Neuroendoscopy Week this year. Will be our 10th anniversary, and well, we're not sure, but we will try. Thank you again for inviting me, and well, hopefully you have some questions.
Thank you, Joachim, for the presentation. We discussed later on. Your micro is very poor, so your connection is very bad. So sometimes we could not listen very well to you. Maybe you can improve this for the discussion. I don't know. So our next speaker is Stefan. Stefan,
well, there's no way. This is, sorry, but this is the best I get in my home.
Where are you living? In the forest? So Stefan, are you ready? Stefan?
Professor Schroeder, he's not ready yet. We should move probably.
Okay, then we continue with Ashish.
Yeah.
Is this correct? Yes?
Yes.
Okay, then I may introduce Ashish Zurin. I know him for a long time. He is working at the in the Institute of Medical Sciences in New Delhi. I had the chance to visit this department, very active, amazing. He has a great interest in endoscopy for many years. He is a great teacher. He organized a training program in endoscopy for the Indian residents. And his major interests are skull-base surgery, cerebrovascular, and of course, neuroendoscopy. Please, Ashish, we are happy to listen to your lecture.
Can I share my screen?
Yes.
Is it visible?
No,
is
it's
it visible?
good. Yes. Perfect.
Is my audio okay? Okay.
Audio is also good? All good.
Thank you. I thank the organizers for this invitation, and it's a wonderful conference and a difficult topic, a very controversial, pure endoscopic versus microscope versus endoscopy assistance in transnasal surgery. And oops, why is my screen not moving? Yeah. So this, I've been serving at the AIMS for the last 28 years now. It's one of the bigger departments in the country, one of the big training programs. And this is actually, we have to understand, and when we are putting the endoscope or the microscope through the nose, we have to understand, are we targeting the pituitary, which is the standard between the four blue lines, between the carotid, within the cavernous sinus. We're just under the cellar. We either approaching the microscope, the endoscope. This is different from when the dura expands, but like Professor Goel said, that how it expands, and when you require an extended approach. The difference between the pituitary and the extended approach to the skull base that we have to understand. And this is my own video, 2008, I think, when I was very good at microscope. And you can see the hardy speculum inside, and we're putting, this is, I think, the old Leica or the NC4 Zeiss, I think that must be that. And we take off I was trained under the microscope in the 90s by my teachers, Professor Banerjee, who you met yesterday, and Professor Mehta. And used to do this microscope surgery within, we used to actually, never 15 minutes like Dr. Al Goel, but always 30 to 40 minutes. It used to be over. And then you see, and then there's a difference. And then I was trained in endoscopy, ventricular endoscopy by Professor Gab in Greifswald. And then my friend, Professor Martin Bittag, actually taught me in the mid 2005 to I think 2010, and then you realize that the endoscope actually your visualization starts where it ends in the endoscope. So for the cellular lesions, it's good. Both are good, but the moment you start expanding and then you start seeing more. Regarding mononostril and binostril, I think if you are doing an endoscope through the microscope, mononostril is always the one. But the endoscope, for the endoscope, it's always binostril. It's never most mononostril in my hands. You see more, and then this is what you start seeing more. You can actually start seeing where the tumor is, and you can do the hemostasis. This becomes fine. So in the microscope, a standard microsurgeon, no fogging, 3D vision, good hemostasis, good bimanual dissection, but the endoscope gives a panoramic view, a wide angle, and probably a better visualization. We don't use the C-arm at all, and we use the navigation now. This is the difference. A pure pituitary surgery within the 4 blue lines, a standard pituitary adenoma, is a minimally invasive, simple endoscopic approach. It can be done with a microscope as well. They're the same. The moment your dura expands above or the sides and you have extensions, it becomes more of a maximally invasive or an optimally invasive. You actually take out more skull base. You actually take out more mucosa. There's a middle turbinectomy involved. There's a nasoseptal flap for the repair. It becomes a 2-nostril, 4 hands approach, and that is an extended approach. And you have to, this is the harvesting of the Haddad flap, the nasoseptal flap based on the nasopalatine branch of the sphenopalatine artery. And this is the vertical incision, the horizontal and the upper horizontal incision. And the skull base repair is, sorry, the dural incision changes. And in a standard endonasal, it becomes a 5 o'clock to a 7 o'clock. But in extended approach, it becomes an inverted T, or you can make it a lying down H. You take your limbs up towards the planum and the tuberculum, and this is where you incise the anterior intercavernous sinus and coagulate. The repair has to be very meticulous, especially when you're doing an extended approach. Standard endonasal, no problem. You can put if no CSF leak, you can just put some gel foam or Surgicel and just close it. If it's a big cellular defect, you can put some fat. But if you are doing an extended approach, you need a 3-layer approach: a fat plug, then an inlay facial lata, and then a Haddad flap, and then again some fat packing over there, and then and some gel foam and all, and then reinforce with some glue. But what happens if it goes beyond these dural lines? It goes beyond the nerves and the arteries. That is different. That you cannot do with endoscope. Then you need some microscopic approaches through the cavernous sinus, either centered on the anterior clinoid process or the posterior clinoid process. So what about standard adenomas, standard pituitary adenomas, endoscope or microscope? This is my evolution. I was trained as a microsurgeon, and this was where in 2002, it was 2000, I think I trained in Greifswald, ventricular endoscopy. Then 2008, it was BITAG. And all this time, I was a student of Vinko Dolenz and learning to do all these approaches. So I changed completely from a microscopic. It's 10 less than Dr. Goel. So it is 580 till last year. That's pre-COVID. And now it's all endoscopy. And along with that, transcranial, but which I always mix with a transcavernous if it's required. So review of literature, a systematic review and meta-analysis, 23 case endoscopic series was higher gross total removal, but there was no difference in CSF leaks. There was another series in which the gross total resection, visual improvement, and the overall complications, there was no difference in microscope or endoscope. However, the length of stay was much longer in the microscope. Regarding Cushing's, microadenomas, this is another systematic review and meta-analysis, 97 articles. The results were same for the microadenomas between microscope and endoscope. For macroadenomas, endoscope was better, 76% remission versus 59% remission. And there was lower recurrence in Cushing's after with endoscope, 1.5% versus 70%, but the CSF leak was higher. Regarding growth hormone secreting adenomas, 31 studies, another systematic review. And for the non-invasive macroadenomas, endoscope was better. But for invasive macroadenomas and microadenomas, there was no difference between microscope and endoscope. This is another for recurrent and residual pituitary adenomas. There was this was microscope was better. The endoscope was better than the microscope for recurrent tumors, and the visual improvement was also better. For the IC injuries, it was slightly higher in endoscope than the microscope, but it was said, but in these series, the review of these series said that the more experience, you less likely to injure the carotids. This is our series from AIIMS on Cushing's disease, which was published, I think, a couple of years ago. And the remission rate with endoscopic surgery was significantly better than microscopic. Endoscope is nearly 88% in my personal hands. And when I was on the microscope, it was 56%. With univariate analysis, we found that endonasal TNTS, day 1 morning cortisol, and day 1 ACTH were significantly higher predictors of remission. Multivariate analysis, the most important predictor of remission was the morning cortisol level. This is a standard position. In an endonasal, we use the infraumbilical incision, and that is the exposure that we are talking about. For standard adenomas, we don't only use one screen. For giant and invasive ones, we use a double screen that is required sometimes. The standard 2-nostril approach, right side, left side, and then the sphenoidal stage, the cellar opening, and then the extra capsule, and then the dural opening, extra capsular dissection. And the good thing about the endoscope, you can see the normal pituitary gland and preserve the pituitary gland. See the arachnoid bulge, and if there's a tumor which is bulging into the cavernous sinus, there's a difference in the bulge and invading into the cavernous sinus. You can actually see and remove that part of the tumor. And this is tumor which is going down. That's a small posterior septostomy. I'll just forward these so that we are able to save time. And then the septum is undeviated to the opposite side, and take off the vomer. That's the nasal stage. We do all ourselves, no ENT with us. So because they have their own busy clinics and ORs. We work with each other for the angiofibromas and for the petrous works. But there's something that we're doing ourselves. And then we go to the opposite side. And that's the opening of the cellular floor. Dural incision from 5 o'clock to 7 o'clock position. And then make a U up above so that we preserve the arachnoid. Then some extra capsular dissection. Again, tumor removal, first posterior, then lateral, and then anterior. You see the arachnoid bulging. That is the problem. Once the bulge starts, and you can deliver the tumor slowly. This was not possible in my hands, at least in the microscope, especially the lateral tumor removal, and then pushing the arachnoid back in, because if you leave it here, the postoperative scan will show the tumor again. So you push the arachnoid back with a cotton patty, and then you remove the rest of the tumor. And then if there's no CSF leak, just pack it with FAC and close. What about giant and invasive pituitary adenomas? What is the best, endoscope or microscope? So like Dr. Goel also already mentioned, size of tumor is important, but pattern is very important. That was the landmark classification, which he already mentioned. The pattern of growth is more important than the size. And especially in the cavernous sinus, NOS grading and the modified NOS grading into 3A and 3B is very important. So in grade 4, with total encasement of the IC, gross total resection is as close to 0. But endoscopic visualization is much better. And we see that this is the NOS4 score is much worse. Regarding the negative predictive factors of the fibrous tumors, extension of the cavernous sinus, NOS 3-4 grades, subarachnoid extension, grade 3-4 Goel and NOS 3-4 of NOS, and multilobular configuration. Many series have said that, but these are individual series in which better outcomes, like oncological and clinical outcomes after endoscopy. This is another one in which it compared endoscopy versus microscope, transsphenoidal, and open transcranial approaches. And this was better paracellular extension. This was a very good meta-analysis and review, Schwartz department, in which the NOS 3-4 cross-total resection was much better than in endoscope than in microscope. There's another meta-analysis with 16 studies in which the microscope cohort has had lower resection rate and worse visual outcomes than the endoscope. This is my personal series with 60 cases of giant adenomas, with all of them above 4 centimeters, 1/3 having paracellular extensions. This is purely transphenoidal series in which majority, 80% were endoscopic and 20%. This was, I think, last 10 years. One IC injury, but patient did well. We lost 4 patients, more because of the residual tumor hemorrhage. Univariate analysis, we found that the retrocellular extension, subfrontal extension, cavernous sinus extension, and multilobulated tumor and T2 hypointensity were poor predictive factors. In the multivariate analysis, the multilobular tumor shape lost its significance. We found that in giant adenomas and invasive adenomas, endoscopy was better for subfrontal and the paracellular extension. It was not the vertical, but the side and the front extension. And we actually reduced our transcranial transcavernous route, which I used to love earlier. That number has reduced. And the gross total and the near total resection rates were comparable to literature, around 30 to 40% gross total and around about 20 to 30% near total. And talked about the factors affecting the extent of resection. The visual improvement was around about 67%. These were the cases with subfrontal extension. That was what NOS3A and GOEL2 cavernous sinus extension. This is another one. There's another one which is near total resection. This patient had a post-operative apoplexy. We had to go in transcranial, and there was near total. This was the only one we did a combined EATS and transcranial and subtotal. This patient had a STOMI post-operative course with a subtotal residual. This was a NOS4, GOEL2, and this the side of the 4 we actually take off the middle turbinate. So I don't take the middle turbinate at all in any other pituitary adenomas, except if there is a paracellular extension. A Haddad flap. It's always better to cover the bare ICA with a nasoseptal flap. Especially drilling is much more over the right cavernous sinus and also on the dorsum. The navigation is important, especially doing the extended approaches. Especially the 1 o'clock, that is, you'll see the carotid, that is the carotid there. We use the Doppler and we are drilling some more and taking up that dura. That is a bulge of the tumor that we have to remove. And then another is a lateral bulge. And that is, we incise the dura lateral to the carotid. And we can just divide this dura. The carotid is lying in the middle. Flow seal helps for the cavernous sinus bleeding. Then fat, Haddad flap. Then bilateral NOS4, GOEL3 or 4. This was a difficult. I've done 2 or 3 such bilateral cases. Bilateral middle turbinectomies and Haddad flap. Drilling not only on the cellular floor, but bilateral cavernous sinuses and also of the planum, if you see. And we are dividing the dura, that's the anterior intercavernous sinus, which is coagulating divide. That's the supracellular extension above, coagulating the anterior intercavernous sinus. Then decompressing the cellular component first. As expected, the supracellular is soft. And then we go lateral to the carotid.
1 more minute, please.
Yeah. Because this was a big talk. So this now going lateral to the other side carotid as well. And both the carotids are bare. The CSF repair is done on the upper part, that is the supracellular cistern. The lower part, so it's a 3-layer repair. So this was the tallest lady in the world we operated. This was a nightmare. Very, we didn't have the longest instruments that were required. But these are the difficult ones. What do we do for these? These are not for endoscopic or endonasal. They require transcavernous. This is how Professor Caldwell showed yesterday. Mobilize the cavernous sinus. And then the Parkinson's triangle. That is a tumor. So you cannot completely eradicate these tumors. The main idea is if they are functional tumors, you have to make them amenable to medical therapy and make them smaller in size so that gamma knife or medical therapy can be given. I think I just go to conclusion. I think that's the best thing to do. Oops.
Thank you, Ashish, for this nice presentation.
I'll just conclude with the last 2 slides, I think. So in my understanding, endoscopic endonasal transfemoral approach is safe and feasible for giant pituitary adenomas. Extended endoscopic endonasal approach has a better extent of resection. The poor extent of resection was found with retrocellular, subfrontal, and cavernous sinus extensions and MR hypointensity. And we found that extended approaches give better visualization beyond the 4 blue lines and also beyond the dural extensions. We found that extended approaches are the best for extradural tumors, chordomas, chondrosarcomas. There is no difference between microscope and endoscope in a stellar lesion, but the extended approaches are required, are appropriate for cavernous sinus extension for NOS 3-4 or GOEL2 extension of a giant pituitary adenoma. And very controversial. I'll still feel good doing a craniopharyngioma from below. And suprasellar meningiomas is controversial. Because of lack of time, I've just skipped the slides. But extended approaches are optimally invasive, require more drilling, more mucosal mobilization, and require a lot of repair. Thank you.
Thank you very much. So we discuss at the end. So now the question again to Stefan.
Yeah, I think it should work this time. Let me try.
It's your last chance.
All right. So
Looks
can you see
good.
my PowerPoint this time?
Looks very good.
Even a complete screen?
Yes,
yeah,
perfect.
Okay, perfect. So thank you very much for the invitation. Yeah, it's very hard to add anything more after these last lectures, but as you know, I like navigation technology. I will show you something that we do in Vienna. So what it is all about. I would like to start off with a severe complication in this 75-year-old male with a very unusual cellular tumor. As you can see, he was referred to us as a pituitary adenoma. However, we were not completely sure if this is the truth. So here you see the intraoperative video, and I will go a bit forward. We did not have navigation at this point of surgery, so we tried to coagulate here the intercavernous sinus, as we always would do with a transtubercular approach. And then we took, as you can see here, our knife, and we made a horizontal cut. Well, we did. Again, we had no navigation where the knife was. We did not feel any resistance, but as you see, here is a carotid artery bleed, and it is actually, as you can see, a very flat cellar. So we were not completely sure if we could prevent this in future. However, if you use navigation, of course, you can see it. So this patient was finally treated with the extra intracranial bypass surgery and obliteration of the carotid. I don't want to go into detail of this case. So what I would like to show you now is a case of a 14-year-old female with a recurrent invasive non-functioning pituitary adenoma. And she was operated about 10 years before in a countryside hospital of Austria and checked for a couple of years, but then lost to follow-up. And finally, she presented to me with a normal vision, with no anterior pituitary insufficiency, but with a intermediate left cranial nerve 3 palsy. So oculomotor nerve was obviously damaged. So we knew that you had gamma knife on the left side of an invasive part of the pituitary adenoma. And as you can see here, that's the pictures how she presented to us. So on the left side, obviously the carotid artery is encased. You can see that here. So 3A and 3B, so superior inferior cavernous sinus compartment is filled. And this was the area where she had gamma knife. So we didn't know really what to expect. However, we expected a carotid artery where we needed Doppler and navigation. So here's the navigation planning as we always do. You can see we like MR angio where you can see the carotid artery much nicer and the bone in a separated CT. You can see the pituitary gland that's in the middle. And here is a T2 cis image where you can even better see stalk and pituitary. You can see also the extension of this pituitary adenoma here, yeah. And you can see also there's a lot of bone on the hypostosis on the cellar floor. So here's our setup. You can see we are not using any irrigation shaft anymore because of this plastic tube, silicone tube that we have designed especially for the pituitary transnasal approach. So you don't need irrigation because there's in fact no bleeding from the side of the endoscope. So first of all, we always do endoscope cellar floor anatomy matching, and we always have the navigation screen on our side. You can see it on the right top picture that we always know where we work. So we do a navigation guided drilling, and we always have the suction that is checking for the position. So here's our Doppler probe, which we always use as a gold standard to check the ICA position. And when we do the hypostotic bone at the cellar floor, I think it's very, very useful to understand always where the carotid artery is in relation. So first we remove the right paracellar adenoma. So this was not the adenoma that was gamma knifed. And then we go to the left side. And remember, we expect some paracellar extension on this left side, and we expect to see the carotid artery. And actually the adenoma was very, very soft there. And we knew here now is the carotid artery. It was quite easy actually to remove that adenoma around the intracavernous carotid artery from the superior and here even the inferior cavernous sinus compartment. So you can see the carotid artery is freed completely, yeah, until we see even the sixth nerve here inside the cavernous sinus. So finally, we got a very, very nice resection. We kept the diaphragm intact, we kept the pituitary intact, and we could even remove the posterior extension close to the sinus. So that's the postoperative result. You see the pituitary is kept intact. The adenoma is, well, totally removed. She has no visual disturbance. The left cranial nerve palsy resolved. And it was a non-functioning adenoma as before with quite a high MIP index of 6%. So this is how we do our pituitary surgery and also our extended pituitary surgery. So what are the features to plan preoperatively? So we try to identify, of course, always the microadenoma position, then in macroadenomas, the extensions. Of course, we try to preserve the pituitary gland and stalk at all times. And of course, the optic chiasm, especially in extended approaches. Then we try to tailor the approach. So we check if a middle turbinectomy is required, as we heard before, especially in right paracellar extensions on the left side. It's always easier to work from contralateral. Then we tailor our cellar floor opening. We check the sphenoid septations if there are any variations, especially in standard and extended approaches. And then we identify, of course, the carotid artery, as I showed you, and optic and oculomotor nerves. And then for the closure, we try to anticipate, do we need a nasoseptal flap? Because of course you have to prepare it before you destroy its attachment. We always take a bone harvest to close the cellar, and then we prepare for fat muscle and fascia. And here now is our multimodality image fusion, which we think is quite useful. You see a contrast-enhanced MRI, standard MRI. So inside the cavernous sinus, you don't see a lot, as you can see here. Yeah. If you use MRA, which is only 6 more minutes adding to the MR scan, then you see it works very well. You can do a CT scan, which we always do for any transnasal approach, but you don't see the septations. You see that here? There's no septation seen. But if you use the same CT scan a second time and window it differently, yeah, you can immediately very nicely see the air-bone transition. And I think this gives you a very, very nice orientation during the approach. See here even the sphenoid ostium. So this was published in 2019 in Journal of Neurosurgery, and you see also the recipe how you can do this multimodality imaging in your department. Here's a small case. You see this is actually endosuprasellar pituitary adenoma. The suprasellar area a bit bigger, so you have to open the sellar floor quite widely. And the surgeon reported on the next day that the sellar floor was so flat he couldn't remove the suprasellar part. Well, that's possible, but it's only possible if you see what happens with the septations. You see there is an onody cell here, and if you don't know about it and if you don't open it, then of course the sellar floor is super flat, and you probably run into trouble removing this anterior part. But if you have this type of imaging, I think it's very easy to anticipate. Never forget there is some shift, as we heard before, of the carotid artery, especially in parasellar extending adenomas. But this shift is only at the posterior part of the carotid and not at the anterior part where you enter the sellar floor, because here the carotid is fixed at the ring and at the bone. So then last year we tried to optimize the MR imaging for intraoperative guidance, and we found out that the so-called VIBE sequence generates much better pictures, which much better shows the invasiveness and the normal gland position. And also we now include always the T2 cis sequence, so a high resolution, high contrast T2 sequence, which very nicely shows the optic chiasm and the oculomotor nerve. So here's another case of a tuberculum cell meningioma. You can see that here with no change in visual acuity, but intermittent headache. So here was the picture before, and you can see it's very, very medial, so a very good indication, I think, for transsphenoidal approach. It does not cross the carotid arteries at all. It's just infrachiasmal. And you can see here on the sagittal picture that there is not even a tail to the sphenoid plane. So if you do T2 cis sequences, you can even better distinguish. And here are the planning pictures. And you see now that if you look at the optic canals, there is no entrance of this meningioma into the optic canals. So again, it's a very good indication, I think, for a transsphenoidal pituitary surgery. Yeah. So here is the same multimodality imaging with cis sequence. I think you see very nicely optic nerves and the transition to the meningioma. So here is the video, which I don't want to go into detail. Of course, we always match the sellar floor. We check the carotid artery position. We open at the intercavernous sinus. So here we also have actually the detachment of the vascular supply, as you can see here. And then finally, we generate the plane between the meningioma and the optic chiasm and nerves, which was actually quite easy. And finally, we found out that the detachment was a bit on the left side. So finally, we coagulated there. So see how nicely the plane develops. So finally, the outcome was very good, but it was an atypical meningioma with 9 mitosis in 10 high power fields. So we have to observe her very shortly. So here again are the imaging settings that we use: MR, MR plus CT, plus double CT, MRA, and the cis sequence. So this is so-called our recipe that we use for all these endoscopic and skull-based approaches. A word how we navigate, we always use a suction that is tracked so that we have a continuous navigation, either the cheap version putting a stylet inside our regular suction, or the more expensive version having a malleable suction. So then we have generated this, which is actually a specialized tracker, which is put into the mouth of the patient, so that the tracker is very close to our working area and is very accurate, because of course if you work at the carotid or close to the carotid, you need accuracy of a millimeter, and this is what this tracker generates. Yeah, you get accuracy of less than a millimeter, and of course you don't need a skull clamp for navigation, so you can move the head even during surgery. So here's my last case. 68-year-old female with a craniopharyngioma, visual loss. So especially on the left side, she was not able to read at all anymore. There was no pituitary insufficiency, no diabetes insipidus. Here you can see the images. And you see it's quite a supercellular mass. You see the pituitary below here. We're not completely sure where the stalk is. Not on these pictures. Yeah, we just see the pituitary gland below. So here's our planning. So that's our standard T1 planning, and here's our T2 planning. And what may be of interest, so you see very nicely the chiasm on top. You see the left part of the chiasm, so the left optic nerve, optic tract is very thin, which explains actually the atrophy and the visual loss mainly on the left side. Here is the pituitary stalk, which we discovered on the CIS images. And here you see the extension through the lamina terminalis. Here you see an extension through the tuba cinereum into the third ventricle, which we have to take care of. And this is again our image during surgery. So we're always tracking the suction, as you can see. Yeah, we have a lot of space since we don't use our endoscope irrigation anymore. It gives us about 2 millimeters more. And you can see, as always, we open at the intercavernous sinus, we coagulate there, and we cut while we navigate and see exactly where we position the cut. So you see, intercavernous sinus is coagulated and cut. Then the arachnoid is detached from the craniopharyngioma, and we also try to develop a plane to the chiasm. First, we do some debulking. Here we try to develop this plane with water jet dissection and very careful mechanical dissection. Yeah.
1 minute, Stefan.
And yes, that's my last case. I'm done in a minute. So here's the extension now into the third ventricle, as we saw before on the T2 images. Yeah. So we are separating that carefully from the hypothalamus on the right side, removing this part, the first part of the craniopharyngioma, then separate from the left hypothalamus. And actually we found that there was the origin here at the left hypothalamus. So we didn't go for a complete resection. We left the part there because we didn't want to damage both hypothalami. So in the end, here you can see after the last irrigation that we achieved a very, very nice resection. And we, of course, did a multi-layer closure. Here you see the Haddad flap closure. Yeah, here you see the chiasm that descended again. And actually, she did not develop any pituitary insufficiency because we were able to preserve the stalk, no diabetes insipidus, and the visual acuity improved on the right eye. It did not, it actually worsened a bit on the left eye, but this is actually what we expected. And it was, as you see, an adamantinomatous craniopharyngioma. So here's my summary. I think this multimodality imaging permits a very good visualization of bone, soft tissue, and the vasculature. And you can do a very nice preoperative planning and intraoperative navigation. Of course, it adds a lot to orientation during skull-based surgery, especially if you have any variations or recurrent tumors. We like this continuous suction navigation because it gives you information at all times during the endoscopic skull-base surgery. And we developed this patient tracking device, which is very, very accurate. And we think that you need this actually if you work in delicate areas such as adjacent to the carotid artery. Thank you very much for listening, and thanks for attention.
Thank you, Stefan, for this nice presentation of sophisticated imaging and guidance. So we come to our last speaker. Does anybody of the other chairman want to introduce Imad, or should I do that? Nobody there? Then
Should I?
Yeah, please.
Yes, Suresh, could you?
Henry.
Yep.
Yeah, Henry, I was supposed to introduce Professor Kannan. Is it okay, Henry?
Yeah, please go ahead, Sunil.
Sure.
All right. So it is my pleasure to introduce Professor Imad Kannan, who is Professor of Neurosurgery, the College of Medicine in Al Faisal University, Riyadh. Professor Kannan is well known as a skull-based surgeon for last many decades. What he is more famous about is that he's very keen to the teaching programs and the education programs, and you will find him in all the skull-based workshops all over the world and the other education programs. So, Professor Kannan, we would like to welcome you here to this webinar, and please unmute yourself and share your screen. Thank you very much. Professor Kannan, please.
Yeah, I'm trying.
Need some help?
I think I'm okay. I'm trying to get in the presentation mode.
It has come.
Okay, we can see your screen.
Do you see the screen?
Yeah.
Yes.
Well, I'd like to thank Professor Chandrasekhar, Deborah, and Dr. Qureshi for their kind invitation and for the well-organized program. Fantastic lectures from yesterday and today, and I learned a lot. And I'd like to start with my presentation to pay contributions of the masters in both skull-based surgery and the masters in endoscopic surgery. The 80s and witness a major surge in the surgical approaches to the skull base, and we learned all the complex fronto-orbitozygomatic, pre-sigmoid approaches, the Kawase approach, far lateral. We built up all these expertise, and the resurgence of endoscopy that has been presented in the past, but has been fine-tuned and researched in the practice of skull-based surgery, has added an additional visualization arm to the microscopic surgery. And this is the subject of my presentation. So we move from the gross exposure and conventional surgery to a functional exposure by doing many craniotomies. And then we slowly, over the years now, we reverse to the simple approaches by the masters and the hybrid or pure solo use of endoscopy in some of the procedures that in my hand I'd like to practice. This was fostered by the design of the surgical approaches and instrumentation, adding a new microscope and endoscope technology. And of course, imaging has a major contribution to facilitate this functionality, as we heard from the previous speaker, Stefan. So we moved, this is a list of what I call it, the posterior lateral approaches, how we moved from the simple retromastoid down to the combined approach. And then now we are going back, and the same from terional to fronto-orbitozygomatic transbasal approach, thanks to the endoscopy that has aided us to revert back to a simple approach and we can use the endoscopy complementary as a skull-based surgeon. So these are the two powerhouse approaches, I call the retromastoid and the terional approach. The most important message I want to give from this presentation, talking about these two contemporary legends, Professor Kazi Yashagil and Majid Sami, the most important skills, the common denominator for microscopic surgeon, endoscopic surgeon, will remain the perfection of microsurgical technique. It has no value. The tools won't make you a good surgeon, neither the microscope or the endoscope, if you don't know the technique of microsurgery. How you select your approach? There are prerequisites for the optimal approach. This is a short, safe, direct, offer multi-avenues, provide excellent depth and panoramic views that we have added from the endoscopy, the depth from the microscope, and the minimal manipulation of neural structure, the same, both of them, but I think the endoscope has added this additional value. Facilitate bimanual dexterity. We are still more superior with the microscope for the bimanual dexterities. We hope that finding a good holder for the endoscope, that we would be privileged to use a good bimanual, although the four hands technique can be an option, but it's sometimes a limitation and negate the need for complex reconstruction. And of course, cost effectiveness is a great important part, especially in the less developed countries. So we make the decision based on the location of the lesion, the type of pathology we are dealing with, the size, direction of growth, how is the vascular anatomy and venous drainage around this lesion, and most important, patient factors, age, presentation, comorbidity, we should take it in consideration, because sometimes we follow our ego to challenge ourselves, or we forget totally about the patient and their outcome. Of course, the evolution of transfemoral surgery went through phases, and from Schloffer, and I still remember the fantastic meeting Professor Nosp has conducted on the 100 years celebration of pituitary, when we have Professor Hardy coming to the podium, and he said he has an endoscope that cost him $1. And he raised a small mirror from his pocket and said, this is his endoscope. Very interesting concept, and that time we were using that mirror for many years. And of course, many people, they don't talk about Griffith. Griffith, a neurosurgeon from Bristol, in a small publication, he presented the direct approach to the sphenoid sinus, and I think this is a major innovation and an idea that should be accredited to Professor Griffith, that we use it very frequently nowadays. So endoscopy, whether it's the Pittsburgh group, the Napoli group, the Austrian-German group, the São Paulo Brazilian group, they were a contributor to this evolution in the recent years, in the 90s and the nowadays, and it gives you the privilege to take the largest elephant from the small nostril. So it has, the endoscopy has enlarged the indication for the transfemoral surgery, became either endoscopic assisted, or for some cases the endoscopic expanded approach to take a larger supracellular or the small intercellular adenoma, the dumbbell-shaped adenoma used to be a craniotomy indication, retrocellular expansion, subfrontal and extension above and through the cavernous sinus. I have put that design for the extended approach for transfemoral surgery, the endoscopic approach, to grade the procedure itself, not the tumor itself. The tumor, Dr. Nosp has made a marvelous contribution to grading of these tumors, but I grade the procedure into a nasal cavity, grade 1 in sinus, grade 2 cellular and paracellular, and 4 supra and parasupracellular. And this is where I can adjust myself where I need badly the endoscope. It might be in phase 1. I don't need the endoscope necessarily if I know what I am doing. And after all, whether you are doing a pure endoscopic or endoscopic assisted or transfemoral surgery, your end target, you want to reach to the face of the sinus, make a face uplift to enter the sinus and reach the cellular from below. The different, what I feel as a neurosurgeon, I like the midline approach. I like to be on the nasal crest or the sphenoid crest. This is our fixed midline that you will never have a deviation from it. Ostium, they might vary. They're open in one of the chamber. You might end reaching the cavernous sinus from there. So I don't like the ostium as a first landmark. I prefer the midline, the nasal crest, because it's a fixed. And Professor Edlows yesterday, he stated on the importance of orientation of the surgeon during the surgery. Mind you that I've been trained for many years on the transcranial approach microscopically, and I converted to endoscopically, and I find the benefit from each one of them to facilitate the approach for me in a safe way. So this is a few picture. I took it from a video I have recorded, how I do it. There is no sin of using the speculum. And I agree with Professor Ortel. This speculum has never caused a complication itself. And I put it to start with, and I make a small mucosal flap, the septal flap. Then I displace the septum to the other side. And then from the left nostril, I pass a dissector directly under my vision, and I see, and I enlarge it a little bit with the dissector, and this is a tract for me to put the endoscope, and you see here the tip of the endoscope there, and this is the visualization what I see. Then from that part on, I can take the speculum out, and I drill the anterior wall of the sphenoid sinus, and I take my tumor out, and this is endoscopic picture after removing tumor. You see the herniation of the diaphragm. This is the value of the endoscopy. You can see the medial wall of the cavernous sinus, if there is any residual or not. In that case, there was none. So this is a simple approach, straightforward. You don't lose orientation, and you achieve what you want without damaging the integrity of the nasal cavity, which is, for me, is an important part in the procedure. Navigation has been mentioned by my colleague, Dr. Stefan, is of great value. Now, this is the instrument is essential, especially when it comes to recurrence disease as well. You should not proceed without having it, and if you have the intention to go into cavernous sinus. This is a simple case of acute loss of vision involved in a car accident because he lost his vision while he's driving, came to the emergency in the middle of the night. We took him with a pituitary apoplexy, and the day after, he recovered completely. That case was an old case of mine, was done through unilateral nostril with the straightforward transcranial surgery, no place, we did indeed the endoscope on that one. And you see the complete resection. The tumor paved the way, and it's a very soft and pouchal necrotic was taken out. If you know what you are doing, and I still believe the presentation of Professor Atul, I cherish this presentation, and I heard it several times, and I always learn from it, and I applied his concept with the dural margin. There is a technique for the giant tumor that I like to use. I call it the clock technique. You start from the base, then the lateral, keep the central, and then you move slowly up to 12 o'clock, because when you take the lower part, you initiate a dead space that you give a chance for this tumor to herniate down in a good number of cases. These are cases done by endoscopic assisted transcranial surgery when they go high up. And I know from studying that imaging very well that there is a partial apoplexy on the top of that lesion. So I know margins. So I did this one first with the microscope. I decompressed the lower part of the tumor, and then I put the endoscope to retrieve any residual from top when I entered that necrotic material and the cystic component of it. This is a case that first it was shunted somewhere else because she did develop hydrocephalus. This I could not achieve to remove it in one stage, and I said, okay, let me do it in 2 stages, and we did it in 2 stages, but both they were transferred. Amazing, sometimes these tumors come down, but not all the time during the procedure. Sometimes it takes a couple of days to retrieve some of them. We have one case where we get an apoplexy of the upper part, leaving the upper part, and we have to take that patient acutely to do a craniotomy to remove the rest of the tumor. This case, this is a post-op. This is another case. It's very tempting to call it for an extended approach. It's going retrocellular. This case, I didn't do an extended approach. I did an endoscopic assisted approach. So I used my technique, going to the cellular, decompress the cellular, take the tumor from it, decompress the posterior part of the tumor, and doing Valsalva maneuver. That tumor came out toward me, and we put the endoscope, we retrieve a small residual on the top, and that was the post-operative with complete resection. This is 5 years follow-up. The publication on giant pituitary tumor, you see endoscopic result was published by the Pittsburgh group. The total resection, I have to tell you, not very impressive. 66% near total resection. But I think over the years that results has been increased to the 80%. But visual improvement in the endocrine function were superior to the purely microscopic surgery. But there is no clear comparison between a pure solo endoscopic and endoscopic assisted microsurgery. And this is where my critique for most of the publication, they go for one side to the others. They compare endoscopy to craniotomy. We know this is not comparable because this is much better in the outcome. Factor limited the degree of resection, and I agree with their points. Multilobulated configuration, especially if it's of the dura, and the extension to the middle fossa that was statistically significant. In Cushing disease, do we need the endoscope? I thought first when I was doing the Cushing disease, I said, I don't need it. In 25% to 30%, it was a negative MRI. And we made use of a study with the PET scan that in a 25% negative MRI, we did have a positive scan, and we were guided like this case with the PET scan solely. And this is a case we'd like to have the endoscope when it comes to the medial wall of the cavernous sinus or the diaphragmatic deposit of the lesion, or behind the cella, behind the stalk of the pituitary. These are the areas that might be missed by the microscope, and the endoscope will be of value. But again, going back to the Cushing disease, these results, fantastic results, published, I think, more than 15 years ago by Professor Edlows on a microadenoma, he achieved 85%. At the result today, by the pure endoscope, by endoscope assisted, we are not higher than this percentage for Cushing on the first surgery. Of course, a redo surgery is always the result less, but again, although he popularized the endoscopy, but I have to tell his results still superior. And yesterday, Dr. Falbush showed his result in the different functional adenomas that he achieved up to 80 and 90% now in his publication in 2020. And using minimally invasive endoscopic assisted procedure. Kovacs, one of the famous pituitary scientists, he published the studies they have done many years ago, 2012, and there was no significant difference in the remission rate between the two techniques, whether it's an endoscopic or just microscopic. This is another case. This is a case of craniopharyngioma, and we felt there was a cystic component, minimum calcification, and this is where I have no hesitancy with the line of direction of that lesion to go transfemoral as a first-line approach and take it out. And you see, this is a post-operative. We did the binostride, the endoscopic assisted, but without drilling the tubercle, without doing the drilling in the plano-sphenoidal. It was a purely transfemoral surgery with use of the endoscope, a 30-degree high up to retrieve the superior part for an residual, but it came down very easily, and this is the post-operative. This has been done in 2014. This is now 6 years craniopharyngioma without recurrence, without any adjuvant treatment. So the list of indication for the endoscopic assisted or extended approach has increased, not only pituitary adenoma, radical clefts, craniopharyngiomas, but I put the point, avoid craniopharyngiomas with heavily calcified in the midline, and I will show cases. Arachnoid epidermoid cyst, and of course now chordoma, and some cases of diaphragmatic meningioma. And I think the classification done by Professor Al-Mufti and Professor Nismat in Pamir is of value, because if it's type C, it's originated from the inferior leaf of the diaphragma celli, and this is where I feel this meningioma can be taken out through transfer. Above that, I still am a believer that if you want to go for resection, gross resection, with margin to achieve a good Simpson grading, then you should go from above. And anything else, I think it's a big craniotomy from below with adding complication of CSF leak and with less remersion for a long period of time. This is a case, I thought first is a chordoma. Behind the clivus, you see it on this picture. We entered there and we did the standard we do for transfemoral surgery, and I drill a little bit of the clivus and I opened then eventually the dorsum of the sphenoid sinus, and it was a meningioma, but it was soft. And before that we did the imaging with the MRA. It shows that the basal artery displaced laterally, so I thought midline I'm free, and that's what I did. And this is the post resection. You see the lower series. This is a post-op with expansion of the brainstem. See how what's happened to the brainstem here and the way the basilar artery. It was a marvelous procedure that convinced me that this approach can replace a complex approach from the far lateral approach or whatever you want, or combined approach. If you have a purely midline and you have a good arachnoid membrane, arachnoid spaces around the lesion. So we did it through the binostril extended approach. This is a case of chordoma. I see the basal artery on the T2 weighted images. It's deceiving. It was displaced to one side. If you take to this picture, this is where the basal artery, and you see what's happened to the brainstem. If you go through the sphenoid sinus, you have only tumor in front of you. Then I said, why I should subject the patient for a complex approach? Because eventually we are guided by the two Torello canals. This is our lateral margin, but this tumor might be taken almost closely out, the globular tumor, and we see here an invasion of the sinus. There is a small lump that it gave me a hint of it. So we went transfemoidally and we took this tumor by the endoscopic, not the extended, the endoscopic by translabral approach, and that tumor was completely removed and patient was referred. Even we have no hint of a tumor on these images, but we know chordoma, whatever you do, you should complement it with the adjuvant tumor with the proton beam surgery. I go now to the assisted endoscopic surgery in craniotomy. Of course, we has improvised and tailored the approach, the terional approach, to make it a minimally invasive small flap. Just like this one was taken in a small flap, trans-eyebrow approach. And this is a case, you see here, there's a small tubercular cell, almost anterior clinoid on the left side, presented with the visual loss on the decreased vision on the left side. I elected to go from the contralateral side, and it gave me the chance not to manipulate the optic nerve on that side. And that's what I did, the terional approach. This is the right optic, this is the lesion capsule, I'm moving it, I remove the tumor, and I see here the carotid optic nerve here is not very clear. Then I put the endoscope. This is where the value of the endoscope to complement your resection and to evaluate the thoroughness of your resection. First, see the perforator, you see them very nicely, so you won't damage them, even here coming from the carotid, the posterior communicating. You see the third nerve as well, posterior clinoid, optic nerve. And then by tilting the scope a little bit, you see the pituitary stalk and the diaphragma celli. And at the edge, I saw a small lump. This is a tumor residual that I could take it and achieve a gross complete resection of this tumor. This is pre and post, as it's not touched. This is a case of craniopharyngioma, a recurrent craniopharyngioma, operated first in 2015 in France, in Paris, transfemoral surgery. I was surprised, but they did evacuation. I think the cyst referred him to radiosurgery. He received radiosurgery there, and then, or stereotactic radiotherapy. 2 years later, he got his recurrence. They attempted again transfemoral, empty cyst, and they came with the severe visual loss last year, 2019, 2020, around before the corona time. And he arrived here with the severe visual loss, and you see the amount of calcification, see the amount of recurrence. So we decided to go for MABA. A midline, heavily calcified craniopharyngioma, I feel this is not a good indication to safely to go from below and achieve a good resection. So we went and put in, punctured the cyst from here, took the prechiasmatic components, saw the carotid. He was not clear the pituitary stalk. And here there is a lesion heavily calcified in the opticocarotid. This part, you see, when I removed it, it was so attached to the posterior cerebral and the superior cerebellar artery. This is the basal artery. And you see any pulling on this one, you will cause a catastrophic hemorrhage intracranially. And we could dissect this calcification, remove it out. We put the endoscope, prechiasmatic looks fine. And the lateral part, when they tilt the scope, we see the calcification under the pituitary scope, that we could dissect it, maintaining the stalk integrity, because this one was not infiltrating the stalk, but below the stalk. And this is pre and this is post resection. We have applied that concept, the joint venture with the microscope, even for retro sigmoid approach to the petroclival area. And I will show you this is, we applied the previously published paper from Majid Sami of the suprameatal approach. And rather than to do a combined approach, we added the endoscope to go below the tentorium to up, using the 30-degree and retrieve any residual tumor. I'll show you this case. This case was planned first for combined approach, but when I saw the venous system here, I thought there won't be any treatment dura to go pre-sigmoid. So we elected to go purely from suprameatal approach, resected this tumor with the help of endoscope, taking the upper part, and you see pre and post. This is immediate post-op in the brain suite, pre and post. We have applied this one in epidermoid as well, with the great results. So in general, I like to give these two slides as a final message. The classification of neurosurgical strategy, we all under the authoritative approach. We learn when we are a resident from the masters, visited the master, and this is the approach. You were trained 7 years to do sitting position. You cannot go and leave and you do lateral position. It takes you a while to make an adaptive approach to see others, how they are doing, and you take whatever is convenient in your hand with the time span of your experience to make an adaptive approach. And of course, some, they are smart enough to make innovative approach and they come with the new approaches. The other things, there is an inherent bias in neurosurgical training. You are trained and doing only purely endoscopic, and if you talk about anything else, you will be hammered and kept quiet in your department. The span of experience, surgeon preference, cost and logistic. You see, endoscope costs $30,000, a microscope costs $1 million or whatever. And for people for less developed countries, they immediately will engage using the endoscope. And of course, company, this is industrial driven practice. Practice trend like the Chanel bags. The lady see the other lady with the Chanel bag on the shoulder. She'd like to have a Chanel bags. So don't be driven by the peer pressure, but make your own selection. These approaches are made to be thought about, learned, and to adapt in your practice when you can, what you can do safely forget a little bit about your ego and put patients as a front line. I thank you very much for your audience and for your invitation.
Thank you, Imad, for this nice presentation, showing your experience to add microsurgery and endoscopy, which is very reasonable in my opinion. So we are a little bit over time, but I think we should have a little bit of discussion. If Chandra and Moody agrees. So the first talk was from Atul about these giant pituitary cases, which we never see in Germany. And he stated that the diaphragm is the most resistant membrane in the body. So the experience what I have in Germany is not the same, because I have seen much smaller tumor, and the tumor has a supradiaphragma extension through the hiatus, and sometimes by perforation. And I have seen tumors which are going into the third ventricle. So obviously the German diaphragma is less resistant than in India. But my question is, when you have a tumor which is large and you resect endonasally, but you cannot get the tumor completely out of a third ventricle or so, what I have experienced in 3 cases is that we had to come in the night because there was a hemorrhage of the residual, and then we made an emergency resection. So the question is, should we go for this tumor remnant immediately? How frequent is this hemorrhage if you have a significant remnant in the, for example, in the third ventricle?
Henry, so Germans are different and Indians are different. This is, but tumors are not different, my dear friend. Tumors are tumors. And like fingerprints, all tumors are different, we know. But what is important is to identify one tumor from the other. And it is very crucial and critical for during surgery. As regards the bleeding in the residual tumor, you see, if you can resect, if you can kill the tiger completely, it is all right. But if you pull 1 or 2 hair of the tiger, it is all right. But if you go and break his legs, he will jump and break the cage completely. So either kill him or just touch him and come out. You know, you don't put too many instruments in his bum. You understand? You understand, Henry?
Sure.
Either remove it or leave it. If you have to remove it, do a radical resection. And do quite a radical resection. And if you leave, you know, if the tumor, you leave quite a significant tumor, chances of bleeding in residual tumor is quite high. And fatal postoperative hemorrhage is quite a clinical entity. So that is what I have a feeling. I didn't hear your question clearly, Henry, that third ventricle thing.
Yeah, when you make an endonasal resection, because you think the tumor will come down, but it's not coming down, you cannot resect it, would you go immediately for transcranial surgery? Yeah, Imad has also mentioned it. What is your opinion?
You see, tumors, pituitary tumors are not firm like meningiomas or calcified, or, you know, it is very rare that tumors will not come out. Like some tumors treated with cabergoline, some prolactinomas treated with cabergoline become hard and firm. Otherwise, these tumors are soft. They are necrotic. Majority are cystic. They just, you know, they are waiting for you to touch them and they come down to your feet. It is extremely rarely that they will not be able to, you know, amenable to suction or little bit radical aggressive removal. I have never seen, Henry, any tumor, pituitary tumor, which is firm and will not come down. This is my honest answer to your question.
That's interesting. Imad, what do you think?
Yes, I think Atul talking the language of Kenya. He's talking about tigers and safari and interesting. But you see, we learn always from the last experience. And that's what's happened to all of us. You got one infarction or apoplexy and you say, oh, I will never do that again. And I'll go and go complete and I do the needed to be done from the beginning. But these are the exceptions. And in my practice over 35 years, I think I have 2 cases that with apoplexy for the giant tumor that we have to leave a little bit of it unnoticed, especially in the older practice where we didn't put the endoscope to see the residual. But in cases where you put the 30-degree scope and you see residual, you still try to tease, but sometimes it's difficult. You don't want to damage something beyond that you are not seeing. And this is why you have to have a close observation, and this is the value of the immediate post-op imaging, because many people, they don't do the imaging and they wait a couple of days, but that time, there is where the time of complication can occur. And I have discussed this one, I think, with my colleague from Salt Lake, Bill. He has a similar situation. Now he started talking about going craniotomy to tackle them earlier, as you said. But this is my opinion. This is the incident, as you said, how frequent is not that frequent.
Henry, on the other hand, I will like to clarify my statement. Don't misunderstand my statement that I have been able to radically remove all these tumors and some of these tumors are huge and go here and there. But the aim has to be, you see, aim has to be radical resection. You fail and you create complication, you have death, you have mortality following surgery. In giant pituitary tumors, this can happen. But low aim, you keep an aim of radical resection. You may not succeed, but the aim should always be radical resection. And also one thing I will tell you, you see, even Imad talked about extending your exposure. You see, if you know that the diaphragm celli and pituitary anterior wall dura is continuous, you will be surprised that to remove the planum sphenoidal and tuberculum celli is not necessary. Even in mega pituitary tumors, you can just make a smallish incision on the anterior wall of the sella and start remove, which is more often much bigger than normal, and start debulking the tumor, debulking. There is no need to remove planum sphenoidal. In extreme rare situation, I remove planum sphenoidal. So basically what we have to learn is learn the art of demolishing the tumor, learn the art of breaking the tumor, and learn the art of operating in a bloody field without coagulation, continuous coagulation and things like that. That is my strategy.
Okay, Engelbert?
Atul, I admire always your talks and also your philosophies. You know that we had long discussions on that. I would suggest to include classification 5, which is either the Atul size or the lion size. And for all those things, I congratulate you for the walk. I have different thoughts about the dura and the special dumbbell situations in the supradiaphragmatic, the supracavernous extensions, because this is super narrow things, tumor growth. And that's also the answer to Henry. If you have a dumbbell situation like these, that's the probability that there is a swelling and a hemorrhagic transformation of the tumor. And in these cases, I immediately go from the OR to the CT or MRI to see whether the tumor changed in its attitude. If there is hemorrhagic changes, I think it's better to go to the OR again and remove the situation, either transsphenoidally or subfrontal.
Yeah, I agree. We had this case with hemorrhage and we made an endoscopic transventricular resection from the third ventricle, and we released the hydrocephalus because this patient became symptomatic because of occlusive hydrocephalus because of the hemorrhage. And then it was that. So I will do it immediately when I see I cannot take it out. I bring him to the imaging, what Imad said, immediately. And if I see there is a residual in the third ventricle which might obstruct the CSF pathways, I would go again completely. Okay, where Imad, one
comment on NOSP comment. I have to tell in my practice, the two cases I have, they were not dumbbell adenoma. They were giant adenoma, like the one I showed. So, and I don't know how is your practice, Henry or Atul? Did you see hemorrhage in a dumbbell or on the giant one?
It was dumbbell.
The problem in the suprasellar large tumors or giant tumors, I think depends a little bit with the technique. The suggestion of Jules Hardy and others in that time, they said debulk the tumor and wait 3 months, and the tumor comes down to the sellar area, and then it's possible to do it transsphenoidally. This may be because the radicality of removal in the sellar and perisellar dura is not that radical as we do that with the endoscopic theory. There is still blood supply of the tumor in the macroscopic area, and there is hardly tumor blood supply of the either dumbbell tumor situation or in large suprasellar. And I think that's a danger. If you cut the supply of the residual tumor, that will is swelling and bleeding.
Yeah.
Henry, can I make a comment?
Yeah.
Okay.
Henry, can I make a comment here?
Yes.
Ashish, I think last comment before we close, and maybe Ashish Pathak hasn't spoken if he wants to make a comment, but I think we should close the session soon.
Yeah.
We have so many open questions, Chandra.
Yes, I'm
no,
so
actually,
we will continue after the next session as well. Many of these things would probably come into that. Please go ahead.
Ashish, go ahead. Yeah.
Yeah, thank you. I think Henry has an important point. There is a small subset of, so we have identified them around 3 to 5% of patients of these giant adenomas who actually bleed, and they bleed the same night. And my policy is that if it is huge in the direct line of the endoscope, you can take them out in the first go. But the problem is when they go and invaginate into the hypothalamus, or they are going not subfrontal, they are going much more anterior towards third ventricle. They are the ones in the first instance, even if you do an extended approach, or it's difficult to remove them completely and to trace the thing. And they're not as soft. Believe me, they're not as soft. The problem is the tumors which are going into the invaginating into the hypothalamus, the one vertical straight, they are soft. The ones which are going lateral, and especially when we're going beyond the cavernous sinus, they are not soft at all, and they have to be broken. Sometimes they have to be properly cut, and those are the ones that bleed. So our dictum is, in such cases, we keep them as the first case in the morning, and prepare for a transcranial. If we think we can see from 30 or 45 degree scope, the tumor is still there, we can cure it, and still it's not coming down, we go for a craniotomy in the same stage, or we shift to a CT and maybe in a 4 hours time, and then again we don't keep a second case there, and then maybe. But if the tumor is too hard, it's too hypo-intense on T2, these tumors don't bleed, and you can keep them, and you can plan a transcranial excision later. But yes, bleeding is a problem.
Okay, thank you. Then I want to conclude the session like our chief has requested. I thank all the speakers, all the chairpersons, and the participants.
Thank you, Professor Schroeder. We move rapidly to our next session. The chairpersons for this session are Professor Dr. Turel, who needs no introduction to this audience. He's a senior consultant in the Department of Neurosurgery at the Bombay Hospital. He's joined by Dr. Nishit Shah, who is one of our pillars at the Bombay Hospital skull-base endoscopic surgery sphere. Dr. Dilip Panikar, who is a professor and head of Department of Neurosurgery at the Amrita Institute of Medical Sciences, Kochi. And Dr. Rajan Shah, who is the director and head of the Department of Neurosurgery at the Nanavati Hospital. May I request Dr. Nishit Shah to please introduce our first speaker.
You have to unmute yourself, Nishit. Unmute.
Can you hear me now?
Yeah.
Okay, sorry, I think that didn't work. So a warm welcome to all our panelists, Roman, Andre, and Domenico. An absolute privilege for me to introduce my friend Roman Bosniak, who's from Slovenia. Having operated with Roman, I know that he's a fantastic surgeon with an amazing knowledge of the sella and the carotid artery. So we really look forward to listening to you, Roman, and learning a little bit more. Over to you.
Good day, everybody. I hope you hear me well.
Yes.
You see my presentation?
Yes.
Yes. Here on the first slide, I would like to acknowledge the great help of my assistants. These are current and former residents who were very cool in these stressful moments during management of carotid artery injury. So I'm having nothing to disclose. I'm coming from this part of Europe, and I work here in this institution, University Center of Ljubljana, with 2,200 beds and 1,300 doctors and 11 operating rooms. So this is a nice relaxing picture from our Bled Lake with an island. And ICA injury is a serious, potentially fatal situation, depends on cross flow and also experience of the surgeon. The incidence is about less than 1%, but it can be up to 3.8. And the least was 0.12% reported this year from Burdenko Institute in Moscow. Other authors report similar numbers around 0.5% or less. The situations that injury happens, there are in basic two. It is during dural exposure and dura incision, or during cavernous sinus dura incision and exploration and ICA manipulation. So types of injuries, there are many. One of the worst is laceration. It comes from tearing. I would say this is a major injury. Then it could be side cut, puncture or stop, perforator rupture or avulsion, and the one I'm afraid very much from the drill bit abrasion. And of course, sometimes the material you are working with is not good, and this is atherosclerotic carotid, which walls can rupture on very easy manipulation. So immediate after stopping the bleeding with any material you have, in the literature they are talking about muscle patch or any other gauze or anything else matters to stop it. Then you run to angiography and you see you have your bleeding control, or there is still extravasation of contrast. Or it may happen nothing, the patient is okay because he's having a sufficient cross, or there is infarction developed in hours, or infarction in progress developing in hours or days, or in days it can also develop to pseudoaneurysm. So first we can make a general identification of dangerous situations or actions we are doing. One is drilling over the carotid protuberance or paraclaviculum. Then during dural cuts for sella or cavernous sinus explosion, manipulation inside the compartments when we must take care of the ICA trunk and perforators. And we, of course, must take into account also individual tortuosity, curvature of the eyes and medial displacement, and especially be care in more lateral biopsy. Sometimes adenoma consistency is surprising. It could be aspirable or it could be hard and fibrous after hemorrhage. And there is also variations of bony and vascular structures or normal. Here I would mention trigeminal artery. So if we first do a short look to the anatomy, it is inside the cavernous sinus, there are two large perforators, inferolateral trunk and meningo-hypophyseal trunk. These are nicely seen here through the Parkinson triangle, and here is meningo-hypophyseal, here lateral trunk. So lateral trunk is really lateral on the other side of carotid, but meningo-hypophyseal is more tricky. Is posterodorsal medial, and it could be. This is the endoscopic view, also showing inferolateral trunk going over sixth nerve. And here again, look through the Parkinson triangle, and we see that these trunks are quite strong. And if they are ruptured, no problem, because you have a stump. With a proper coagulation, you can coagulate the stump, but if there is avulsion, this is a more problem. There are some anatomical causes for ICA injury. One is a thick bone seen in acromegaly. So there is a lot of drilling and also using the punch, which can be harmful. Then one of the major problems is midline orientation. So it's good to use navigation. Then posterior wall of sphenoid has no true bony markers, no OCR, there is asymmetry of sphenoid and so on. There can be dehiscent bone over anterior loop, no cell present, or you may have no or partial sinus pneumatization. The Kissick carotids are classic danger, and also we must take care of medial curvature of horizontal part of cavernous ICA. Dural redo surgeries for residues or residuals, they are especially dangerous. Sometimes dural floor of sella have venous lakes, which make us problems with hemostasis. And as I mentioned, adenoma consistency is a problem sometimes, but sometimes we do not find adenoma, but another tumor, for instance, chordoma. So the exposure of the sellar floor and lateral walls of sphenoid sinus are crucial. More we have exposed, more we see, less are blind angles. So here you can see in the right lower slide that for medialization of the anterior loop of carotid, we have to cut the proximal dural ring. So carotid can be manipulated quite well, quite much. So here is some features from my technique. So I was checking with rectangular to see where is the dural ring, and then I cut horizontal with angular scissors, and then along the lateral side of carotid to open the lateral cavernous sinus. Then we do blunt dislocation and aspiration by K-hole aspirator, and then we completely freed the anterior loop. So there is no tumor behind it. It is completely mobilized, as we can see here with the instrument that we are around. So some technical issues are also important for carotid injury. So some surgeons, they use Ross drill. I'm using this exceptionally only if there is a strong vomer to do the maximal anterior sphenoidotomy. I use diamond drill for eggshelling. So I do eggshell drilling over carotid. I avoid punching if possible. I start dural incision in the safe spot. It is at 5 o'clock down where there is inferior compartment and carotid is far away. I use rectangular probe first and then followed by rectangular scissors. And I also do the biopsy strictly in the midline. And when I enter intradurally in the sella or into cavernous sinus, I'm using blunt instruments as much as possible, practically always. If I don't see something, I do curve aspirator and I treat ICA gently, progressively, and of course, bluntly. So there are new dangers now. It is the theory of cutting away the medial wall in functional adenomas, and also, as I showed before, dural ring cut for anterior loop mobilization. So a large exposure of the carotid is always good to have a proximal control at paraclival carotid to put a clip there. And of course, you must have a bayonet, special clip applicator and clips prepared, and you use Doppler navigation and so on. And also one I found is that you have to change drill size. This is an instance case when you drill the middle clinoid, which may be something very strong. And when you drill with too big, you can easily do abrasion of the carotid. So when ICA injury happens and it is bleeding is temporarily stopped by any case, if possible, you try to stop it in a surgical way in situ. You can only use clips, but otherwise you did not do definitive stop and control of bleeding. Then you have the endovascular management by flow diverter stent and coils. And in case of insufficient cross circulation, then you need to do some low flow or high flow bypasses, 1 or 2. So in next, I will show the short case series. So the first case come in 2013. This was during the drilling around the middle clinoid. And I think that there was a McConnell artery, which is a artery in the dura over the carotid. So somehow I drilled it off and it started bleeding and there was no stump. And we did solution with putting back tiny bony lamella and make gluing with histoacryl glue. So there was no problems, no toxicity, and the patient is still alive thereafter with no problem, no aneurysm, nothing. So second case is this two-stage acromegalic with bilateral paracellular STH adenoma going supradiaphragmally and extradiaphragmally. So this is the first part. In the first stage, we removed or thinking to remove everything except in the left cavernous sinus because we were afraid of potential bilateral oculomotor palsy. So here you can see that in the beginning that here is still the cavernous sinus full. And at the second surgery, we saw that we prepared to remove the adenoma from the other cavernous sinus, and you also see some extra diaphragma. So second surgery, we were doing this, and during this surgery, it happened that I cut the paraclival carotid with the aspirator. So you can see the tip of aspirator which was drilled, and I didn't notice it was becoming sharp, and here it becomes bleeding. So I simply finished this surgery, doing first simple coagulation and continued removing from cavernous sinus the tumor. But on the 8th day, the first CT scan was done immediately and it was normal, but the 8th day epistaxis appeared and the second one on the 12th day. So despite normal CTA on the first operative day, we repeated CTA on the 12th day and we saw the pseudoaneurysm formation, and this aneurysm was then coiled. and the patient is okay, but he's taking these anti-aggregate pills. So case 3 become a year and a half ago. I noticed this middle positioning of the carotid, so I make large exposure, also one protuberance. I make a middle cut to have orientation, but I didn't notice how much I was coming lateral. When I was doing the biopsy, this tumor was more fibrotic. I felt some resistance, and despite this was a biopsy central, this was huge bleeding. I put several clips, and this is one which helped me to see something, and I saw that I missed. So it looks like some avulsion of perforator, and I didn't dare to remove this clip, which was doing a good wrinkle of carotid, and I put a second one, and this was somehow successful, and the artery was patent and the patient without any deficits. So this is applicator I was having in my instrument set for 5 years, but of course we were not using it from 2013 to 2019. And when using it after 5 years, the nurse didn't know how to use it because it is having a double click system. So one click, first click holds the clip, the second release. So they gave me the classical Yasher-Gill applicator, and I had several problems because it was too big and I had to rotate it when inserting the clip, and I was afraid that I will produce more problems. Then it was difficult without a dedicated instrument. So here is the picture of the histological of the perforator and part of its wall. And the last case is pre-last case, case 4 is from the January this year. This is a huge adenoma. So I was using this instrument, macro dissector, which I was never using, and I was checking the lateral recessus on the left side, and somehow, because I was doing already some hollowing, I was catching the tip on the lateral side of the paraclavial carotid, which was extended, and it was coming much in front, and I didn't expect it. And by pulling down this sector in the mass of the tumor, I blindly cut the avulsed the perforator. So it was a huge bleeding, as you can see. But there was some nipple bleeding out, and I really tried several strategies. So I put one cottonade tamponade here, make a control, and I continued removing the surgery. Then I coming back, trying to put here the lateral classical clip, it didn't go. Then I put 2 clips doing trapping for 12 minutes. And finally, I was putting one proximal clip, and I put here a cottonoid to make some leverage, and I rotated this clip and also the carotid medially. And so this spot come more up, and I could put this, I said, duck clip. So here we can see this in action. So I relocate clip more anteriorly, and somehow I got the control and I was satisfied. And of course, the artery become completely patent. So the patient on the next day, he was with no problems, no visual disturbance, despite I had to put a cottonoid in the lateral part of the cavernous sinus. He survived easily 12 minutes of temporary trapping clipping with 2 clips and 8 minutes of proximal clipping with 1 clip. So here is the CTA and 3D reconstruction. These were done 4 days ago. We are showing our duct clip positioning. and the patient is already transferred to endocrinology to further testing. The last case is from November this year, so we were expecting this tumor is adenoma. We also noticed this medial position of the horizontal part of the intracavernous carotid on the right side. We identified this medial positioning, but here we see the pituitary, which opened laterally like a door, and the tumor behind it was not adenoma, it was chordoma. So during this preparation of carotid, I moved lateral to the middle of the sella, and I didn't expect it. There is some perforator. It was too early for medial hypophyseal trunk or something else, and it comes to bleeding. And I was trying to put several times the clip, but it was very sleepy, and I tried. You can see here that I tried to catch as small part of the wall as possible to control this, but it was slippery. Then I was trying this kind of clip, didn't go. And finally, I was repeating this and somehow succeeded doing this clipperage, and it holds. So I was just then checking the position, and it was really holding parallel to carotid. So for conclusion, I would say there are several preventive measures. The case should be individually studied for bony variations, asymmetry, and also for vascular. Of course, we do not have MRI which would show us perforators in advance, but one of the most important is to have a clear idea of the midline. So I'm doing midline conformation rarely with navigation, which I'm always having with me, but I try to identify both optocarotid recessus, left and right, both protuberances, both paraclival columns. So this is important markers, and the very floor of the sella between columns. When I'm drilling over carotid, I do this eggshell drilling and I change bit size. So when I'm doing dural incision, I'm doing it never in the crisscross fashion, but always as lateral as possible to open the sella like a leaflet in the book. And so I have no blind angles. When I'm inside compartment, I'm doing gentle blunt movement, and I expect perforators. I learned this, and I study configuration very well, do 3D simulation, everything. And when I'm doing biopsy, I'm doing this with not bite through, but I'm just holding it softly so it could sweep out if necessary and if there is some resistance. It's important to have instruments like this bayonet shaft clip aspirator to be prepared, and also the personnel should be trained. And I also have now not single-use keyhole aspirator, but we are having two aspirators, one for extradural and one for intradural work, and the second one for intradural, it is never used together with a drill. And I have prepared double aspiration. So navigation Doppler ICG can also help to identify bony and neurovascular structures during the surgery. So I would thank you for your attention.
May I request Professor Turel to introduce our next speaker?
Good evening. So we now have the next speaker, Domenico Solari. Hi, Domenico. Welcome to this beautiful neuroendocrine symposium. Domenico, as you know, is a brilliant endoscopic neurosurgeon from Italy, from Napoli, and his great interests naturally are in pituitary and skull-based surgery, especially endoscopic, and he's also a great neuroanatomist. We'd like to hear from him something on his complication avoidance, a subject which is very close to my heart as well. Complication avoidance in transnasal surgery, which focus particularly on CSF leak, which is really the bugbear of endoscopic neurosurgery. Domenico, the floor is yours.
Thank you, Professor Turel. Thank you to everyone for having me here. I'll start immediately with my presentation. Okay, did you see that? I guess so. Okay, so really that's an honor for me on behalf of all the School of Napoli led by Professor Cappabianca to bring our opinion on such a good topic as complication. So the first rule, as Professor Turel also stated right now, it is like to avoid a complication. So along your path that starts outside the nose and leads you to the cellular area or to the supracellular area, intradural pathology or whatever, you have to define your steps in order to avoid and properly manage the complication that for sure will happen at a certain point of your activity. So this is a brief reminder. This is the Vesuvio, that's the Mount of Napoli, and this is the Holy Emperor Frederick II, to whom is dedicated our university, and this is Diego Armando Maradona, the third deity in our city. The opportunity of using the endoscope to reach first the pituitary and then the skull base had started in Napoli in 1997. So from that moment, each of us, like starting from Professor Cappabianca, has dedicated like quite a lot of exercise, like to know the anatomy and to refine his knowledge. And these are three fundamental heroes that has led our path. This is Dr. Chabischer, Dr. Prats, and Professor Castelnuovo that is in ENT. So first of all, like no one does take care eventually as neurosurgeon, and then thereafter we beg pardon to our colleague, the ENT surgeons, the lateral wall of the nasal cavities, because you know, like we saw beautiful images with the endoscope, a lot of quality of improving, of extending our corridor, but still there is these structures that eventually may get you in trouble. The first thing is that they can cause like disruption of several of these structures, may lead like a lower quality of life to the patient, and this is not like a good thing to know. And then thereafter, a lot of these structures are in direct contact with the skull base and with delicate areas, vessels and nerves that cross around this path. So our trick is always stay oriented. Like you see on the left side, you will know a bidimensional image of what you are knowing as seen by the microscopic technique, and you have to orient yourself, recognize on your lateral aspect in each nostrils the turbinates, have the septum from midnight to 6 p.m., and then you will identify all the landmarks. And then consider really the sphenoid chamber, like the sphenoid sinus chamber, as a wide chamber that has the access point to all the skull base, at least like the ventral skull base that is seen via this door that open and can be opened with the endoscope. Backing into the nose to avoid the first complication, or maybe like the most threatening, the CSF leakage after the reconstruction, it is to recognize these arteries above the roof of the choana, and these tiny arteries that comes from internal maxillary artery are the feeders of the chunk of mucosa that stays on the septum, and the two Argentinian guys define it as the Haddad Bassagastegi nasoseptal flap, and it is very helpful to spare, like, and to preserve for the reconstruction at the end of the procedure. This is a close anatomical details of what we are talking about. This is a specimen that you see here, this is a plastination cadaver coming from the lab of Vienna, and you can recognize like the maxillary artery back here, the sphenopalatine fossa, nasal posterior artery and posterior nasal arteries around the Vidian canal. And you see here, like there's a vignette defining the path of both of them. And it is very interesting that in the initial part of our career, we did not take care of that, because here we are using like sharp instruments, trying to trim off the mucosa that eventually hinders the route as neurosurgeon. So maybe it is a scattered video, but you see here, like it will start nice bleeding from one of these vessels. So it might significate that your pedicle, it is not anymore valid. So the bleeding, the support, the feeders to the septum, it is ruined, and eventually it will leave like a vascularized flap for reconstruction. So when you're opening your corridor, the first trick is like to get the proper space. This is a vignette coming from Danny Malkasian, the co-worker of Dr. Dan Kelly in Los Angeles, and it defines properly two tricks, like Dr. Bosniak already showed, like which are the dangerous corners in this situation. But you have to prepare, like before seeing the sella and the paracellular specs with cavernous sinus and internal carotid artery, you have to define enough wide window on the anterior face of the sphenoid sinus. You have to have a quadrangular space that gets you a direct view from one carotid to another, from the chiasm to the level of the floor of the sphenoid sinus. Then you see here, like this is a case from Dr. Kelly. If you do not have this window, what you can see is like only like a medial corridor, and then you stay safe because you will not encounter eventually the internal carotid arteries, but you will not solve the problem, especially if it is a secreting tumor. And then, like with the endoscope, like many brilliant views and anatomical point of view have been opened, because you can get close to the target, you can recognize properly which are the tissues that are involved in your surgery. And this is a nice, again, cadaveric image showing the inferior epiphyseal arteries and the complex of vessels that irrorates the chiasm from below. And this is only a reminder, because this is another friend of your surgery. This is our endocrinologist, Professor Colau. And when you are dissecting the tumor, you have to be prepared, like to have patience and treat the pituitary gland with care, with a really extreme care, because otherwise, like the failures of the epiphyseal hypothalamic function is quite sure. And then Dr. Bosniak already showed like perfectly which are the management of carotid that is here, only like a warning, and it is written in red because Dr. Kelly would have said like the big red, like don't forget like that although you can move, you have to have the proper skills to manage and to extend your corridor within the cavernous sinus, to malolateralize the carotid, or eventually like to open the sellar floor. And this is also another video that shows not only like the known complication, but the unexpected complication. That was a GH secreting patient. So we were opening the floor and we were using the drill at the level of the floor of the sphenoid sinus. This is the septum here. This is binostrial four hands corridor, and we stopped the procedure. We went back to the angiographic and it was treated by the endovascular approach, and then the surgery started again. But today, like very nice presentation has been made about like the extension of the corridor in suprasellar and intradural, intrarachnoidal corridor. So we had this opinion when we entered above the sella. We renamed this structure. It is not anymore known for us as the tuberculum stele, but still it is like the same anatomical structures. We call a suprasellar notch because it is an intent, and this can define your corridor, because this inside the sphenoid sinus can be your landmark and can be defined as trick to avoid the complication along the route. First of all, you have a flat angle in between the planum sphenoidale and the floor of the sella. You see here, like you have enough space to place a reconstruction. You do not have the tumor extending forward it, so you will not extend your opening above the planum. So you will have a more convenient angle to remove the tumor via the nose. You do not have to push the tip of the nose. You will not have conflict with your coworker. And this is another trick, like we are not this is a first opening that we were made on the right side of the image, but this is the key point that has been marked in green, and this is what we call the medial osteoid. That is the continuation of the dural distal ring that encircles the carotid artery as soon as it exits the cavernous sinus, and it goes to join the diaphragma cell. we had like this interesting topic before with Dr. Goel. Do you see here, like if you cut this point up to this point, you will have to cut the diaphragm cell. So you are pretty sure to be in the supracellular space and to have the intra-arachnoidal corridor. And this is only like to remind that you can extend laterally to this point as long as you respect the optic canal, and above the optic canal you can extend, especially in meningioma surgery, according to the definition of the attachment of the dura. But what is important for us, this is the math process that it is behind. Like it is nothing anymore left to the case. You can calculate your working area and surgical freedom. It is not like 100% of determination of what you can do at the level of the skull base, but at least can give you like the an esteem, like a precise esteem of what which is the freedom of moving your instruments with all the structures that blocks the way. And this is, you see here, like the projection of the quadrangular space in which the tips of your instruments, it can be moved like with the endoscope in a fixed position. Thereafter, if you are doing this surgery, mind where is the chiasm. You have to be prepared, and you have to know that eventually a meningioma like this will push posterior and above the chiasm, so you will encounter like the lesion first, the vessels on both sides, like the pituitary gland here, the diaphragma cell, the arteries entering the canals, but you will have the chiasm and pituitary stalk back in the field after you remove it from the arachnoid, the lesion. This is another condition. This has been caused by a craniopharyngioma, recurrent craniopharyngioma. Here you see the cystic component, like the third ventricle that has been breached. And you see here the solid component, and you can recognize here below this red spot, the optic chiasm. So when you're coming from the nose, you will not have this wide opening here, because if you open above the chiasm, you will have a sort of via lamina terminalis corridor. So you have to respect the main length and the trajectory of the endonasal corridor. So you will have to use the subchiasmatic corridor and enter also the third ventricle via this corridor. The same it is if you have like the pituitary stalk, especially of course in craniopharyngioma surgery. It might be that craniopharyngioma will be like a capsule of your tumor, or you have to dissect on both sides to go in the retrocellular space. And as in other surgeries, as neurosurgical procedures, be aware that tiny vessels are live. So when you are using your endoscopic and nasal corridor, it is a bimanual dissection technique, and it stays attached and it stays like strictly adherent to the rules of microscopic microsurgical dissection. Both ends, the surgeon should use both ends and dissect with suction, blunt and sharp instruments from the arachnoid and from the tiny vessels. Again, I will not stop on this corridor. Dr. Bosniak already shown like which are the consequences of touching the carotid. I only use these pictures to know that there are several spaces that can lead you to follow the tumor in the paramedian skull base, but you have to be prepared like to recognize. Otherwise, you get a disaster. You will cut the main oculomotor nerves and also the nerves of sensitivity led by the trigeminal nerve. And this is only a reminder that comes from the group of Pittsburgh, this one from the group of Danny Prevedello, about the definition of the carotid and its relation as compared like to the angiogram and to the specimen inside the carotid, inside the cavernous sinus. And finally, when applied to clinical space, this is a new from Dr. Fernandez Miranda, and this is a very nice definition. It's like the Michko redefinition of the NOSP classification. It adds that little more that can help you very much, because pituitary tumor, it seems like a very simple when it is inside the cella, when the gland protects all that is beyond the cellular space, but sometimes you need to follow the tumor and recognize major structure. So if you enters in between these windows, you have to redefine the cavernous sinus as inferior compartment, posterior compartment, superior compartment. Why? Because if the tumor has entered in between the two horizontal tracts of the internal carotid artery, then that space, it is widely open. So maybe, like if you are lucky that the tumor breached the medial wall of the cavernous sinus, you will follow only with suction tube and you will enter the cavernous sinus without mobilization of carotid. You enter with blunt instruments and you can eventually avoid that complication. And again, like we discussed this topic before, that was a recurrent tumor that has breached the diaphragma cell, and this is what we call an intracerebral adenoma, because there is no cleavage plane, there is not the gland that helps you in having like a further layer to cover the diaphragma cell. We went inside this surgery, you see the reopening, like to preserve this pedicle of mucosa. This is the dissection of the tumor. I'll go. You see here, like by manual technique, it was not anymore a soft tumor. You see, it requires sharp dissection with these true cut instruments. This is the Doppler probe to identify the carotid on both sides. This is what it remains of the dura at the level of the planus sphenoidale. And then at the end, this is the arachnoid. That is the chiasm above. We are following the tumor. We are dissecting with blunt maneuver, and at a certain point, do you remember that part that was crossing over the internal carotid artery? And you see here, like that's the vessel, this is the posterior space, you have the chiasm here, and we did not see anything at this point. Like this is the stalk, this is the chiasm here, the stalk is here. We did not see anything here. There is no bleed, so we proceed with the reconstruction, and we were like surprised, not that much, like to see this kind of situation. Of course, this is an intracerebral hemorrhage of the residual tumor that was a giant intracerebral intrarachnoid tumor. So that was the cause of this infarction, and the patient has plegia, and that has been already described. So we completely forgot. We did not have like immediate CT because the patient was not referring any complication perioperatively, but the day after he woke up with this situation. So this is a bad outcome, although the tumor was removed. So aside these that are general complications that can be avoided, like there is the most threatened of all of us. This is the focus on my presentation, the CSF leakage. This is not anymore like 20 years ago. Like the rate are getting down, like lots of techniques have been described, lots of surgery has been like described from many schools. And we like to show this again, like sentence coming from our friend Dan Kelly, that is the real Achilles heel, because every time like that you enter like a special surgery as removal of a skull-based tumor, at the end you will be tired. So eventually that part of the procedure will be performed like with not the adequate focus, with not the adequate effort. So the first trick that we have to learn is that skull-based reconstruction is the same as tumor removal for endoscopic endonasal surgery, because like there are these pitfalls. You cannot suture the dura. You will have the pulsation against you because the CSF mass is above you, and the patient it will stand 2 days after, the day after will stand. So if he stands, eventually the intracranial pressure will low, but still like all the pressure of brain pulsation and vessel will stay on your defect and the reconstruction of your defect. And on the other side, especially for the transtuberculum transplanum corridor, you will have these other pitfalls, this anatomical, we can say, like variation that can lead you to a very, very cumbersome process of reconstruction. Why? Because we showed before, like it is essential to extend wide up to the carotid and optic nerves. So it will be irregular in shape, and there are the neurovascular suction. And eventually, if you're performing craniopharyngioma or adenoma, you will have the third ventricle opening. So you have CSF leak, and you have to remind also this one. Like if you go for the first attempt, you will have a high chance of performing like a nice surgery, next surgery and have your defect fixed again and no more complication. But if you go for the second time and you leave something behind, then it will be disaster, and you will not get like the resolvement of the complication. And then of course, like there is meningitis and there is hypertensive pneumoencephalus that can happen. So Dr. Schwartz, for instance, like defined this path of pneumoencephalus like to eventually quantify the risk of CSF, because maybe there is CSF and you do not recognize because the patient has tampons, there is Surgicel, there is fibrin glue that leaves like the tiny vessels not coming off the nose. So eventually do a CT scan and recognize this path. It will be very helpful. And then, of course, when you are aiming to reconstruct a patient after the removal of the tumor, you have to be a neurosurgeon. So you have to deal with all the components that you have opened before. You have to fix the intradural compartment, you have to close the osteodural defect, and then you have to manage the extradural, the sphenoid sinus. And again, this is a paradigm that's still alive and is still there. It defines the entity of the fistula and eventually suggests what is the most appropriate technique to fix the skull base reconstruction. And when you are speaking about the extended, you have to consider the grade 3 of entity of CSF, because you have arachnoid opening and you have third ventricle opening. It is very nice, contrary-wise, if you are dealing with an intracellular, intrasupercellular adenoma that does not breach the diaphragm. So you have only to have this in mind, like you have to protect the cistern. If you eventually have like the falling of the cistern inside the cellular area, you have to pack the cella. If you had like a maneuver that exposed both media walls of cavernous sinus, and eventually you can close the cella if you breach the diaphragm. And this is our experience. We started in 2007 with this technique that we call it Gramma, and Dr. Schwartz group call it the gasket seal. It is a multi-layer technique. You will have a semi-solid buttress wedged in between the bone and the dura. And then inside, we placed like a substitute that was at that time bovine pericardium. You see here, that was a large opening. You see the chiasm that is pushed behind. That was a meningioma, the vessel. So we started here with filling the dead space with fibrin glue. You see the borders of the osteodural breach. So we start with fibrin glue. Thereafter, we wedge like a layer of substitute, and then like this, that was the mucoperichondrium of the middle turbinate, and then there was a semi-solid buttress. And you see here this pressure, and that's the tricky. Here there are like the optic canals, the optic nerves, and the carotid artery. So in this case, it was a flat positioning, so we could have performed that. We covered it, and then we used also these tiny pieces of flap. It was not a regular flap, and then we fill again the sphenoid sinus with fibrin glue and with Surgicel. That was again like the middle turbinate. In 2007, we were using like the removal of both middle turbinate. But this was surpassed by this other technique that we adopted, because we aimed to remove that semi-solid buttress, because we felt that there was something that with the pressure like moved, and that gets the leakage. So we tried this technique, like we call it the sandwich or the button technique, as Dr. James Evans would have said. Like it is made of multi-layer, again, like autologous fat stitched with the dural layer, and then like farther layers, like placed in between the different spaces, like the intradural, extradural space. But all of these are like inside the cranial space, because they do not come in the sphenoid sinus, that again, it is filled with different material. You see here, like it is only a piece. That's a tiny stitch that has been placed outside, of course. This is the breach. It is not as huge as the other one. That was a meningioma. This is a craniopharyngioma. We are working like, again, with 4 hands binocular technique, a tiny piece of fibrin glue, like to fix that excess of fat that has been pushed away by this construct. And then we start to fix the fat inside, 1 layer inside, And then this other layer, the outer layer, it is wedged in between the dura of the patient and the bone. You see here, like with this tiny anglet curette, it is pushed. And again, like in the most dangerous area, the inferior corners, and then above here, you see here, that's the optic canal, so we cannot push a semi-solid buttress. And this is a farther piece at the level of the flanus sphenoidale. And then nowadays, like starting 2019, we adopt this technique. No more material, heterologous material. We have only autologous material. We start with fat periumbilical flap that we use as a corkscrew. It goes in and out the breech, and then like we use the anesthesiologists like to have like first Trendelenburg and then anti-T position to have the corkscrew that is pulled forth and back as a yo-yo, and it is stuck with fibrin glue. So thereafter we cover it with a proper Haddad Bassagastegi flap, and then we fix with a tiny layer of fibrin glue. And then the sphenoid, it is filled with a Surgicel, and that's it. No tampons, no CSF leak. So what we can suggest, like first of starting the surgery, you have to develop the appropriate knowledge, and you have to train. Like this extended procedure, still, this is not clear that can be done like in selected centers that need like the proper learning curve, at least 50, 70 cases per year before starting these procedures. You have to select your case, because not any pituitary or craniopharyngioma or meningioma can be performed only because it is in the sellar or parasellar areas via the endoscopic endonasal corridor. And then you have to have your roadmap with the identification of your dangerous landmarks, and you have to have your team prepared to manage that complication at any time and with the proper time, because each of the complications that we've shown has been like detected along the path, so in the different phases of the procedures. And then you have to plan the procedure as you were having that complication and have an alternative planning. And this is only a reminder that not every time like you need to be a great surgeon. Sometimes you need like to be only like more focused on what you're doing. Thank you.
I would request Dr. Rajan Shah to please introduce the next speaker.
It is my privilege to introduce and invite Professor Andre Grontes for his lecture. He is no stranger to this august audience, and it's always a pleasure to hear him and learn from him. Professor Andre, stage is yours.
Thank you very much for the kind introduction, and also both Chandrasekhar and Moody for organizing this and inviting me. Let's see, let's share that. Yeah, I think sharing is succeeded. Well, and Chandrasekhar and Moody asked me to reflect on the past and future of, no, sorry, that's not something I have to be there. Yes, this is the first slide, not starting at the end. And it was on their suggestion that I also use this for Janus, a Roman god, the Roman god that is always depicted with two heads. And in the Roman mythology, it's the god of the dualities, so life and death, beginning, end, but also past and future. And therefore also he is the namesake of this month, January, which is the first month of the year. And also this is why we have the New Year's Day tradition of reflecting on the previous year and looking ahead to the upcoming year. And I think we all did this very extensively because of the pandemic, that this past year, we were happy that it was gone, and we hope that it will improve. So I will first look to the past, and it could be very extensive to talk about the history of endoscopy, but it is endoscopic skull base surgery. Nevertheless, I want to show you that we really have to give credit to this man, Harold Hopkins, who was a professor of optical engineering at the University of Reading in UK, who developed the so-called coherent fiber optics. The non-coherents were already very well known. They were light cables, but he made it coherent so that also images could be transmitted through these fibers from one end to the other. And that made fiber endoscopy, fiber optic endoscopy possible, for example, in gastroenterology and bronchoscopy and so on. But this same man had 5 years later a patent on the rod lens endoscope, so an improvement of the conventional glass lens endoscopes. So these two developments were absolutely essential. And Gérard Guillot in France, and he has been mentioned yesterday already by several, he was the first to use such an endoscope for pituitary surgery in 1963. And also he used a video system for the endoscopic procedure, while others with endoscopes were just looking through the optics at one end. And he was not only a very gifted neurosurgeon, he was also a very well-known and gifted organ player. But when we now go to endoscopic skull-base surgery, it started with the pituitary surgery, and actually it was in Nancy in France, Roger Jankowski, who published this small thing about how I do it on endoscopic pituitary tumor surgery. And that was the first time that it was really applied. I described the technique that we used from the early 90s in this book that was published in 1995, and also had a whole series of, let's say, endoscopic skull-base surgery in that time. And more or less the same time it was Haedong Yo, who I also met at a course in Washington at that time. He worked in Allegheny Hospital in Pittsburgh together with Ricardo Carrao as ENT surgeon. And they really pushed this forward and developed a proper technique for endoscopic pituitary surgery. Well, and here in Europe, it was certainly the Naples group with Enrico De Vitis and then his successor, Paolo Capabianca. And now the tradition is continued by the younger generation. And we just heard Domenico speaking, and also Luigi Cavallo. They continue the endoscopic skull-base tradition in Naples. Also in Italy, it was Giorgio Frank who showed us that the cavernous sinus can be approached from the nose much better actually than from a transcranial approach. And that together with Ernesto Pasquini, the ENT surgeon, he developed this technique. But I think the one who really deserves the credit for the expanded and really extensive endonasal skull-base surgery was Amin Kassam. At the time when he worked at the UPMC in Pittsburgh, he developed this idea in approaches in the sagittal plane and coronal plane at different levels of endoscopic skull-base surgery. And when he left Pittsburgh, this was continued by his team with Paul Gardner and Carl Snyderman as ENT surgeon and Juan Fernandez Miranda, who now left to California. But they continued to do that. And it spread throughout the world. In the Americas, you had Danny Prevedello and Theo Schwartz and Fred Gentile, we have heard them. And in Sao Paulo was Aldo Stam, who really did a lot of work in endoscopic skull-base surgery. In Europe, we have heard all these people already here as lecturers, mainly in Germany, Slovenia, and the group in Vienna. And also in Australasia, so in India, we know that Chandrasekhar and together with the ENT surgeon Nishit Shah. But in Australia, it is Charlie Teo who still does a lot of extensive endoscopic skull-base surgery. Nevertheless, there was an important development somewhat later, and it has been mentioned here, and that was by these two ENT surgeons who described the vascularized pedicle nasoseptal flap. And that really changed the game, because before that, and actually personally, I was very reluctant in the early start of this millennium to do it anymore because of the high rate of CSF leakage and multiple surgeries afterwards. So I was more or less frustrated about it. And then this really changed. It has not reduced it completely, but certainly this made it possible to do these extensive surgeries. So that means at this time we have these kinds of levels of difficult surgeries. So from easy and simple sinonasal surgery and the regular pituitary surgery up to the really highest level of middle and posterior fossa coronal planes, up to the occipital condyle, into the posterior fossa or CP angle. So this is a different area, but this is now the current state. And then they ask me, so what will the future bring? That's difficult to tell. I think that what will not change in the future is probably the goals of skull-base surgery. The goals are still the same. It has been the goals 50 years ago, and the goals 25 years ago, and will be the goals of our endeavors. And that is that we want to maintain, or even if possible, improve the quality of life of our patients. And we hope that we can recover or at least improve any existing neurological deficit. We want to ensure that the tumor, and of course that the symptoms that it causes, will not come back as long as possible. And ideally, we hope it is gone forever. And by doing this all, we always have to keep in mind that we do no harm. And that was the talk by Roman and also by Domenico on that we have to ensure that we will not have complications. So how will we achieve that? I think that I just picked a few things here that I think 3D endoscopy has not been a topic until now, but I think it will come. Some instruments that will go by that. The 3D endoscopy is already around for 15 years, but it is developing slowly, and it is apparently capable of reducing the learning curve for people starting this technique. Personally, I have still difficulties that we need these big glasses to have the 3D effect. But there are developments that this will not be needed anymore with 3D screens and so on. So this could be, this is an ongoing thing. And also we need more instruments for dissection and tumor removal and hemostasis, and they need to be more versatile. So I think that even simple instruments that seems like only a grasping is also capable of coagulating, and it is much more flexible. It can turn in any direction, and it can be miniaturized, and therefore these are the developments that we need to enhance what we are doing inside. Because I think still that the instrument development was lacking behind. And then, yeah, well, artificial intelligence and robotics are on the thrive, and we know that the Da Vinci robot is very common now in urology, gynecology, general surgery, simply not capable for any use in neurosurgery. But there are now surgical robots and developments for neurosurgery. And these are just the things that where we want to consider having a robot. On the left side is the precise, and on the right side, that is a development of my own university, the RoboSculpt, who really can do skull-based drilling and skull-based procedures. Until now still in the lab, but these are developments. So I think they can work already in a very tiny field, and then the robot will be more than just a holder system. It will really participate in the surgical procedure itself. And then when we have malignancies or remnants that we leave there, we can have these collagens that have integrated cesium. So it is a localized, surgically targeted brachytherapy that we can apply so that we can deal with that during the closure and actually already immediately treat any remnant. And then, yes, I think the reconstruction, that's still one of the drawbacks that we have. There are some nice developments of, for example, injectable and malleable, like a foam, so-called thermoresponsive and fiber reinforced calcium phosphate or calcium sulfate, but they are rather stick. And the last development is the adipose tissue-derived stromal cell. So this would be, and this can regenerate the bone, and then we really can close the defect that we have made in a better way than, and of course we still need that flap over it. So these are some of the developments. And this will be the developments for the younger generations. And I want to tell them this quote from Mark Twain, that 20 years from now, you will be more disappointed by the things you didn't do than the ones you did do. So really explore and dream and discover and go ahead. We need this for the future. And this is about future. The best way to predict it is to invent it yourself. And I started with the Roman god of Janus, and I show you some picture of my hometown, a town that was founded by the Romans over 2,000 years ago. And I thank you for your attention.
Okay. Yes.
A few comments maybe before we go to the next session. Dilip, Keki.
So I think, yes, I think what you have seen actually in the earlier part of this session were problems of complications and mainly anatomical knowledge of anatomy, understanding that in every surgery there is some kind of a key point, whereas in cellular and paracellular surgery, it is the internal carotid artery. And therefore, you have to acquire the knowledge, both from your anatomical dissection as well as from your radiological viewing preoperative as to where the ICA lies and what are the various anatomical nuances of both the tumor as well as of the ICA. And so actually fear, most of the people are afraid of ICA, rightly so, but fear comes from ignorance. And therefore, this ignorance has to be overcome by knowledge of anatomy. And so study the location, as Roman very nicely said, the location, the characteristics of both the ICA as well as of the tumor. And of course, should some kind of a hole develop, then you must first control yourself before you control the bleeding. And then you put some materials to some muscle or some fibrin or some collagen or fibrin glue or whatever you have, flow seal to stop it. And then you must always expect, if you are expecting the eventuality of a carotid rupture, then you should have your endovascular team ready at hand to be able to bail you out from this. So the problems are, of course, in this kind of a situation particularly, the problems are of space, very narrow space. The problem is of instrumentation. You may not get the right instruments at the right time, and therefore you need to prepare yourself with those instruments. And therefore, the readiness is so important. By way of navigation, you must have your navigation, and you must have your correct instruments and the correct nursing staff. So all this has to be anticipated. I always say complications occur when you don't anticipate them or you don't prepare for yourself. So anticipate and prepare your staff, talk to your team, talk to your assistant, talk to your nurses of what things you will be requiring. don't think every case is unique. Every case is different. There are no two cases which are identical. And you need to do some homework if you really want to avoid complications. And yes, I think Solari, Domenico, also talked about staying oriented and maintaining maximum exposure right from the beginning so that you have a good amount of space to work with. Domenico's talked about CSF leak as a complication. And I can only say, as I always say for any intracranial skull-based surgery, plan your closure before you plan your exposure. And then the 3 Fs, which you talked about, fat, flap, and fast. So if there are questions, then of course, I'm very willing to put them before the floor.
Professor Turel, may I just say one thing?
Yes.
Sure. I would like to congratulate with Andre because, like, for the sake of time, like,
Do we have any questions, Domenico? Do we have any questions for before you go to Andre?
Okay.
Are there any questions for Roman or for you, for that matter?
I have one question regarding skull-base reconstruction. Domenico mentions the gasket seal technique, and he showed a case of a craniopharyngioma or a suprasellar approach. And I'm very conservative to use that because I know some people who had a visual deterioration when you push in a rigid piece in the close vicinity to the optic nerves. So I would strongly advise against that. And even Ted Schwartz mentioned a patient who was deteriorating in vision. So I would prefer a FAT and a flap.
Totally agree. We left that because we just retained at that time that can be like a much resistant support, but it was a failure. We did not experience, by fortune, we did not experience any deterioration, but we left as soon as we realized that was very, very dangerous.
Yeah, I think it can be used for olfactory groove reconstruction. That is, I think, a nice technique for that. But close to the optic nerves, I think it's not so good. All right, thanks.
Dr. Solari, can I ask you a question about your reconstructions and the prevention of CSF leaks?
Yes.
In recurrent cases, in redo surgery, endonasal surgery, where your nasal mucosa is often scarred and the tissues may not be very healthy, does your pattern or does your plan of reconstruction change?
So it mostly depends if it is a recurrent tumor that we did operate on the first time or we did not. Eventually, you can evaluate if for sure it has been not evaluated by us. You can consider like that there is no pedicle available for doing the flap. So the most thing that you can rely on is the fat. So if you have fat, you can use maybe a little extra amount of fat and then use mucosa or from the floor of the nasal cavity without a pedicle or from the middle turbinate if still there is one over there. Along this year, none of us is an ENT, but we learned from ENT because we really had like this sensation that eventually we could fail like in a snap if we did not mind it before.
Okay.
We never use, for instance, we never use fascia lata. We never use like intra-extracranial flap harvested from the glabella or from the temporalis. But inside the nose, we are prepared to harvest any tiny pieces of mucosa, although it is not pedicle.
Well, I would like to comment about CSF leak repair or prevention. So in fact, we have to reconstruct arachnoid. Arachnoid is the first frontier to the CSF. And I will start doing that if I'm putting to the rest of the arachnoid or over the third ventricle. If opened, I put some tachosil to close and to reconstruct the arachnoid. And I also started spraying autologous fibrin glue made from the patient. So this spray makes artificial temporary arachnoid, and then we put many layers. It doesn't matter if this is 3F, multi-layer or gasket. but the first frontier is the arachnoid we reconstruct. So this is maybe a principles and put some physical support, some physical suspension of this material.
I have to intervene. I think KK, we have to get to the
Just
next session.
one point for the young neurosurgeon, Shekhar,
Yes,
is that there is an immediate post-operative CSF leak. Please do not try any conservative measures like lumbar drain or diamox or whatever. Simply go in straight away and re-explore and seal the leak, because this CSF leak is a sign of danger and sign of death. So please do not wait for the next morning or the next day. Address CSF leaks immediately. It is an emergency. That's what I want to convey.
I think it's an important lesson to understand. And thanks all the speakers and moderators. And we move to the next session. Vikram?
Yeah, we shift gears now and move to our 7th session, which is about craniopharyngiomas. And I have great pleasure to invite Professor Rick Boop as a chairperson, who's the chairman and professor of neurosurgery at the St. Jude's Children's Research Hospital. Professor Vedantam Rajshekhar, who's professor and head.
Well, thank you. Can everyone hear me?
One second. Professor, just a second, Professor. Professor Rajshekhar, who is Chief of Neurosurgery Unit 2 at the CMC Vellore, India. Dr. Sunil Shah, Consultant Neurosurgeon at Bombay Hospital, who unfortunately could not join us right now. And finally, Professor Mishra, who is the Chief of Neurosurgery and the Chief of the Gamma Knife Center at the PD Hinduja Hospital. May I request the chairpersons to briefly introduce the speakers just prior to their talk, please. Thank you. Professor Boop.
Yes, let me share my screen. And I'd like to thank everyone for a very successful meeting and for the opportunity to see all of my old friends whom I haven't seen in months. I'll give you some thoughts on craniopharyngioma in children. And I hope that we're to the point where the discussion about radical resection of all craniopharyngiomas is the only treatment, because that's the way it was when I trained. And I think over time we've learned that that may not always be the best case. So let me start with this case. And this is a patient that we had last month who presented with loss of appetite, sleeping more than usual, and then clinical symptoms of DI, and came in with the MRI that you see here, read as craniopharyngioma. And when she came to clinic, not only did she have poor vision, but she was cachectic, she was lethargic, she almost passed out in the clinic, and we thought, this is not the typical appearance of the children that we see with craniopharyngioma. They present with loss of growth velocity, they present with visual symptoms, they present with headaches, but they don't typically appear acutely ill. And diabetes insipidus is not a common presentation for craniopharyngioma. So with that, we checked germ cell markers, and indeed her beta HCG was elevated, suggesting that this is actually a mixed germ cell tumor, and what was being read as craniopharyngioma is a mature teratoma component of that. So we treated her with a temporary shunt and a round of chemotherapy, after which her beta HCG normalized. And then we took her to surgery and removed the teratoma, as you see here, from a transcallosal approach. So if we had treated this patient with radiation or anything other than surgery for a mature teratoma, it would have not been appropriate. When we think about childhood brain tumors, keep in mind that craniopharyngiomas make up less than 10% of the pediatric brain tumors. And if you think that the average children's hospital sees between 30 and 40 brain tumors a year, that means that most pediatric neurosurgeons will only see 1 or 2 a year. And it begs the question, since nobody can get a lot of experience with craniopharyngiomas at a typical place, whether these children should be referred to specialty centers for care. Nowadays, we have a number of opportunities, treatment options for these patients. And I'll make the point that whenever you've got this many options reported in the literature for a single disease, you can recognize that all of them will work in some instances, but none of them will work all of the time. And nowadays, we would like to tailor the approach to the individual patient and not just say all patients need treated in a single way. And the second point is that craniopharyngiomas need to be treated with curative intent. The next point is that as we move forward, as our technology improves, as we become better surgically, societal expectations for outcome of this disease have become more stringent. And so back in the 70s, we were happy with just mortality and morbidity. Then we went to the Glasgow outcome scale of excellent, good, fair, and poor. But nowadays, our colleagues and our families depend upon us to look at quality of life measures, detailed neurocognitive measures, formal neuroendocrine, neuro-ophthalmology evaluations, and postoperative imaging. So what we know for sure of childhood craniopharyngiomas is that they must be approached with curative intent. Both surgical excision and limited surgery plus radiation work well for most children. The recurrence risk for both of those treatments is about the same. Aggressive surgical procedures and multiple interventions increase the risk of a less functional child. So if we get an incomplete resection of a craniopharyngioma and we decide to observe the child, we know the mean time to progression is 24 months. And if they progress and have to have a second craniotomy and then radiation therapy, the chances of having a functional child after 3 interventions is much less than if we go straight to radiation therapy after an incomplete resection. None of our treatments works perfectly well. Intracystic therapy will be talked more about later. We need long-term follow-up to know what our complication and control rates are. Younger patients don't do as well cognitively. Patients requiring shunts do less well than patients who don't require shunts. And patients with diabetes insipidus tend to have poor quality of life, diabetes insipidus being a measure of hypothalamic dysfunction. And growth hormone just doesn't have effects on growth, but it also has cognitive effects. So replacing growth hormone is important for these children for more than just stature. So let's look at this. Both surgical excision and limited surgery have about the same outcome. And this is a 10-year-old paper by Parsa before he died, which was an analysis of the published literature with over 8,000 patients showing that the long-term outcome of gross total resection and subtotal resection plus focused radiation was about the same. One of the important things to note in this paper is that 23% of these people had subtotal resection, but nothing else done. That means that they were treated with less than curative intent, and it's just a matter of time, particularly in children, before the craniopharyngioma starts to grow back. So I think this is not optimal. And here are the Kaplan-Meier's of subtotal resection and radiation plus gross total resection, overall survival and progression-free survival. What the group commented on is the data seems to support that subtotal resection and focal radiation is a reasonable approach while limiting hypothalamic and hypophyseal morbidity. And that's been our experience. So we approach these patients with the thought of radical resection, but if the tumor is stuck to critical structures or we're going to damage the hypothalamus, then we're quick to back out and consider functional focused radiation instead. More aggressive procedures and multiple procedures increase the risk of a less functional outcome. This is a paper that Tom Merchant published where we stratified all of the procedures that our craniopharyngioma children had had as to invasivity. We had a couple of patients who had incidental craniopharyngiomas that were small. Families were surgically averse, and they were treated with focal radiation without a biopsy. But I don't advocate that, and we only do it in very rare situations. But children with cystic craniopharyngiomas who simply had aspiration or decompression of the cyst followed by focal radiation, moderate invasion, moderately invasive surgery, dissecting tumor away from critical structures, or more extensive procedures. And what we found when we looked at quality of life measures with the families was that the patients who had limited surgery and focused radiation had the best quality of life. Those with extensive surgery, less so, and patients who had multiple procedures had the worst quality of life. So here's a video of a child who came to us, and this was edited by one of my fellows, Chenran Zhang, who's now in Shanghai. But this was an 8-year-old who presented with short stature, and he was found to have this craniopharyngioma. And when you look at it carefully, what we see is that the pituitary gland is normal, the stalk is normal. So this is actually a craniopharyngioma of the third ventricle. And so to approach it pterionally or transsphenoidally is probably going to violate his pituitary stalk or his gland and produce an endocrinopathy. So our approach to this tumor was a transcallosal approach to the third ventricle. And just to get there quickly, here's the interhemispheric dissection, opening of the corpus callosum. And once we're in the ventricle, the key to opening the door to the third ventricle is coagulation of the septal vein, which patients tolerate quite well. We've done it in dozens of cases with no complication, leaving the thalamostriate and internal cerebral veins attached, but then we can open the choroidal fissure and have access to the whole third ventricle. Here's massa intermedia, mammillary bodies, and then tumor coming into view. Typically, we'll put gel foam in the back of the third ventricle to keep blood out of the aqueduct, and then start dissecting the tumor as you see here, mobilizing the tumor, and eventually, in this case, getting this component free. And once we get this component out, we're able to bring in the ultrasonic aspirator, debulk the wet keratin. And in this case, there was a large piece of calcium anteriorly that we were able to mobilize and deliver out. And that gave us access to the anterior component of the tumor. I think it's going to come loose here. And then the rest of the tumor came out quite nicely. And this child had transient diabetes insipidus postoperatively that lasted about a month and then resolved. But so far, other than his growth hormone, his vision and endocrine status have remained normal. And he's 3 or 4 years out now with no evidence of recurrence, so should be cured. Here's another case that we approached with curative intent. This is a 5-year-old child. Again, let me get on to the next case here. With this larger craniopharyngioma, but in this case, he has a postfixed chiasm. And as you can see here, the tumor is extending up between the frontal lobes. So this is an anterior interhemispheric approach. You see how we use tenting stitches to pull the sagittal sinus over so that we have direct visualization of the interhemispheric fissure with no need for fixed retractors. We can then dissect out the vessels down to the tumor capsule coming into view here. And then at the back side of the tumor capsule, we've aspirated some to get better exposure. We see the chiasm stuck to the back of the capsule and the optic nerves coming around the sides, and carefully dissecting the chiasm loose. And this is a Spetzler microdissector, which is a nice modified curette with sharp edges that is good for dissection. Then further mobilization of this capsule. Anterior cerebrals come into view just under there, and then moving the capsule away from the visual apparatus, dissecting it out, eventually opening the capsule and debulking tumor from within. Standard microsurgical dissection until we get down to the cella. And in this case, once we got into the cella, the tumor appeared to invade the left cavernous sinus. We could see pulsations here, and the stealth told us we were right on the carotid artery there. So we debulked what we could out of the cella, but postoperative imaging showed some persistent tumor involving the upper clivus and the left cavernous sinus. So we gave some focal proton beam to that area, and he's done fine in long-term follow-up. So what we know is that younger children tend to do more poorly than older children who have more interventions. In this graph, here are the children who've had a single operation and focal radiation versus those who had multiple operations and then radiation. And I will point out that as our radiation technology improves, as we become more focal, we're now to the point with proton beam where we treat 5 millimeters surrounding the tumor, and we update our treatment algorithm weekly with MRI, so that if we have cysts that change size one way or the other, we update our conscription so that they're included in the high dose treatment plan. But here are preliminary results from our current protocol, in which we've enrolled 100 children for protons compared to our previous children with photons, and demonstrated at least equal progression-free survival and diminished complications, radiation necrosis, radiation-induced vasculopathy, moya, or stroke is now well under 1% in the proton beam era. And what we have found is that whereas we would typically see some step off of IQ with 3D conformal photon radiation with proton beam, their IQ scores are remaining stable, at least out to the 36-month median follow-up that we have at this point. In terms of intracystic therapy, most of the children will respond quite well to either particle emitters, bleomycin, or interferon in the short run. But when we look at long-term follow-up, there's a fairly significant progression of tumor recurrence over time when we get out to 5 and 10 years. So it's great for a temporizing measure. The long-term cure rate is not nearly as good. As I had mentioned, younger patients don't do as well. Here's IQ in children less than 7 versus older than 7, significantly different for the younger children. Here's attentional deficits in children with craniopharyngiomas, which is the most common problem we see when they get to school age, and we don't see that with our other brain tumors. And then when we look at children who have diabetes insipidus, again, those who have diabetes insipidus don't do as well as the ones who don't have DI. And we use that as a surrogate for hypothalamic dysfunction. And again, if you add DI to a younger child, then you're going to have a significantly less good cognitive outcome than you would in the older children. Hydrocephalus in the short run doesn't predict IQ, but the need for a shunt, the children who have shunts cognitively are not as good as the ones who don't have shunts. And you see here, on average, about a 10-point IQ difference between the children without shunts and the children with shunts for both females and males. And this is detailed neurocognitive testing that we've done. As would be expected, the females typically have a better IQ than the males as a general group. Growth hormone, somatic and cognitive side effects. When we look at our series of children who had growth hormone replacement versus those who had no replacement, we actually had better progression-free survival in the children on growth hormone. So the argument that giving growth hormone to children who have radiated residual of tumor is probably not correct. Those children had a better outcome than the children who had no growth hormone. And we do think that it has significant cognitive implications as well. So this is a review of our first 97 children treated with 3D conformal radiation. And what we saw is over a 10-year period of time, we had 18 recurrences. If we look at gross total resection, the recurrence rate is somewhere between 15 and 20% in most series. But of those 18 patients who recurred, they've subsequently undergone 38 procedures over the next 10 years. So initially, if they had a cystic recurrence, we would take out the cyst and leave the radiated solid portion of the tumor. Nowadays, if we have a child who has a recurrence after radiation, I think that that is an indication for radical resection, and those children need to try to have all of the tumor removed if possible. Just a comment on targeted therapies. This is a developing field that has tremendous implications for children and adults with craniopharyngioma. And this is just a picture of a child with a hypothalamic chiasmatic glioma demonstrating a very significant response to a BRAF inhibitor, vemurafenib. And a number of children that we've had with high-grade gliomas who demonstrated progressive involution of high-grade tumors, glioblastomas, anaplastic astrocytomas, to entrectinib. How durable that'll be is yet to be seen, but the children seem to be responding to some of these targeted therapies. And we all are familiar with this paper looking at BRAF inhibitors for papillary craniopharyngiomas and subsequent reports showing dramatic responses in a fairly short time of adult papillary craniopharyngiomas to BRAF inhibitors, as you can see here. So trials are ongoing with BRAF inhibitors for the adult. And this is a new paper from the NYU group, Jeff Wissoff's group, showing a single case report of using MEK inhibitors for Wnt craniopharyngiomas, which is what the adamantinomatous pediatric craniopharyngiomas are, and demonstrating a response of the tumor to a Wnt inhibitor, binimetinib. So I'll stop there in the interest of time. And once again, congratulations on a successful symposium, and thank you for the opportunity to present.
Thank you, Dr. Abboub. The next speaker is Dr. Henry Schroeder, who will talk on surgery for craniopharyngiomas in adults. Dr. Schroeder?
Yeah, can you see the screen?
Not yet.
Yes.
No?
Yes.
The slides, yeah, your slides are come on now. Yeah.
Yeah, now it's good?
Yeah, it's good.
Okay, again, I want to thank Chandra Moody for his invitation to present here at this nice symposium. I learned a lot already. It's really interesting. And my topic is craniopharyngiomas in adults. I think it's a little bit different policies than compared to the pediatric population, because in the craniopharyngiomas in Germany, at least, the tendency to be less aggressive is very obvious. And there is a German study where the pediatricians look after the patients and not the neurosurgeon, who is more optimistic, obviously. And they found what Rick already mentioned. If you are too aggressive in the surgery, you really create a very bad outcome for these children regarding cognitive function and also in the quality of life in general. So the main question always when you see a craniopharyngioma is, should we do a gross total resection? And for adults, my aim is usually to get a gross total resection, but not in any case. So if you see on the pre-op MR image, you have this hyperintensity around the lesion, and the patient is presenting already with hypothalamic signs, then you have to be a little bit careful with the resection, because you can really have a devastating outcome for these patients. The next question is, if you can resect the tumor completely because there is no hypothalamic invasion, should we sacrifice the stalk? And there are a lot of opinion about that. And what is the best approach? Is it a transcranial approach or is it an endonasal approach? Initially, we always did these surgeries via a pterional approach or an interhemispheric approach, translamina terminalis. You see, this is a chiasm, it's a prefix chiasm. So at that time, we made a pterional approach, but when you look to the tumor, you don't see it very well because all tumor is covered by the optic chiasm. You see the carotid and you have just the retrocarotid window to see the tumor. And then you have a lot of manipulations to the carotid and also to the optic apparatus, which may cause visual problems because of the surgical approach. That's why for most craniopharyngiomas, what I see, they are usually midline tumors, not the A2 type of tumor, what we see in India. So what we see is usually midline tumor. So the endonasal approach is for me the best option usually. It has the advantage that you very early can identify the pituitary stalk. And if you see it early, I think you have the best chance to preserve it. And you see also the vessels of the superior hypophyseal artery, which is supplying the chiasm and the infundibulum. And then of course you have a good chance to preserve these, which is of utmost importance for the visual outcome. If we talk about stalk sacrifice or not, we have to take into consideration, even if you can preserve the stalk anatomically, you can have a stalk which is not working. And then you have not very good pituitary outcome, and you have a tumor remnant because you did not cut the stalk. And Ted Schwartz made an evaluation, and they found that in 50% of the cases where they could preserve the stalk, it was not working. So this should be considered when you think about stalk sacrifice. And Oldfield, because of this observation, recommended that he choose to have a complete tumor resection with sacrifice of the stalk, because he said you can obviously replace all the pituitary hormones very well, and the patient can have a good quality of life as long as the hypothalamus is working well. But of course, we have to consider different situations. I was in Bangladesh to make a life surgery course, and there was a young boy, and if I would resect the tumor completely, he certainly had a pan-hypopit function. And then they said, please don't do it because this patient will die. He will be sent home to his rural area. The parents have no money to buy all the medications. So this should also take into account. And there was a nice paper I found from a Japanese group, and they've had a very aggressive surgery with removal of the floor of the third ventricle, including the stalk. But they found in 50% of these patients to have an improved DI. And that is an observation what I had never made. When I cut the stalk, the patients have lifelong DI, which requires substitution. There's a nice classification of tumors where you consider an endonasal approach from Kassam. They divided the tumor into a pre-infundibular tumor, which is located in front of the stalk, an intra or transinfundibular tumor, which is arising within the stalk, and then the retroinfundibular tumor, which is arising behind the stalk. And the pre-infundibular craniopharyngioma, I think, is the best tumor where you can preserve the stalk in a functional way. When you open the dura, you see this is a gland, it's the optic nerve left, right, and you see only the arachnoid, you see the tumor and branches of the superior hypophyseal artery. This is one case. She has really a visual problem, 0.1 and 0.2 visual acuity and bitemporal hemenopsia. And you see this small supracellular lesion. You see this is a chiasm, it's a prefix chiasm, but we have enough space between chiasm and the gland to approach the tumor. This was my first craniopharyngioma, which I did endonasally. So dura is already open, left optic nerve, right optic nerve. You see the gland here, and we have here the tumor. So we incise the tumor, debulking with ultrasonic aspiration, and then we dissect along the good visible plane. And with the HD camera, we have such a nice view that we really can differentiate very nicely between the normal structures and the tumor. This is the stalk on this side, and you see this paper-thin structure. This is not a tumor capsule, but this is the infundibulum. This is hypothalamus and can be divided and dissected from the tumor. And after enough debulking, we can remove the lesion. And we have almost no manipulation of the optic apparatus. We can preserve all the vessels which are supplying the chiasm. And you see any transcranial approach would cause more damage compared to the endonasal approach. That's why in these cases, I think this is the ideal approach to have a gross total resection. And you see already after 14 days, he had a normalization of the visual field. And it's now 11 years after surgery and we have no recurrence. So Fred Gentili always said you cannot get a gross total resection of a craniopharyngioma if you not sacrifice the stalk, but I think it's not true. There are cases where you have a good plane between the tumor and the stalk and you can resect it with a good functional outcome and also with avoidance of recurrence. And this is a patient 11 years after surgery, did not get obese. He needs substitution because of partial insufficiency. He has 10 milligrams hydrocortisone a day and thyroxine and testosterone replacement. But I think it's a good outcome in these kind of tumor. Transinfundibular craniopharyngiomas are worse because they arise within the stalk and the chance to preserve the function of the stalk is less. You see as one example, this is all stalk and all stalk is dilated because the tumor is within the stalk. And what we do then, we open lateral, we debulk the tumor, we release the cystic content. And then if you look here, you see this is not capsule of the tumor. This is all normal stalk. If you take this out, of course, the stalk will not work properly. An example is a 29-year-old male patient. He complained of headache, fatigue, and his girlfriend was not happy with his performance. And she sent him to the doctor and they found a partial pituitary insufficiency. And then you see this midline tumor. And as Rick mentioned before, I initially thought it might be a germinoma type of tumor, but all the markers were negative. And you see the lateral extension of this tumor. It is filling all third ventricle. What approach is the best? Transcallosal I was thinking about, but you see it's so wide you have to open the corpus callosum and you will not reach this tumor here. And this tumor is really only in the midline. The longitudinal axis is that way. So I always try to approach a tumor in the longitudinal axis. And in this special patient, you see there is an ideal condition because this is a gland and this is a chiasm here. So we have plenty of space, almost 1 centimeter between chiasm and the gland. This is unusual, but this was fortunate. So we said we make an endonasal approach. So we already have opened the dura. You see again, this is a gland. This is a carotid here, clonal carotid, optic nerve, optic nerve. We have to open the arachnoid first. We identify the stalk very early and you see this is all stalk. This is not tumor capsule. This is just all infundibulum. And then of course we have to find the right plane to dissect. Ultrasonic aspiration is very helpful because this tumor was soft and we could debulk it. And now you see this is all the stalk. This is infundibulum. And the tumor was very sticky to the third ventricle. So we had to use a 45-degree endoscope and with a bimanual traction, counter traction technique, we resect the tumor because you see there's a gliotic plane. It's not the white hypothalamic tissue, what you see when you enter the hypothalamus. And that's why I dared to dissect the tumor. And it's of course very important that you not simply pull on the tumor, but you have really to dissect around. And only if you have dissect completely around the tumor, then you should remove it. So not take a big forceps and just pull, but you have to dissect. And this is all done with a 45-degree endoscope. I had to bend my suction because I could not reach it with a normal one. And then after I have a gross total, or I have complete the section of the tumor, I can take the tumor out. You see after resection, this is the roof of the third ventricle. This is a posterior commissure, and this is a fornix and the foramen of Monroe. And then we used FAT, the flap, fibrin glue, and the lumbar drain. And 10 days after surgery, you see the gross total resection. I preserved the stalk, but the stalk was not working. So the patient needs complete replacement therapy. We tried to avoid desmopressin or minurine, and then he had to drink 8 liters a day. So it was not a good idea. But I think with substitution therapy is he is happy, and the girlfriend is happy again with him, and he did not gain weight after the surgery. But what we do when we have a patient who is endocrinologically intact, this is a 76-year-old female. She had visual problems. You see, this is cystic tumor, this is a chiasm. What we should do with that case? So we open up, you see the cyst here, we release the cyst, the chiasm is released, but when we look to the stalk, all is tumor. Should we resect the stalk? I think it's not a good idea. So we make just a decompression endonasally, and then we send her for fractionated radiotherapy. Usually they get 30 fraction, 1.8 gray, means a total of 54 grays. And you see 3 years later, no recurrence, stalk is there, and she has still no hormonal replacement therapy. So I think for these kind of patients is ideal. Another patient, 48-year-old female, visual problems, but endocrinological, completely intact. So same thing, so we made debulking of the tumor, and what we see the stalk is infiltrated, so we left this piece. This is a residual, what we have after the surgery. Then we sent her for fractionated radiotherapy. She got only 45 grays, and you see the tumor is almost gone, a very small residual. So although craniopharyngiomas are benign tumors, they respond very well, and there is a nice study from 2014, and they showed that they have a really large control rate of 88% after 20 years, and the overall survival is also very good. So I think it's a reasonable option. If the patient has a functioning stalk and you have no chance to dissect the tumor from the stalk, we should not sacrifice it. The last type is a retroinfundibular tumor type. You see the stalk is in front. What we do with that? Of course, we try to get a gross total resection. This was a patient. You see the tumor is going into the third vein, or is pushing up the roof of the third ventricle. So we go in and we have immediately a control over the stalk. So it's very nicely seen. And then we try to find the plane and we dissect. And we use always traction, counter traction technique. Here are the small vessels of the superior hypophyseal artery. We take utmost care to preserve all these small vessels when we dissect. But you see, it's a good plane. We can go around. Here is the hypothalamus. And we keep the plane and dissect the tumor. The solid tumor part comes out. And then finally, the cystic tumor part is again dissected, traction, counter traction, and sharp dissection to avoid any pulling to the hypothalamus. And you see the stalk is here, preserved. And he had DI for some days after the surgery, but then later on it recovered. See visual problems, improved already 1 week after the surgery, 3 months after surgery, no recurrence, no gain of weight. And he has a partial insufficiency, but he does not need any substitution of desmopressin and no gain of weight. We investigated the quality of life and olfactory function in our series of the previous transcranial approaches and the endoscopic approaches, and we found a better rate of stalk preservation, although we had a gross total resection. Previously, you always sacrifice the stalk to get a gross total resection. So that I think the endonasal approach is really better because we have the same nasal quality, but we have a better stalk stalk preservation. So our philosophy is now, if the patient presents with pituitary insufficiency, NTI, we just sacrifice the stalk. When you look at these cases, the stalk is almost completely destroyed by the tumor, so we take it. But if the patient is endocrinologically intact and the tumor can be dissected with preservation of the stalk, especially in the pre-infundibular type of tumors. We always aim for gross total resection. But if the tumor is involving the stalk and the endocrinological function is very good, we do not sacrifice the stalk, especially in the older patients. We just make a debulking to decompress the optic apparatus, and then we send them for fractionated stereotactic radiotherapy. And I must admit, we have never seen so far a recurrence after this radiation. So conclusion is the gross total resection is of course the best option in patients, but not at the expense that you decrease the endocrinological outcome. Then we would prefer a subtotal resection and then a radiotherapy. Thank you for attention.
Thank you, Dr. Schroeder. Now I call upon the next speaker to speak again about craniopharyngiomas in children, and that's Dr. James Liu. He'll be talking on surgery for craniopharyngiomas in children. Dr. Liu?
Great. Can everyone see my screen?
Yes, we can.
Okay. Thank you, Chandrasekhar and the organizers here for organizing this terrific meeting. Let me just begin. I think one of the previous speakers mentioned not one case is alike. I think that was Dr. Terrell. And I think that's true for craniopharyngiomas. They really come in different shapes and sizes, and each case has its own personal challenge. So we must be tailors and tailor our treatment for these very challenging and formidable tumors. And as Dr. Boop and Henry nicely illustrated, we have to really establish the goals of surgery. And my philosophy is you always have to attempt a radical gross total if safely possible, and at the same time optimize the quality of life. And so our goals are for visual preservation and avoiding hypothalamic injury, and of course preserving the stalk if safely possible. And of course, if there's tumor that's adherent to something, a critical neurovascular structure, we have to consider the quality of life, and we must have to leave some residual if possible, but then use other forms of adjuvant treatment. So in terms of approaches, we've covered transcranial versus endoscopic endonasal, and I think we have to use a personalized, tailored approach in order to maximize our extent of resection while at the same time avoiding complications. These are some of the things that I think we have to consider when we choose an approach. Certainly tumor location, position of the chiasm in relationship to the stalk, involvement of the third ventricle, and this is important because you have to determine whether it's a purely intraventricular, which are a lot more rare, as opposed to retrochiasmatic tumors that push the floor of the third ventricle superiorly. And of course, prior surgeries and of course surgeons' comfort and preference factor into account as well. These are the different types based on the Kassam classification that Henry mentioned, and I think the ones I would agree that the type 1 preinfundibular are the best ones to preserve function, and I also find that the type 2 transinfundibular I generally sacrifice the stalk, and in some cases retroinfundibular. So in terms of surgical approaches, there are different avenues to get there. You can come in from the front, from above, or from the side, from above, through a pterional orbitozygomatic or even a eyebrow approach. And Hakuba and also Al-Mefti and now Kenji Ohata have advocated coming from lateral, a transpetrosal approach. And as Dr. Boop nicely mentioned, the transcallosal approaches, and then my preference is like Henry's, to come from below when appropriate. So this is the view from above. This is an orbitozygomatic approach, and you could see the tumors hidden from view. So you must open up the lamina terminalis, and you end up working in very small corridors, which results in blind spots and a lot of neurovascular manipulation that can result in visual loss. When you come from a lamina terminalis approach, my preference is to come midline. You have a much better view of the tumor. As in this case, you can see there's a nice lamina terminalis window on the MRI, and we like to come at these subfrontal or interhemispheric lamina terminalis approach. And this is an example showing access to the lamina terminalis. And the advantage here is that you really have a nice midline view, so you have visualization of both walls of the third ventricle and both walls of the hypothalamus. And so there's the basilar artery. And so although you have an excellent view from above, the blind spot is always this undersurface of the optic chiasm when you come from above. And so although the initial MRI looks very favorable, you must follow these craniopharyngioma patients long term, and you could see there's a bit of recurrence there, which was later treated with fractionated radiotherapy to give long-term control. So here's the view from above, and then here's the view from below. And so I think the major advantage from below is that you really have the ability to see the undersurface of the optic nerves, the chiasm, the small perforators going to the chiasm, and also the view of the hypothalamus. And I think this is where you get a major advantage in that you have fine dissection of this area of the hypothalamus to avoid injury and perhaps maybe to avoid chronic obesity. So the dogma in the past for the transphenodal approach was that if the sella was not expanded, this was a contraindication. However, I think now with the expanded endoscopic approaches, this is no longer a consideration. We can certainly get access to supradiaphragmatic lesions without having an expanded sella, and I think that thinking is antediluvial. So here's the view. You can see there's no injury to the hypothalamus, gross total resection, and here's a nice paper from our colleagues in Napoli, looking at their experience with pediatric craniopharyngiomas. And what's interesting is that the selection criteria, contraindications, surgical techniques are very similar between adults and children. And I would have to agree the same in our experience as well. The considerations for children are as such, small nostrils and narrow nasal cavities can be a challenge, but I think what the literature has shown is in most cases that you can still use a 4mm rod lens, and if you have to, you can downsize to a 2.7. And pneumatization or lack of in younger children can be a challenge, but you can still drill these areas of the skull base with image guidance and careful skull base drilling techniques. So what are some operative pearls for success? We generally like to use a 30-degree angled endoscope to get a nice view of the sella. It's important to make the bone opening along the plane of the optic canal, so you end up getting a trapezoidal bone opening of the planum, or also called a chef's hat. When you open the dura, you must identify these vessels first. These are the branches off the superior hypophyseal that will give rise to supply to the chiasm as well as the stalk. You must preserve these in order to avoid visual loss. And also in terms of dissecting the arachnoid, you should keep the arachnoid membranes towards the neurovascular structures, so you stay right on the tumor capsule. And these arachnoid membranes will continue along the membrane of Lilliquist, and you must maintain this membrane of Lilliquist in order to avoid injury to the P1 perforators. I think a good technique to find the stalk is to elevate the tumor from the gland and look for the portal striations that will give you a sign of where the stalk is. And then of course there's the basilar artery in the background. And this is the quote from Ed Oldfield, is to try to do a complete removal if you can't save the stalk. And even if the stalk is intact, it may not be functional. And if you do have to take the stalk, as in this infundibular type, we do a low stalk sectioning. And we have seen some cases where eventually they regain their ability to secrete vasopressin after long term. Again, a nice advantage is the direct view of the hypothalamus, and you must resist the temptation to pull, but like what Henry mentioned, you must dissect the tumor all around the adhesions before delivering the tumor safely to get this nice view of the posterior circulation and the third ventricle. So reconstruction is always a challenge. Oftentimes these communicate with the third ventricle, which can result in a higher risk of CSF leak. So multi-layered repair is very critical. We don't use the gasket seal for reasons explained earlier, for a risk of visual loss from optic compression. But here's an example. This is a 12-year-old boy. He's already panhypopit with short stature. You don't really see the stalk on imaging, but my feeling was this was most likely a type 2 transinfundibular, which was confirmed at surgery. So here we are opening the dura in the planum, and then you can see we've identified the carotid on the left. And we'll start with debulking of the tumor intracapsularly, which will then allow collapse of the tumor. And here now you can start to see the chiasm coming into view. After further debulking, we'll begin to dissect the tumor away from the chiasm using two-handed technique, a gentle suction sweeping. We can really find that interface between the hypothalamus and the tumor capsule, and then carefully dissect this area. We'll then lift up the tumor and find the membrane of Lilliquist, and then peel those arachnoid membranes so they fall away from the tumor capsule and towards the neurovascular structures. And once we've confirmed that all of the tumor adhesions are free from the hypothalamus, we can now deliver the tumor, not pull, but deliver the tumor from the cavity and get a nice complete removal here. Here's a view of the third ventricle. And then we'll use a 30-degree angled endoscope. We'll look all the way around. Here's looking off laterally to the left. You can start to see the proximal ICA coming out of the distal dural ring here. And then here's the pulsations of the membrane of Lilliquist. This has been kept intact. And then there's the dural defect, which we repair with fascia lata and a nasoseptal flap. And this patient has been 9 years recurrence-free after gross total, no radiation. He's been on hormone replacement therapy. He's now an adult. I recently saw him. He's now an adult now. Here's a case. I did live surgery in Mexico City. This was a 7-year-old girl, panhypopit, already with visual loss. And you can see that the sphenoid sinus was not very well pneumatized here. But still, with image guidance and drilling, we were still able to get this tumor out. And she's been 2 years recurrence-free now. And fortunately, you can see she doesn't really have obesity here, which is very fortunate. Now, this is a case of an 18-year-old. You can see the tumor is much larger, going up into the third ventricle. And here there was some tumor adhesions, so I got a near total removal, but I added IMRT, and he's been 9 years recurrence-free. So this is an example of near radical total as opposed to a gross total, and then adding radiation therapy. This is a patient where one of my colleagues put in an Ommaya reservoir to decompress the cyst. You can see there's been nice decompression, but this is only temporizing, and it's not with curative intent. So the patient was then taken for endonasal surgery, and we were able to get about 90% removal. The tumor was very adherent. It was actually encasing the proximal ICA and going towards the middle cerebral artery. And so here we decided to treat with RT, and he's been safely controlled for roughly 4 years now. So I do see patients who were childhood craniopharyngiomas that eventually grow into adulthood. And as Dr. Boop nicely mentioned, that multiple surgeries and shunts result in worse outcome. And this is an interesting case. She's had 3 prior craniotomies, 1 microscopic transsphenoidal, a right ICA injury that occurred in one of those craniotomies, and now she's been blind in the right eye. She was diagnosed at age 14, and she's now 32, and she has this tumor. And what do you do about it? I read all the prior op reports, and all they could do was drain this, but did not attempt to remove the cyst. So you see the cyst presents itself to the sphenoid sinus. So naturally, I would think this would be favorable for endonasal approach. And when we drain the cyst, you can see the cyst wall is not your typical cyst wall. This thing is thick like rubber. It's not a thin cyst wall. It's very fibrous, very thick. So we tried to attempt to define a plane, and luckily we found a plane, and I was able to peel it off of the cavernous sinus on the left. There's the remaining left optic nerve. You don't see the right optic nerve because it's atrophic from being chronically blind. And we end up debulking the cyst. And I left a very, very microscopic remnant on the right cavernous sinus because it started to bleed. And here's the final view with multi-layered repair with a fascial graft and a nasoseptal flap. And I treated this cavernous sinus with IMRT. And this is probably the longest she's ever been, now 6 or 7 years recurrence-free. Probably the longest period of recurrence-free that she's ever had. This is a recent case in a young girl I did last month. And what I want to demonstrate in this video is you can get big tumors like this out endoscopically. And as Henry nicely showed, you must use sharp dissection. And this is the beauty of this approach, is looking for that interface where the tumor adheres to the hypothalamus. And you can find a plane, you can define the plane, and use sharp dissection to carefully release these adhesions from the tumor without significant hypothalamic manipulation. And then once the tumor is completely freed, you can remove them and deliver the tumor out the corridor. And then with the endoscope, 30-degree, we can inspect all around the corners, have a beautiful view of the foramen Monroe. She did present with hydrocephalus preoperatively, and we ended up shunting her afterwards, and she's done quite well. There's an example of a large cyst in a retrochiasmatic craniopharyngioma. I debated as to which approach I would go with first. I thought about coming in transcranially, but I felt that since the solid component was retrochiasmatic, I felt that doing a endonasal approach first would give me the best visual outcome, and then perhaps coming in second stage to remove the rest of the frontal lobe cyst. But here you can see already this tumor goes over the chiasm. It almost encases the ACOM and the right optic nerve, and then forms that frontal lobe cyst. So at this moment, I already determined that it's probably going to be impossible for me to get a safe, complete removal. So I'm going to try to do the safest maximal debulking. And here you can see this is the stalk, and I'm able to save this stalk. And since I know I can't get a radical gross total, I'm going to do my best to save the stalk here. And so here's the technique of lifting the tumor up from the gland. You can see the portal striations. There's the basilar artery. And then once we've dissected this tumor all around the undersurface of the chiasm, we can remove this tumor. And then here's the frontal lobe cyst. This is quite a reach. I can't safely dissect this area. Here's the ACOM. It's plastered with some microscopic cyst wall. And then here's the stalk and the chiasm. And so this is the immediate post-op scan. I thought about coming back from a second approach, but then once I saw the 3-month scan, you could see the cyst has collapsed, and instead of doing a second surgery, I treated this with IMRT, and you could see the tumors regressed quite a bit. So I think this raises the strategy of maximal safe debulking, adding radiotherapy. Here's an example of this where I left a little tumor just behind the ACOM because it was wrapped around the ACOM perforators. And at 3 months, you could see it's already starting to recur. And so we sent for radiation therapy, and you could see 2 years post-op, the tumor is dramatically regressed. So I think this supports the role of radiation therapy. I do think that if you're going to radiate and you're going to leave subtotal, perhaps leave the least amount of residual. And of course, we can't forget the open approaches. Here's a lateral extension into the Sylvian fissure, in which case this makes the most sense to do a orbitozygomatic transsylvian approach. You can see it, the tumor is accessed through the carotid oculomotor triangle. And then this was a near total. I had microscopic adherence to the optic nerve, which I left, treated with IMRT. And then here's one where, again, previous surgery, previous terional at another hospital, now has a cystic recurrence, which failed Ommaya catheter from another center, referred to us for treatment. And I think this is a great example of using the eyebrow approach, because the cyst on the imaging was primarily in the frontal lobe and also above the chiasm. So it was suprachiasmatic. So we used this corridor to get to the frontal lobe cyst and get control of it so that there's no cyst wall adherent to the frontal lobe. And then you go subfrontal, and there's the right optic nerve, and the tumor is very adherent, so and very dense, calcified. So you must use a lot of sharp scissor dissection, and I did a lot of piecemeal removal for this. And then what I found very helpful in this case also was when the tumor is very adherent to the optic nerve, which it was, you can use an arachnoid knife that's made by this right here. This is the arachnoid AM22 knife. If you cut right on the tumor capsule, it'll release the adhesions towards the optic nerve, and it really releases these adherent tumors to neurovascular structure. So this is an excellent technique. We can dissect this off of the A1 vessel here, and then the chiasm, and get a gross total removal here. And the reason why I chose to come in from above here as opposed to from below is that I knew this was going to have microscopic residual, and if I want to send the patient to radiotherapy, you don't want to wait 3 months for a nasoseptal flap to heal. These eyebrow incisions heal very fast, and you can send them to radiation therapy within 2 to 3 weeks. And so here's the post-op scan. And what about this multicystic lesion? You can see the A3s are encased. It goes laterally into the Sylvian fissure. So in this case, a transbasal interhemispheric approach would be the best approach. It's encasing the A3s, and then you can follow the tumor into the lamina terminalis. And here I got a near total removal. And I think we have to image these patients rather quickly. Luckily, the patient came back to the ER exactly at 3 months for her 3-month scan. And of course, it was due to recurrence from worsening vision. And now you can come in endonasally, come in under the chiasm, retrochiasmatic, remove the remainder of the cyst wall. And if you see dense calcification like this that's adherent to the chiasm, I don't attempt to remove these dense calcifications. This could probably result in worsening vision. And here's the view of the third ventricle, which was repaired with a nasoseptal flap. And because I knew I left residual, I don't hesitate to send them to IMRT. And here she is now, 4 years recurrence-free from this tumor. And then lastly, I'll show you this case. This is a case of that ended up to be a papillary tumor. This is the perforators that you must preserve, and then we'll puncture the cyst to collapse the cyst wall, and then we'll remove these solid components. But in these mixed density tumors, the cystic part is always the most difficult, and here the cyst was very adherent to the walls of the hypothalamus, so you have to use two-handed dissection techniques to remove this. And then here's the final view. And then on the imaging, you can see there's a bit of enhancement. I wasn't sure if this was post-op change or residual, but the important thing is that the pathology here is papillary. And now, as our Dr. Boop had mentioned, this is part of the BRAF pathway, and you can use BRAF and MEK inhibitors as potential adjuvant therapeutic options. And we're seeing an emerging body of literature on using these inhibitor as a potential area of treatment. So in conclusion, I think the endonasal approach is an excellent option if the tumor is midline and retrochiasmatic in children, but you must have expertise in both approaches and have knowledge of the anatomy, surgical technique, and also team experience. I think adjuvant therapy with radiation is an excellent option for leaving residual tumor in order to optimize quality of life. And we must continue to explore the molecular targets as this can be an option for our patients as well. And I thank you again for this opportunity to speak at this terrific symposium. Thank you very much.
Thank you, Dr. Liu. The next speaker is Dr. Basant Misra, who will be sharing his personal experience in the surgical management of craniopharyngiomas. Basant.
You seeing my screen?
Only half of it. Yeah, now we can see the whole screen.
You can see? Okay, yeah. Thank you, Sekar, for this opportunity to be part of this excellent symposium. Very well done, very nice talks. I have really understood a lot of nuances and learned a lot with this symposium. So thank you. In the last maybe 35 years, we have had many procedures which you have done over the period of years. This is my personal experience. One of my residents analyzed 86 patients which I had operated in the hospital between 1995 to 2012. I give you those little bit data on those patients. We have a follow-up of 40 months on those patients. But the important thing is there were many surgeries, many different approaches were used, and our philosophy, as many of our previous speakers talk, safe radical excision. The critical thing is, like James talked about it, you need to have the knowledge about different approaches, because you need sometimes different approaches which suits the tumor best in a different type of tumor. Mine has been mostly transcranial approach, and this is till 2012, 75 cases. We did 116 approaches in those patients over the period of years. The majority were through a transcranial, what we call the lateral subfrontal approach. It's a combination of frontotemporal and pterional approach, and the other approaches. And we have been doing a little more of endonasal transfemoral approach lately, but these data was up to 2012. So some examples, this transcranial approach, extensive tumors, very common in our continent. This largely cystic but solid component also there. If you do a CT scan along with that, they will have a lot of calcium, which is not so well seen in MRI. And this is a short video, extensive, again, the wide opening of the sylvian fissure to avoid retraction, so that we don't damage the patient by contusion or retraction, and wide opening of all the arachnoids. And very often there is a problem because this is a prefixed chiasm. So I have very often used the retrochiasmal translaminar terminalis route. And I think that's a very nice route to take out the tumors with a retrochiasmal. Today, the trend is through endonasal approach. We have a large experience with this prefixed chiasma with retrochiasmal tumor being operated through this retrochiasmal route for a very, very long time, and quite satisfied with this. So this is behind the chiasm, and we can have very wide opening there because there is a large tumor there. As I said, though it looks mostly cystic, there's a lot of calcium in the cyst wall. And one of the tricks been told many, many years back is don't leave the cyst wall. So you can keep on dissecting out, but don't leave it so that it doesn't slip back to the depth and you lose it. So one handle of the cyst should be, one part of the cyst should be used as a handle to excise and do a radical excision. And you can dissect it out from the hypothalamus with microsurgical techniques. There's just a lot of calcium there. We are all behind the chiasm here. This is the right chiasm, the optic tract, and this is the optic chiasm here. And this is cyst wall. We're dissecting from the hypothalamus with a combination of dissecting forceps and a suction with without any suction as a dissecting tool. You can have rear radical resection with this, and you see the last bit of the cyst wall which is coming out, and we have a radical excision there, and you can see that this is the behind the optic chiasm whole thing, and you see the stalk there and the end of surgery, and this is a little bit of this is what the surgery cell fibrillar and in the undersurface of the chiasma. Oh, shit. I don't know what happened. Sorry, Rajsekhar, I don't know what happened. Something happened.
So why don't you try share screen again?
I did. You were screen sharing. It's coming. It's your screen sharing. Are you seeing anything?
No, we're just seeing some part of, yeah, we're seeing your, the home.
No. Are you seeing my screen?
Yeah, we are. I presume this, yeah, it is yours, yes. Yeah, we are back on.
Okay, so let me go. Okay, so multi-compartmental cranio, again, something which is a little more common in our continent, and this is a child with this tumor all over the place with hydrocephalus. And again, many of these patients, we don't need to do a shunt because with the decompression of the tumor, again, the same approach. So most part of this is something which was operated, I think, probably 20 years back, a young girl when she was, and I have a follow-up I'd show you at the end, the follow-up on this with the same approach. And you see we had a radical excision then, and at the end of surgery, you see the basilar artery with all the branches, the 4 branches. And we see that, as I said, this was about 20 years back video. And we're trying to sew behind the chiasma we have. And you can see the stalk there intact. And this is the post-op CT scan immediately. We have a follow-up, I'll show you later. So in our practice, it has been the workhorse because this is the shortest working distance and of course the experience over the period of years. Tumor extending to the 3rd ventricle, as I said, retrochiasmal route has been very, very useful for us. We don't use so much the optocarotid space to avoid damage, vascular injury, and so that's the corridor least used in our practice. And we preserve the membranes, the arachnoid, as already emphasized. Of course, the disadvantages, as we know, there is a lack of direct visualization of the undersurface of usually the ipsilateral optic nerve, and which can probably be a little bit, can be taken care of with endoscopic assistance. Now, in the past, we have also used supraorbital approaches, which I don't use anymore. And this is a child. This is a child who actually presented with almost functionally blind, 1-year-old child. And with this cystic tumor, you see the chiasm pushed up. And so with this, we did a supraorbital approach. This is the youngest child I have operated with a craniopharyngeal, 1-year-old child. We have used more and more. We are using this in recent years, but till 2012, we had used 7 cases, and this have helped. Our navigation has helped us, and I will not, because we have got very excellent presentation, so I will not go through that very much. But we had initially, of course, the problems of CSF leak, and we used the nasoseptal flap and the fat and glue as is usually done, and our ENT colleagues help us with this. We started only with cystic lesions in the sella as the endonasal approach, and over a period of years we have used a little more. We have been a little more aggressive, and this is a patient who had transcranial surgery by us, and this was post-op, and then she had a recurrence 4 years down the line, cystic recurrence, which we operated through an endonasal route. And this again is about 10 years back. This is a child with a giant multi-compartmental cranio. You see in the posterior fossa and going right up to the lateral ventricle. And this we used endoscopic, but a subtotal. We knew that we can't clear this tumor. And then this child was sent for radiation therapy. And this, of course, the standard, many speakers here are much more experienced with this approach. But this is something which we had done, and we believe that in very extensive tumors and large cystic components, the endoscopic transpinal approach can be used with an idea to subtotal excision and send for radiation therapy rather than do a transcranial route. And this is after radical decompression. You see the basilar, and that is the lot of calcium there. And this similar closure technique, first fat and then the head flap and then glue, and that's about what we do in these cases. What about a tumor like this, the very extensive tumor, though Henry showed very nicely this longitudinal axis. This was going laterally. This was an attempt outside done for endonasal endoscopic approach. Again, we are seeing some of these cases now where it has failed because of lack of experience of the surgeon, because the endonasal has become so much of a kind of a popular technique. The people without experience also tried that. This is the post-op from outside, so we had to go in and we removed that transcranial route. This is another, again, this is a caution of the T2, this involvement of the edema of the hypothalamus, which should have given us some clue that this dangerous lesion, again, attempted outside for an endonasal approach. The tumor was all there, pituitary was removed, and then we removed through a transcranial route. So we are seeing some of these patients with failed endoscopic endonasal approach where we have operated through a transcranial. So in our earlier practice, it was mainly used for cellular lesion and predominantly cystic lesion and midline retrochiasmal lesion. And in multi-compartmental lesion, we have aimed at subtotal excision. There's some of the, now we have about 7 cases where true third ventricular lesions, and some of the criteria used for that is intact and normal size stalk is seen, sella is free of tumor, patent chiasmatic system viable, and this is from the literature. These are the criteria used for pure third ventricular lesions. Hypothalamus at or below mid-third portion of the tumor. This is below, the hypothalamus is below the tumor here. And the another criteria used is this one slide is missing. This is mammillary body angle, which they call it, from the plane of the basal plane of the mammillary body and the floor of the angle of the floor of the fourth ventricle. That angle is acute in these cases because the tumor has pushed the third ventricular floor down. One can use the criteria to identify the pure third ventricular lesions. So we have an interest with intraventricular lesions for a long time. And this is we have a large third ventricular lesions, and these are the benign lesions. This is 5 now, 2 more we have added since then in 2014. So we have 7 true third ventricular lesions. And this is this is mammillary body angle, as we are talking of. This is the angle of the mammillary body's plane and the fourth ventricle floor. So this angle is obtuse, then it is the it is not third ventricle, extra third ventricle. If it is acute, then it is a true third ventricle because the floor of the third ventricle has been pushed down. So this is the criteria. So this is one example where we have done that, and the tumor is within the third ventricle. We opened the dura. Rick Boop showed one. I think they operate in the lateral position. We operate in supine. This is the callosotomy is only 1 to 2 centimeter. We don't need a wide opening, and you can both do a transcallosal or a transcortical. We use always with an endoscope assistance. Initially, our third ventricular, for all third ventricular, we used about 25 cases interferential approach influenced by Dr. Apujo's work. But since then, we have left it, and we advise our young neurosurgeons residents not to use unless the tumor has separated the fornices, because if you are trying to develop a plane between the fornices and it has not been separated by the tumor, we always produce some damage. So we don't use that anymore. We actually, in 1994, the first time in the literature, we described the subfornicial with what we call the subfornicial transcordial approach. And that time we called the subfornicial suprachoroidal, and this was subsequently described by Professor Roten as the transcordial approach. So this is a third ventricular cranio. The video, short video, again, this is supine position. This is right, this is left, and this is transcallosal corridor, which we said about 1 to 1.5 centimeter, maximum 2 centimeter. And we always stress the choroid plexus, and it always goes to the third ventricle. And you can open up the whole choroidal fissure, have a full extent of the third ventricle can be exposed. And as Dr. Boop said, you can sacrifice the septal vein without any consequence. This was the tumor which was, because the foramen mondo is widely opened, we used mainly the foramen corridor, but we opened up also the choroidal fissure, and we decompressed the tumor, and you can see that calcium was cut. There was calcium around it. Then we are dissecting the tumor out from the floor of the third ventricle, and then the whole thing was removed. And then we are opening the floor of the third ventricle, which is called microsurgical third ventriculostomy here. What we normally do endoscopic, this is what microsurgical, and this was some of the calcium bits were there anteriorly, which was again removed. And this is the basilar artery, you can see there. And that's the floor of the third ventricle. And that part of the tumor which was there, we removed it. And this is at the end of the surgery. You can see the mammillary bodies. And then you can put the endoscope there. You see the third ventricular floor is free, and there is a ventriculostomy there to prevent the hydrocephalus needing any further treatment. And that is the post-op MRI with the total excision needing no further treatment. This is a very extensive tumor in a child. We did in 2 stages. First, we did a tironal, first actually was transcallosal, and the second stage, a tironal craniotomy, and we had a radical excision. And this child has been without any further adjunct treatment, remains recurrence-free last 10 years now. This is a more recent gentleman who had presented in his 5th decade with this tumor, altered sensorium, a lot of endocrinological dysfunction, heavily calcified, going up to the lateral ventricle. Again, the transcallosal approach, the same route, and there were some adhesions, which is not uncommon. The cingulate adhesions, one has to be very careful. For a young neurosurgeon, may get lost. So the white corpus callosum does help to, identify that. And then we have opened up the choroidal fissure here, a heavily calcified capsule, as I said, and used dissection, cutting scissors, and CUSA. And then we had the part of the tumor which was in the sella, which was not taken out through this route. This is the immediate post-op. You see the cellular tumor, something was left, which this is a recent tumor, which will call back for a second stage through endonasal route. This is after 10 days, the hemocaphalus. So post-operative course, this patient was okay. He remained required in the ICU for some time because of hypothalamic disturbance, because he presented the altered sensorium, but finally was discharged without any problem. These are some of the do's for transcallosal route. We don't coagulate cortical veins, and we avoid the interfornical approach. And some of the other approaches which we have used, which we don't use anymore, is something again which Pernesky, I got influenced when I did a course with him. And this is there was a child actually from Pakistan who had this residual recurrent tumor, which I did an anti-hemispheric approach to this route. And this I don't do it anymore. This is another one, again, anterior hemispheric route. Again, I don't do it anymore. This is a different tumor. It's a good approach, but I don't like handling the both the frontal lobes in any of these cases, so I don't do it anymore. But this is one of these cases which I did that. Stalk section, we had a lot of discussion on this. I think if you need to section it to achieve a gross total excision, it's better to section as distally as possible from the hypothalamus to avoid hypothalamic dysfunction, though the patient will be pan-hypopate and needs replacement. So this is this till 2012, 75 cases, 116 operations. And we had recurrence over the period of years of 25% who subsequently cases who subsequently underwent surgery. 8 patients of those had adjuvant radiotherapy, and 4 patients the fractionated radiotherapy, and 4 patients gamma knife radiosurgery. Immediate post-operative period, 82% had required replacement of glucocorticoid and 30 thyroid replacement. Diabetes insipidus, immediate post-op very high. But long-term replacement, if you see 30% needed DDVP, but 60% plus glucocorticoid and thyroid replacement. And testosterone 45%. Growth hormone replacement has been low because the large number of adult patients were there, but more and more pediatric patients are being replaced with growth hormones. Vision improved in 75% of patients. Both patients who were blind at presentation remained blind. 1 patient who died because of hypothalamic disturbance on post-op day 3 because of hypothalamic disturbance. This craniopharyngioma is follow-up. This is the first one I showed you. This is that patient follow-up is for life. This is the first operation I did in 92 when I was in Trivandrum, Sri Chitra. Subsequently, 97 microsurgery again and gamma knife, 2000 again microsurgery, 2013 again microsurgery, and she's remains free now and remains in follow-up. My current approaches are only these 3. I don't do in any more this bifrontal anterior-hemispheric frontal frontobasal approach or supraorbital keyhole approach. So there are many surgical approaches. I think one need to choose that one is comfortable, and radical resection is the best chance of cure, as we heard from many speakers today. There is acceptable morbidity, however, significant endocrinological consequence. And as Henry said, if the child or patient is not able to follow up with an endocrinologist, that may be a death sentence. So one has to tailor the approach depending the patient's socioeconomic status, which is also important. And this is also possible in recurrent tumors, which you have done, and adjuvant radiation, we have found it beneficial. We already heard about the BRAF inhibitors in papillary craniopharyngioma. Thank you very much for your attention.
Thank you, Basant. We'll move on to the last talk of this session, and that's going to be given by Dr. Locatelli on surgery for recurrent craniopharyngioma. Over to you, Dr. Locatelli.
Can you see my presentation?
Not yet.
Okay, no, sorry, yes. Okay, share screen. Okay. Now?
Yeah, okay, we can see it.
Okay, so. Okay, I'll try to stay in time, but it will be easier because most has already been told. So recurrent craniopharyngioma is one of the most controversial dilemmas in neurosurgery. Most recurrence appear during the first 5 years. Hypothalamic neurovascular lesions are unpredictable, and there is obviously an high tumor variability. We have to consider which previous surgical approach has been done. If radiation therapy has to be considered, because radiation therapy may be sometimes a problem for revision surgery. Recurrence rates and mean time to recurrence are dependent on initial extent of resection. So, which are our predictor of recurrence? Extent of resection at first surgery, tumor diameter, more than 4 or 5 centimeters is significant. Suprasellar third ventricular extension, residual calcification more than 10% of volume, hydrocephalus. Obviously, if primary operation has been a gross total resection, more time will pass before we have problems with recurrences. Subtotal resection obviously will be confronted with conventional radiotherapy, fractionated sterile radiotherapy, radiosurgery, new operation, or endocavitary radiation therapy in a shorter time. And which are our targets? Any one of us has already told our target are normally considering the quality of life, preserving the quality of life, decreasing the recurrence rate, and most of all, increasing the recurrence-free interval. Which are our tools in these target? We can repeat surgery, we can go for radiotherapy, we can go for radiosurgery, we can go for endocavitary therapy when there is a cystic recurrences. Medical therapy, target therapy has already been told about, but surgery is just a possibility. So we have to balance which is the best treatment modality. And then which are the main problem? The main problem are which surgical route to use in a second or third operation, because there are technical difficulties after previous treatments. It is a good idea to consider a new approach. Arachnoidal scarring, loss of gliotic reaction, local reactive changes are well known. And after that, we have to consider how much, how much we have to extend our resection. We have to consider age, morbidity, previous treatment. All of the previous speakers considered this problem, because obviously it is different talking about a pediatric case or a 70 years old gentleman. So normally extent of resection is to be considered according to the difference of patient. And this leads us to a personalized, tailored approach. Any one of us is conscious that an approach has to be tailored according to the difference that we have in different patients. So let's speak first of all of which are the ideas of taking a tumor from an endoscopic endonasal approach. Which are the options? The pros option are brain retraction is obviated, direct manipulation of the optic apparatus is minimized, early identification of pituitary gland in the fundibulum, eye magnification, obviously early chiasmatic decompression, and direct inspection of the hypothalamus to determine invasion. We can explore very well all the hypothalamic and the endoventricular apparatus with the endoscope inside. Obviously, we have a better vision, is well known to any one of us, a better vision than from a microscopic point of view. These type of vessels are not so easily seen in a recurrent tumor, and the best vision we have in endoscopic approach are a good reason to go from this point of view. And these are other example of this intraoperative vision about talking about the optic apparatus and talking about the vascularization of the optic chiasm. And first choice for me is obviously this endoscopic endonasal approach, but another good idea is we can go with prefixed or postfixed chiasm well from below. And which are the problems with this type of approach? We can talk in this topic. We can talk for a long time, but in a relapse, the orientation can be more difficult. You need obviously always near navigation. You can have lack of anatomical landmark and scarring, and sometimes repeat surgery is not difficult by itself, but can be not so easy to find the best type of closure, because if in the first endoscopic endonasal operation it has been damaged, the septal pedicle flap, or radiation has already been done, or there are particular conditions, the risk of CSF leakage in the second endonasal operation can increase. Microscopic has already been well exposed from any one of us. Obviously, I share the opinion that you do need to having both tools, and you have to be a microscopic and endoscopic surgeon. So I prefer, up to now, I have to say that I have operated about 90 cases up to now, and of craniopharyngioma, and since 2004, and most of the cases after 2004, except a couple of cases, I have operated always by endoscopic endonasal route, but the lateral extension obviously is better controlled. You have to take care, as I already told, about the risk of CSF leak. And in a case you have intraventricular pure located cyst, the endoscopic endonasal is not the good idea. But as already told from anyone else, any one of us, the endoscopic purely intraventricular, the purely intraventricular cyst is very rare. What about recurrences treated by endoventricular cyst treatment? Someone else will speak after me according to this problem, to this topic. But obviously, sometimes the recurrences is just cystic. You can gain time. You cannot solve the problem, but you can gain time before another reoperation. You can use this type of access to solve the anatomocephalus. You can solve cystic compression. And I published in 2004 in Nervous System. You can also resect part of the cyst with laser inside the ventricle with this technique. Obviously, it is subtotal or maybe mainly partial resection. You can also put some drug inside, and someone else will speak about that. And you can also treat endonasally the cyst without any idea of these this treatment to be gross total resection. You can marsupialize the cyst. I have published this many years ago. I still remember in this case I show in a very more than 20 years ago a marsupialization of craniopharyngioma already treated. You can think this patient was operated the first time by Yazagil, and he had been treated by radiotherapy, and he continued to have cystic recurrences without any evidence of at the time any evidence of the craniopharyngioma solid part. Marsupialization worked for at least 7 years. But after that, the tumor recurred in a very important way. So, which are the results, the outcome after this type of recurrence, after another operation? Normally, preoperative visual loss is the most important predictive factor for postoperative visual status. And overall, looking at the literature, and in particular to this article, no statistical differences in rates of visual outcome between primary and recurrent craniopharyngioma. And most of all, results on visual outcome do not differ between gross total resection and subtotal resection. Normally, endocrinological outcome is not statistically higher, looking at only the diabetes insipidus, but other endocrinopathies are more common following recurrent surgery, and this is clearly understandable. Neuropsychological outcome, as already stated, is worse, mainly in pediatric patients after a recurrent operation. Mortality rate is higher for recurrent surgery. This is significant, and clearly in more recent time, mortality is decreased in an important way. Let's see which are our idea with some quick example of recurrent craniopharyngioma. I will show just this was my first craniopharyngioma coming from Peru in 2004, and it had been operated, I think, a couple of times from a transcranial approach. Then we take this part, and we were able to follow this patient for a couple of years before she returned home. I have no, it was too old. My postoperative is not here, but she was well for a couple of years, and I don't know after that. But it was my first operation. Then this followed. These are after that almost all except 2 cases I operated in endoscopic way. This obviously it has been operated in the first time by an endoscopic endonasal approach. Recurrency in the posterior fossa has been operated by an assisted post-operative posterior fossa access. This case is quite interesting because in this case, this young boy was operated in another hospital before, and with a transcranial access, trying to preserve and to have the longest period of good quality of life. But 2 years later, he recurred, and we did an extended endoscopic endonasal approach. This had been already told to the boy and his family, and at the end it was a good option, because if you can appreciate this video, the usual access, the scarring is almost visible, but the scarring was not so difficult to take, and using the ultrasonic aspirator, we were able to dissect. And you have seen many of these wonderful videos before, so I don't want to be too exhaustive on this theme, but you have to say, I have to remember that together with sharp dissection and resection of the tumor from the hypothalamus, the endoscopic diving technique like this, we press with liquid the tumor from behind, and we favor the extrusion of the tumor and clean in the meantime the entire ventricle, is a good way, in my opinion, to favor the final result. And you can see the final result, and clearly this is the follow-up 4 years after. Another case in which we did a couple of endoscopic endonasal approaches. It looked very, it is rare that we go the same way 2 times with the same approach, because there was no idea of where was the tumor, the residual tumor remaining. At the last one, we decided to go transcranial, and after that, since this younger boy was already blind at the beginning in the right eye, we were very conservative, and we did transcranial, and after that resection by resection, after that resection also radiotherapy. Another case, this case is an idea of what can happen with young boys. In this case, endoscopic fenestration was done, and this is what happened after 2 years. After 2 years at cyst regrowth, the child presented with right homonymous eminapsia, extended endoscopic endonasal approach, 3 months posterior stable residual cyst, and after that we decided to go for fractionated stereotactic radiotherapy. The idea is that most cases we try to delay as much as possible radiotherapy. We could discuss about that because I have heard different opinion, but my idea is I try to take the tumor, if possible, from the nasal route, if possible. And let's see what happened after that. Obviously, we have a good clinical outcome, 2 years follow-up after radiotherapy. It is a satisfying MRI, but you have to keep in mind that we will follow this young boy till at least for the next 20 years. So we have to see which will be the final solution, if this will be the final solution, or if targeted therapy could be our final solution at the end. And now I want to remember before concluding that this is a very old video, 10 years ago and more. And I was just showing, I want to show this because you see this was a catheter left inside the ventricle. At the end, this catheter, not by us, obviously, because we are very cautious about leaving a catheter so long inside the ventricle. The catheter was in between the anterior communicating artery and the chiasm. A big cyst developed between the catheter and the arteries. This young lawyer became almost blind, and we had to treat him, taking with a lot of difficulties. Not the cyst, but the catheter was completely filled with calcification, and taking out the tumor was the catheter was more difficult than taking the tumor itself. So when you leave a catheter inside, take care of what happens and where it is positioned. It seems so easy, but it is not. Concluding, the management of recurrent craniopharyngioma remains one of the most controversial and challenging topics. if grand total can be achieved safely, preserving hypothalamic function, it remains for me the treatment choice. The endoscopic approach now for me is a preferred one, but obviously a tailored multimodality treatment is employed to optimize outcome. And sometimes intentional stage resection in pediatric cases should be considered. And then we have to balance timing of radiotherapy because children become adults, and when they are adults, we have to treat them all the same. And the span of time we have to follow this patient is all lifelong. So before using radiotherapy, in my opinion, we have to think about it very, very carefully. And the role of surgery and adjuvant radiotherapy for craniopharyngioma may vary in the future. Obviously, targeted therapy can be of an important choice. Nevertheless, surgery can still be a major therapeutic option in the management of recurrent craniopharyngioma. Thank you for your attention.
Thank you, Dr. Locatelli, for that presentation. I would like to thank all the speakers for giving excellent talks. I don't think we have too much time for questions, but I would like to ask one question, if I'm permitted to do so, and that's with respect to the management in the early postoperative period of patients undergoing radical excision of craniopharyngiomas. We know that these patients require very aggressive fluid and electrolyte management. So I would like to ask all of you to comment on that. Also about the duration of hospitalization that these patients typically require after a radical excision of a craniopharyngioma.
So in my experience, this is very variable. So you have patients, they have not much problems, but we have already also seen patients who come in with hypothalamic problems, and after surgery, they had a very stormy course, and they were staying at least 3 weeks. And we have to be very careful with the balancing of the electrolytes, DI treatment. So it can be really a problem. And the more aggressive you are, the more you have to expect that such problems may occur. And we place all these patients where we have a big hole in the dura with a lumbar drain for 5 days, and to have a lower rate of CSF leakage. Initially, in our experience, we had problems with patients, really with tremendous problems with CSF leakage. We designed the nasoseptal flap a little bit too small, and then they start to leak, and finally they ended up with a shunt because they had also hydrocephalus before the surgery. So it can be tricky.
Dr. Boop, in children?
Rick had to leave.
Oh, okay. Okay. Would Dr. Liu like to comment on that? Or?
Yeah, I would agree with all the points that Henry mentioned. One other thing that I like to do is I keep them on high-dose steroids, usually like 10 milligrams of Decadron every Q6, because I always worry about swelling in the optic nerves and getting delayed visual loss. I also try to keep them well hydrated because you can get vasospasm of those small perforating vessels going to the optic nerves. And then lastly, I think if they have pre-existing hydrocephalus, I have a low threshold to shunt them, because if you go endonasally, they'll probably leak, and then you have a CSF leak on top of hydrocephalus. So those would be my main points.
Okay, Shekhar, do we have time for any more questions, or should
I think Shekhar, I think in interest of time, we'll have to move on. Some other aspects of craniopharyngioma will be covered in the next session.
Chandra, so one short questions to Jim. Sure. Jim, do you have any different strategy in adult patients and pediatric patients? Because pediatric patients are more vulnerable to hypothalamic problems.
I think my philosophy and techniques are similar, whether it's children or adults. I think even in adults, I try to be I tried to be as safely aggressive as I can with dissecting that plane, which I think you beautifully showed. I think you can define that plane, and it just takes a little gentle traction and sharp, dissection of that plane, and of course use your judgment as to when you have to leave some behind.
Dr. Locatelli, you have any comment on this before we close?
Well, I think that my previous speaker covered very well the topic. And regarding the time after when we need to keep the patient in the hospital is very variable. It depends from which type of resection you did, which type of if you tried for gross total, if it was a very aggressive operation or not. So I cannot say how long it takes. You have to count on at least a couple of weeks.
Thank you. Then we move on to the next session.
Thank you, gentlemen. The next.
Thanks all the speakers and moderator.
We move on to session 8. The chairpersons for this session are Dr. Jalali, who's an eminent radiation oncologist at the Apollo Proton Center in Chennai. Professor Gianpiero Tamburini, Professor of Neurosurgery at Rome, Italy. Professor Vernon Velo, Head of Department of Neurosurgery at the Grant Medical and JJ Hospital. Professor Chinari couldn't join us today. May I request the chairpersons to please conduct the session.
Thank you. Good evening, everyone, and it's my pleasure on behalf of my colleagues. So we go to the first part by on the intracystic treatments for craniopharyngioma. Dr. Tamburini, please. So may I request Dr. Tamburini to kindly start the presentation.
Gianpiero, can you share the screen, please?
The other one.
Dr. Tamburini, probably you have to change your headphones. There's a lot of disturbance coming from.
Yes. Do you see my screen now? Yes, we can. Okay, good. So thanks, Shekhar, for giving me this opportunity to be part of this meeting today, this afternoon. And we will move on from surgery to alternatives that we may have, especially in the pediatric age. So chemotherapeutic intracystic treatments are one of the options that we are using to consider in pediatric patients. Why do we consider this kind of treatment? We have to remember, especially for children, that the cystic component is part of the lesions in around 90% of the cases, and frequently this component is quite huge. And this component itself determines frequently with its upward growth secondary CSF obstructions and secondary hydrocephalus. And we know that symptoms of increased ICP reveal the tumor in 40% of the cases, actually. Why should we care about cystic component, especially in the growing child? And we know this is necessary not only to control the hydrocephalus and presenting symptoms and signs, the optic pathway compression, the increased ICP. But also it is important to delay direct surgery, maintaining the best for the patient's endocrinological status as long as possible. It has also been used, and we are still using in selective cases of residual recurrent cysts, or as a salvage therapy in patients in compromised clinical conditions, which are unable to afford the further surgeries. What about the first thing that we need? We need to position the catheter inside the cyst. There are alternative proposed techniques for this. In the past, especially in adults, it was proposed to implant this kind of catheters stereotactically, but as I've said, most of the data are on adults, and it's quite technically difficult in small children. With it documented a relatively high rate of cyst fluid leakage, up to 15%, which conditions the success of the intracytic treatment. This was the technique proposed by our good friend Sergio Cavallero through a craniotomic approach. This publication was in 2005 in Child's Nervous System for this kind of intracytic treatment. We will speak about the kind of treatment he proposed, and we still follow. And we have pure ventricular endoscopy. We are using this kind of technique in the last 11 to 12 years. Which is an option, a further option, as well as an assisted stereotactic positioning under endoscopic view. In this case, the endoscope is used as a control of the correct direction and final position of the catheter. In all cases, whatever technique you choose to use to implant the catheter, you have to control the position of the catheter, and especially the absence of cyst fluid leakage at some distance, generally at 3 to 4 weeks from the catheter implantation, injecting the contrast inside the cyst through the catheter, which is connected to a subcutaneous chamber. So this is the first important step before starting any kind of treatment. So which are the treatments that we have available now? The ideal treatment should be long-term effective without side effects and no long-term concerns. But actually, none of the substances that have been tried for intracystic treatment have all this kind of positive effects. I would say that especially in children, radioisotope has been almost abandoned in the last decade in order to avoid secondary local radiation effects. And the literature in pediatric age is almost centered on bleomycin and interferon. What about bleomycin injection for cystic craniopharyngoma in the pediatric age? The first small clinical series, which was published in 1985, actually clarified already the limits of the subsequent published series, which are this kind of limits. The dosing schemes have been quite variable in the different series that have been published, and also the dosing interval, as you can see from this resuming slides, it's been quite variable in the different reports. And what about the results that have been reported? These are the main series that are present in the literature, with a complete response between 30 to 60%, and also the follow-up variable between 3 up to 9 years. So very different kind of response, but also different follow-ups. Again, other series reporting between 40 and 70% response, at the follow-up varying between 3.5 and 6 years, up to 6.5 years. The main limits, resuming of this published series, are that primary cases in all the series are joined with recurrences. Purely cystic tumors are joined with mixed or mainly solid tumors, and the usage doses that have been proposed are extremely variable. And then we have the problem of secondary effects of bleomycin. There's been reported 5% risk of blindness, and also in the risk of extensive hypothalamic injury, in the panhypopituitarism after bleomycin injection, and also death after leakage of the bleomycin outside the cyst walls. So it is a drug that is still can be proposed, but actually for its secondary effects, along the years, along the decades, we have tried to find alternatives, and the alternatives that has been proposed at the middle of the first decades of 2000s by the San Paulo group in 2005 is the interferon. The first series that the San Paulo group reported was on 9 patients with this kind of schema of injection in the system of alpha interferon, 3 million units every other day for 12-day cycles, with a quite encouraging success rate up to quite 80%, but the first series with a follow-up of less than 2 years. So they published a few years later a larger series on around 20 patients, a similar scheme of doses injection, but again the results quite encouraging, more than 90% reduction in 60% of the cases, now at a longer follow-up of 22 months. And the first side effects that they reported that are confirmed also in more recent series were minor effects like a headache or fever that were quite common, so not really important side effects in this larger series. Then came the first international multi-center study to which we participated, and the conclusion with the longer follow-up due to the presence of recurrence of the cystic components and also the solid component of the craniopharyngioma was that it has been considered, and it should be considered as a useful kind of treatment to postpone direct surgery, but not a definitive treatment. This was on 60 cases in 2010. Then there has been another international multi-center studies in which all the cases were analyzed with a longer follow-up, and we see that a 5.8 years mean follow-up. Certainly, the interferon intracystic treatment allowed to prolong the time before tumor progression in pure cystic tumors, but not statistically significantly differently in solidocystic tumors. So you see the progression-free survival for pure cystic and solidocystic. In solidocystic tumors, the progression-free survival was not exactly the same. Then after this, we have had other small series, and you see that as long as we go on with longer follow-ups, the risks of progression come out. And in this series, that was a small series of 3 cases in this large Chinese study, in 2 or 3 cases at 6 years, at around 6 years, we had a progression of the disease. Another series in which interferon was used in 6 patients with 1.25 cycles. The scheme of administration was very similar to the original one, and not significant change in the schema of administration. But you see that also in this more recent series, the follow-up was up to 28 months with encouraging results. But I would say probably also in this series, the follow-up was too short to see recurrences and progression of the disease. So we have said that we have very limited secondary effects, and one of the things that since the beginning of the use of interferon was said that it has no neurotoxicity. Then a few reports have come out showing that we may have this kind of secondary effects because of secondary leakage, and case reports came on in the literature, like these patients that had a secondary seizure, probably due to a leakage around the temporal lobe, and another case showing secondary involvement of the chiasmatic region, you see, with this hemianopsia documented on cambimetric examinations. And the largest multicenter study, more recent multicenter study, reported this kind of secondary effects. We had one case of visual loss among the severe complications, and one case of diffuse frontal atrophy reported. And these are the percentages of secondary effects, which are, and I also consider minor, like influenza, like malaise or headache, in around 15 to 20% of the cases. We have to say that in our experience, which has now collected 22 cases, we had 2 cases of technical failures because of trapping, especially of the intracystic catheter, and correct treatment was possible and completely in only 9 cases, and a VIN follow-up of 4 years. Let's see in details. We had 2 cases of complications, one related to catheter malposition, and the other to intracerebral drug diffusion, in spite of apparent no leakage from the cyst wall at the time of the control. All this without significant sequelae. And also the other things we have to consider, I support David statement that at the time of surgery we have to operate the adherences that we could find at the level of the cyst walls around the surrounding cerebral structure were reinforced. So it was compared with a primary surgical treatment, more difficult to detach the capsule from the surrounding cerebral and vascular structure. So the ideal course is this kind of patients with a purely cystic tumor, which had resolution of preoperative symptoms without endocrinological impairment and stable disease now at a follow-up of more than 4 years. And in all cases that we had the tumor stabilized among the whole series, 3 were the children that had a complete stabilization of the tumor only with intracystic treatment. We had a transient response in other 4 cases, and I will show a few examples of this. This was patients after the first cycle at an MRI, and then cyst recurrence that was quite early at 3 months follow-up. We had the second cycle, and the patients at this point had a complete hormonal replacement treatment. And after the end of the second cycle, she underwent resection and subdocular resection, a second recurrence which required a second surgery, and in this case, after second surgery, we send the patient to a radiation treatment. The problems that we had was especially with this kind of tumor, apparently cystic, but I would say surrounding the hypothalamus at 360 degrees. This kind of patients, especially smaller patients, have the highest risk of having a change in the evolution of the recurrences and the progression of the disease. You see, the MRI was quite encouraging after interferon treatment, but only a few months after this kind of treatment, 6 months after the treatment, it showed this kind of multicystic progression. So this has particular cases. Also, this patient, which also had, I would say, not a 360 degrees, but a surrounding of the cyst of the tumor around the hypothalamus, rendered our work quite difficult only with interferon. We went on with 3 cycles of interferon. It apparently went well, but then it started to develop this lateral cyst, which was growing, and then he was operated through epithelial approach to remove this kind of cyst. And then he had a second regrowth of the same cyst that we attempted to treat with a positioning of a new catheter inside this cyst. But you see that most of this cystic content was too dense at the time of the control, and we also saw some fluid leakage from the cyst also inside the ventricular system. So at the end, he underwent removal also of this second recurrence of this lateral cyst. What we learned from this is that multicystic progression, especially of solid cystic tumors, apparently presenting with mainly cystic component, like mainly cystic tumors, are very difficult to treat. Our experience in this context was particularly difficult in children smaller than 2 years. And these are the 2 examples that were shown before, the ones that we had a very good results with a complete collapse of the cyst and tumor appearance, which was quite positive at the end of surgery in the first case, and this kind of incomplete collapse of the cyst after interferon treatment, which is suggestive, like the MRI showed at images review, surrounding the hypothalamus and displacing the inferior portion of the ventricle. These are the tumors which are more difficult to be treated in spite of apparently presenting as purely cystic tumors. So at this moment, I will say the intracystic alpha interferon therapy allows to control craniopharyngioma in selective cases, purely cystic, not 360 degrees surrounding the hypothalamus. In most of the cases, the control should be said is temporary, and some of these craniopharyngioma escape the effect of the agent and tend to have an aggressive course. We have studied those patients recurring, especially those with multicystic recurrence, backwards to see if the levels of inflammatory markers that have been documented in our and in other institutions from the proteomic analysis were different, and we saw that there was a difference in the descents of the alpha defensins between the different groups. So a more rapid descent of the alpha defensins was really the marker of a successful treatment compared with those in which this kind of decrease was not documented in the proteomic analysis. And similarly, we also saw these other markers that are beta tymosins that were largely documented to decrease in the successful cases and not decreasing in those that had multicystic recurrence. Finally, I would say that we are now studying also the walls we are backward studying the walls of the tumors to see if other markers of progression and recurrence like beta-catenin or interleukin-8, which have been documented now in immunohistological studies, may actually be a reason explaining why a part of these patients tend to recur and progress more actively than the ones in which the success was actually obtained. Thank you. So it's my pleasure to introduce the second speaker of the session, which is Professor Sergio Cavallero, which is full professor in the surgical department in Federal University in Sao Paulo, Brazil, and with large experience in the treatment of craniopharyngiomas, not only with interferon, but with endoscopy and open surgery, is well renowned worldwide in all the neurosurgical field. I consider him a friend and a master. So Sergio, please.
Okay, thank you. And to begin it, I'd like to thank the organizers of this meeting for inviting me. Could you see my screen?
Yes, we do.
Okay. So I'd like to thank the organizer of this meeting for inviting me. It's a pleasure to be here with you to discuss about ventricular craniopharyngiomas and the endoscopic approach. I work in São Paulo. It's my oncologic institute for children. As you know, craniopharyngioma is a benign histology, could call a multiform cross craniopharyngiomas. Present a few or no genetic alteration and grow around the hypothalamus and present high rates of recurrence. So I can call the craniopharyngioma as a super tumor. So you can do different approach, total exercise, partial exercise, push-on, drainage of the system, associated with radiotherapy or intracystic therapy. So concerning the embryology of the craniopharyngiomas due to the migration of the pharynx to the floor of the third ventricle, during the 50 weeks of the pregnancy when occurs this migration, some cells, some remains can stay in this way. So we can find the craniopharyngioma in all the parts of this way. So you can find cellular craniopharyngiomas or sometimes outside of the brain, sphenoidal or ethmoidal craniopharyngiomas, cellular, infundibular, or ventricular craniopharyngioma. And today I'm going to stress with you about ventricular craniopharyngiomas. It's a little hair localization, 0.7 to 11% of the craniopharyngiomas, and the symptomatology is a little bit different. Some increase of the intracranial pressure due to obstructive hydrocephalus, hypothalamic and pituitary dysfunction, but visual deficit is a little bit hair. So you can use 4 different kind of modality to approach the ventricular craniopharyngiomas. Intracystic therapy, combine endoscopic approach with subfrontal approach, pure neuroendoscopy, or combine pure endoscopy with assisted endoscopy. It's my first case that I treat with chemotherapy. It's a bleomycin in 1996. 6 months after treatment, 25 years follow-up, not grow anymore. But it's very toxic. I show Dr. Tamburini, and now I moved 20 years ago for intracystic chemotherapy. And the one approach by endoscopy is to put the catheter use endoscopy. So now you can see a big craniopharyngiomas outside in the lateral ventricle. Use the endoscopy, I can insert the catheter in a good place without vascularization. You need to pay attention to put all the holes inside to the craniopharyngioma to avoid the leakage. So it's the protocol. I put the 3 million international units every other day, totalizing 36 million units that I call one cycle. I think Dr. Tamburini showed a lot of these results, but it's some kind of the therapy of the approach to the craniopharyngioma. In 2017, I saw this beautiful publication in Neuro-Oncology associated with 21 international centers to study interferon craniopharyngioma. They call Toronto Protocol. When you analyze the São Paulo Protocol beginning 20 years ago to the Toronto Protocol, look at the results of the Toronto Protocol is not the same, because it's my first choice to put interferon in young patients, and the Toronto Protocol, they do interferon after radiotherapy, after some surgery. It's not for the virgin cases. So there is some parts to use interferon in craniopharyngiomas. Look at this case, huge craniopharyngioma, 3 cycles, 10 years follow-up, no endocrinologic deficit, no obesity. So the interferon increases the apoptotic factors, but decreases the cell viability. Of course, the craniopharyngioma not to kill the interferon not to kill the craniopharyngioma, but decreases the cell viability. So the second approach is the subfrontal approach, combined with ventricular endoscopy. Like in this case, it's a huge craniopharyngioma. After removed by translaminar terminalis, I combine with endoscopic approach. Look, this approach is a subfrontal. I love this approach. You can identify both optic nerve, the chiasma. It's a prefixate chiasma. Open the lamina terminalis. All the time you need to pay attention to not damage the vascularization of the optic pathway. And now you can see several stones inside to the third ventricle. So I think once the craniopharyngioma is pure ventricular, the translaminar terminalis is wonderful to do. Sometimes you can remove a large stone inside to the third ventricle. It should be the first approach. But when you use this approach, you have a blind region, is the posterior part of the third ventricle and the superior part. You know, with this approach, it's absolutely impossible to see this region. So when I finish to remove the tumor, there is no more tumor in this view. You can combine with ventricular endoscopic approach. But look, complete resection of the tumor. We thought it was complete resection. It's a several small calcification. So now we've detached the tumor, large component of this lesion. So then, no more tumor, you move, you put endoscopic approach when the ventricular is large. Oh, no more tumor here. So then when you put the endoscopic, you can verify the superior part of the third ventricle. There is some remains of this tumor. So now use the forceps and aspirate. I can remove complete the tumor in the posterior part and superior part of the third ventricle. So, and here's the pre and the postoperatively, no more tumor. So the third approach is the pure endoscopic transcranial approach. So normally I need to use the Gabi endoscope and put the ultrasonic aspirate through the Gabi. It's look like it's again to destroy the craniopharyngiomas. How does it work? I put the borehole in the coronal suture, introduce the Gabi endoscopy. You need to use the Gabi because the unique endoscope that's the endoscope pass through, identify the tumor, verify the monoforamen, and then introduce it through the endoscope, the ultrasonic device. So if it can help. So now you can see the cyst, bulging the moral foramen. After remove the cyst, to put the endoscope and try to completely aspirate the tumor. So it's look like a dream to completely remove a tumor using just one burr hole. And here, the preoperatively and the postoperative and the preservation of the hypothalamus, I think, one important factor. Here's another case, a pure third ventricle tumor. Now you can identify the anatomy, the anterior caudate vein, thalamus straight vein, septal vein, choroidoplex. Now you try to coagulate the capsule of the craniopharyngioma. During this procedure, I continue to wash the ventricular cavity to become clean. And now you can coagulate the capsule of the craniopharyngioma with bipolar, aspirate the fluid component, and look several small calcifications in the wall of the craniopharyngiomas. Now when we remove the fluid, the tumor begin to detach of the third ventricle, but in that region is very attached to the fornix. You need to protect the fornix all the time. In that approach, you don't need to cut the septal vein. Of course, it's possible, but with endoscopy it's a little bit difficult. And now I am inside to the craniopharyngioma. You can identify several calcifications, cystic part, solid part. And now I introduce the ultrasonic device with vibration and irrigation. There is no aspiration. So try to remove a small piece of the tumor to molecular biology and to the pathology, and they use endoscopic device. You can slowly by slowly remove all this component without traction. So then you begin to identify the floor of the third ventricle. So the aqueduct now is becoming free, and the interpeduncular cistern, you can see this huge calcification, very attached to the basilar artery, and try to almost completely remove this lesion. And the postoperative look, it's left a small piece of the calcification. It was very hard to remove, but the patient in the postoperative without any endocrinologic deficits. And the last one, when they combine pure endoscopy and assisted endoscopy. As in this case, this patient was submitted to 2 previous procedures plus radiotherapy and the tumor recurrence. Now I try to approach by the endoscopy and open the fluid. Now we are inside the tumor. But the tumor in that situation, I think after radiotherapy, it was very, very, very difficult to remove. I tried to remove with ultrasonic device, but it's not, I don't obtain this success with that. So I stopped this approach and changed and put the tube. And now I beginning to work through the tube without CSF. So the coagulation became more easily. They now use a different instrument. I beginning to completely resect the tumor. Look, you can see very well the hypothalamus, the preservation of the hypothalamus, but it's a very calcified tumor. So using ultrasonic device and other kind of forceps, you try to detach this tumor of the optic pathway of the hypothalamus, but slowly you continue to remove this tumor until to arrive in the interpeduncular cisterna and clean this structure. 6th nerve, 4th nerve, 3rd nerve, and the basilar artery. So now it's a gross total resection of this tumor. Aqueduct is free, and the moral foramen, choroidoplexus, thalamus striate vein, it's all preserved. And here the post-operative of this tumor. It's my series from 1991 to 2020. I operate 106 cases. It represents 7.1% of our activity. The median age of the patient was 80 years old. The clinical presentation, the majority of the cases are huge craniopharyngiomas, hydrocephalus, visual distress, and intracranial hypertension. And you can use several approaches. I think the neurosurgeon should be very versatile and listen what the craniopharyngioma to say, what the approach he'd like to go out or not. So you can use a different approach. And look, several cases I use interferon with the first approach, and other results, I can resect total resection in 70% of this patient. We have 4 cases of mortality, 1 fetal before birth, 1 due to bleomycina, the patient had cardiac problems after use bleomycina, and 2 in the postoperative due to a sodium alteration. Is the overall survival our case, but the best results that obtain concerning the obesity when they use interferon alpha is the same to when you have the panhypopituitarism, the good results when you use the interferon alpha. So in conclusion, ventricular craniopharyngioma as a hair topography, in respective of the approach used, this essential to hypothalamus preservation, and endoscope is an excellent tool in craniopharyngioma surgery. Thank you very much for your attention.
Thank you, Dr.
Thank you, Sergio.
I would like to introduce our next speaker. Actually, it's a privilege and honor for me to introduce to you Dr. Rakesh Jalali, who is a radiation oncologist. He was the director of the radiation oncology department at Tata Memorial before, and now he has moved on to Chennai, and he has taken over the Proton Beam Center there at the Apollo Chennai. Welcome, Rakesh, and it's over to you to tell us something about radiotherapy and proton beam therapy for craniopharyngiomas.
Thank you, Dr. Vernon. Can you see my slides?
Yes, we can. Go
Great.
ahead, please.
Thank you so much. I'd like to begin by expressing my gratitude to Professor Depujari, the WFNS team, at what a fantastic 2 days we have had with virtual, an academic feast, so as to speak in this cohort of tumors that we have been discussing. Already a lot has been spoken about craniopharyngioma, and I'll restrict myself to the radiation aspect. And as we learned that the paradigms for management of craniopharyngiomas have been evolving over a period of time. And as was demonstrated by several speakers, particularly by Professor Rick Boop, that increasingly standard of care is conservative surgery plus focal conformal radiation. And as you can see, if you look at the relatively earlier data, even that was a large cohort of 144 published studies about 12 years ago, and that also that time it was anywhere between 75 to 95% local control. And subsequently, of course, several series from different parts of the world have tried to show what are the different technologies and different techniques such that you have effective and robust and durable local control for these set of patients, both in the pediatric population as well as in the adults. One of the key areas from the radiation aspect, of course, has to be that direct radiation should be discouraged. We still get sometimes occasionally patients where we are asked to give direct radiation because surgery especially is absolutely essential, particularly when they compress the chiasm or they are relatively large. And invariably we get a combination of cystic and solid area. The dictum for us is treat what you see, but surgical impression is absolutely important. As some of you know who have been working for many, many years, that we always discuss with the surgical colleagues, especially if the tumor sliver is left behind the stalk and different, especially in the different, and also when they have multi-compartmental locations of this tumor. Typically, we do the tumor bed cavity, which forms our what is called clinical target volume, and we give anywhere between 0 to 5 millimeter on the gross tumor volume. And then depending upon the technique, especially if it is with image guidance, or earlier, currently we use image guidance, but earlier we used to stereotactic guidance. And then you have a very narrow margin along it such that you try to limit the radiation volume as much as possible. We really try to defer radiation in spite of all the high precision techniques that we have. And if there is no cutoff really, you could try to defer as much as possible. Occasionally it's not possible because the patients could have recurrences already, and multiple times of surgeries does increase the morbidity and sometimes even mortality. And you have to kind of balance between the two, but the dictum is try to defer radiation as much as possible. There is no doubt that the best possible technique that you have in the center, and again, as we have realized from the surgical field, that it should really go to a person who has a high volume with special expertise, especially with such a difficult tumor as craniopharyngioma. One could even argue that same holds true for radiation therapy, because these are the tumors relatively difficult. They need very high precision. They need very intense surveillance and monitoring. And as you know, they can be associated with very high and durable local control and survival. But these are the tumors which also have an extremely high burden of treatment-related morbidity, both from surgical, but also very, very significantly from radiation point of view, whether it is cognition, hormone, growth retardation, and so on and so forth. So you have to be as conformal as possible. Many years ago, we had the 3D conformal therapy. Then we moved on to stereotactic or stereotactic conformal radiotherapy. Currently, we use the IMRT technology and particle beam therapy. This was the data from St. Jude's, and you heard Professor Boop already telling us the updated data of 97 to 98% long-term overall survival with this technology. And clearly, there are several areas of the brain that you have to spare without compromising the local control and survival with this high precision technology. Now, in Mumbai, in Tata Memorial Hospital, where I spent most of my career, we ran a prospective data trial many years ago, almost 20 years ago, combining the focal conformal radiation with stereotactic radiotherapy or IMRT with a fractionated approach, because largely the tumors that we saw were relatively large or recurrent, where you had to necessitate a fractionated approach. And the classic dose is 54 gray in 30 fractions in 6 weeks. The strength of this data is prospective and also is associated with, it's a consecutive prospective series, and also associated with in-depth neurocognitive and neuroendocrine data, which I will be showing in subsequently. But suffice to say, in this 70 odd patients in the earlier analysis, at a median of about 3.5 to 4 years, we did have 3 deaths, and most of them were because of the electrolyte imbalance and repeated infections. And we had 1 vascular event, but overall the patients did well with 5 and 7 year overall survival above 95%. As some of you know, we went on to do this randomized trial because one of the challenges in radiation is that there are not too many randomized trials done, such that you don't have a very high level of evidence for a high precision technique as compared to a conventional approach. And fortunately, we could manage to do this randomized trial, and we could demonstrate that the reduction of the normal volume radiation did yield at 5 years superior clinically relevant endpoint of outcomes, of functional outcomes like neurocognition and neuroendocrine, and this yielded a relatively high level of evidence. What was interesting is, of the 200 patient cohort which were randomized in this series, which was the number that we needed to have the appropriate statistical power, the commonest histology was belonged to craniopharyngioma, and we have done a subset analysis of the patients which are in craniopharyngioma cohort, and you can see the median age. This was the series ran from 3 years to 25 years of age. So the median was about 11 to 14 years with the skewed ratio of the male and female ratio, and you can see these are the various demographic profile. At a median follow-up of a little bit more than 5 years, but the range from anywhere between 6 months to 10 years, the survival was very, very gratifying. It was 98%. We did had overall of 6 recurrences out of which, yielding a disease-free survival of about 92 to 93%. And 3 out of them we could salvage further with the subsequent therapy, mainly with surgery. And so overall survival was encouraging. Is an Indian cohort of patients yielding about more than 98%. We did have our share of neuroendocrine function, but as you can see, it was significantly lesser in the high precision stereotactic conformal radiotherapy arm as compared to the conventional arm. We ran, again, a relatively simple battery, which was relatively easy to practice in clinical practice, which included a different neurocognitive and neuropsychological domains. We also, many years ago, tried to show the correlation of the importance of the reduction of the doses to the temporal lobes, especially on the left side, and yielded perhaps for the first time in the world the dose constraint as to how much you should not exceed the tolerance of doses to the left temporal lobe such that you can preserve the neurocognition. Increasingly in the last decade or so, we have realized the importance of hippocampi as to be the seat of cognition as well as memory in adults. And again, we try to correlate what are the dose constraints to this. This happens to be among the largest series which has a detailed baseline and 5-year cognitive database, again, yielding from the prospective series that I showed you. And we drew the hippocampi retrospectively and tried to correlate the patients on a logistic regression model as to how many had neurocognitive decline and those who did not, and try to see on a multivariate analysis which are the possible factors. This paper was published a year ago, and essentially what it showed was that craniopharyngioma among the histologies, and this is based on all the patients on the trial, but as I showed you, a vast majority were craniopharyngiomas. They did worse than other tumors, but most importantly, it seems we stumbled upon a kind of a dose constraint on a fractionated schedule, that if you do not exceed the mean doses of radiation to the left hippocampus more than 30 gray, especially in young patients, this possibly could be used in inverse planning systems on the radiation technology, such that you put it to the computer that you do not exceed the left hippocampus dose to more than 30 gray. It will try to yield a plan which will, what is called dose conformal avoidance to the left hippocampus, and yet yield the possible doses to the tumor such that you have an effective local tumor control. As has been mentioned again, because of the location and because of the morbidity of the treatment, basically from surgery as well as radiation, the endocrine late effects are an extremely important component, and we have realized both from the growth hormone, the GI, the thyroid, and the cortisol axis all are affected. In the main randomized trial, we could demonstrate the stereotactic radiotherapy was superior in terms of preservation of the endocrine deficit as compared to the conventional arm, but we also tried to correlate this again on a logistic regression, almost akin to what we have done for the left hippocampus, to try to come out with a dose constraint, because this data was lacking in the literature as to how much dose we should not exceed such that there is no deterioration of the cognition endocrine. And based on this data, we found out that 27 gray was the mean dose. It's actually D50, which is slightly different than mean, but more or less the same, was the cutoff point. Now, unfortunately, however, in craniopharyngioma, this is overall childhood brain tumors, but in craniopharyngiomas, unfortunately, we cannot preserve less than 27 gray, but most likely the hypothalamic pituitary axis, which comes within the clinical target volume. But nevertheless, this is the data that we came from. But we also, I will show you now then how the particle beam therapy makes a little bit of difference in this scenario. And all of us know the unique characteristics of protons, because now we have the proton facility in our country as well. And the second facility is going to come very soon in Mumbai as well. And the present one is in Chennai. We know the technology of proton, that at the Bragg peak that you can literally reduce the doses to literally zero beyond the tumor. And that is the beauty of the proton. However, within the proton world also, there has been a tremendous amount of evolution. We do not now use what was originally called the passive technology, where you had to double scattering, and there were several limitations the way we used to deliver the protons, and it was also quite cumbersome, and we could not do it on a routine basis. The modern proton beam therapy is what is called image guided. And the advantage of the image guidance is that you break the proton beam into very tiny spots of few millimeters. It's already 3 to 4 millimeter spots, and they can actually by spot, line by line, layer by layer, They can, with the help of Monte Carlo algorithms, and we also have an inbuilt CT scanner such that you can highly precisely deliver the beam on a daily basis. Therefore, it is called. So therefore, it's very important within the proton world to discern the different technologies of protons. So the modern proton is what is called image-guided pencil beam technology, which yields to IMPT, intensity modulated proton therapy, and you can really sculpt the doses as whatever you may want to, akin to what is IMRT, the intensity modulated therapy in the photon or the X-ray world. And that has been demonstrated in various series in the proton therapy as well, both in terms of different combination with surgery in different series. And you can see anywhere between 80 to 100% 5-year data emerging. There is not too much 10-year survival, and we are all conscious of craniopharyngiomas not being cut off at 5 years. We really have to wait for 10 to 20 years data. But so far, whatever data is available between 5 to 7 years, they all look encouraging. And another advantage, of course, of protons is the uniqueness of significant reduction of second cancers, which also sometimes can be a problem in all childhood brain tumors and also in craniopharyngiomas, where they have a very high expectancy of survivorship when they need radiation. This was the preliminary experience of treating children that we have put together and was published a few months ago in the JACE Journal of Clinical Oncology's Global Oncology Journal, and also included few patients of craniopharyngiomas. And that you can see they have usually the solid cystic component. Many of them have had one surgery, but sometimes they have had number of surgeries as well. But they were all fit for focal conformal radiation therapy. And this was one of the first child, actually, it was Dr. Dev Pujari's a child who he had operated upon. We were observing this child, and eventually when the proton beam came available, then he was irradiated and went on to become the first child in our country. We also have a high precision photon technology of helical tomotherapy in our center, and frequently we would run a photon plan as compared to the proton plan. And as you can readily see, that what a tremendous amount of dose distribution, conformal dose distribution you can achieve with the pencil beam, the IMPT technology. In particular, if I may draw your attention to the hippocampus here, which we can spare quite nicely with the proton, which we could not spare with the photon, even if it is a low to moderate doses. And we ran different plans, and in particular, as I mentioned, 30 gray was the mean dose, but here we could achieve only 5 gray. This is 546 centigrade, which is 5 gray, and the cutoff is actually 3000 centigrade, in other words, 30 gray. And so we could achieve a very nice dose distribution for this patient. There are several things, though, we have to be a little bit careful in the proton therapy because of the positive charge that they have as compared to the photon, which is just X-ray. So any change in density while treating with the proton can cause dose perturbation, and you have to be really sometimes literally you have a sleepless night occasionally, because if there is any change in the cyst, or if there is any change in any density within the path of the proton beam. Fortunately, you need only 2 or 3 beams in photon as compared to IMRT, or as compared to while the radiation is going, for example, even like a gamma knife in a radiosurgery plan. So it is just few beams, but you have to try what is called class solutions. You try to put the beam such that you try to avoid, for example, a shunt or an Ommaya reservoir. And even if you have, then we have to always get the density. We have to put it in our treatment planning algorithm. We usually, as I mentioned, we now run all proton plans with not only the Monte Carlo optimization, but also Monte Carlo calculation. So once you have the density, then you can, get away with it. But this is a very, very important point during the proton beam therapy, which was not so important in the photon therapy. Also, as was mentioned again, there is a percentage of patients which can have a change in the cystic component during the radiation therapy. This was seen in the photon world as well. I have to say, over a period of time, this phenomena seems to be a little bit less as compared to, say, for example, 20 years ago or 25 years ago when I started my work in this field. And partly it could be that maybe better surgery, or maybe the patients are being sent very early, and sometimes second resection rather than large tumor that were being sent to us with very large amount of cystic component as well. But nevertheless, this is an extremely important point. About 5% to 14% of the patients, and sometimes even more, in the radiation and after the radiation therapy can have this transient inflammatory response and cystic change. And in our small, relatively modest series, we have also seen at least one case where there was, if you can notice, this was the planning MR. We do a quality assurance MRI at least 4 to 5 times during the 5 to 6 weeks treatment. So every 10 days we do an MRI because that is very important and incorporate in the planning systems. And frequently we have to involve our neuroradiologist and also sometimes our neurosurgical colleagues because they will tell us where the tumor was. And you can see there's a mild increase in the cyst here, but also occasionally we see a decrease in the cyst. For example, here there was the cystic component. After 20 fractions of IMPT, there was actually a reduction. And this can again change the plan a little bit because the proton is so much dependent upon the density. And this was the point I wanted to highlight because many of your patients may go for proton. So it is always a good way to have the share the dialogue radiation oncology colleagues, like we did for the photon world when the cystic changes were there. So it is a little bit more important, and we frequently in about 60 to 70% of our patients, sometimes we may have to change or what we call adaptive radiation planning that we have to incorporate. But nevertheless, I have to say that proton is one of the finest technologies because these patients do live long. It is absolutely critical to spare every single bit of normal tissue. And it is imperative we give the finest technology. And so therefore, several centers throughout the world, and this is just an example, but same is with the Children's Oncology Group in the US. There are several children's group and the neurosurgical and neuro-oncology groups in Europe and different parts of the world. They have completely switched over from photon to proton. This is just a list of pediatric tumors where there is, depending upon the availability of the evidence as to how many patients could be possibly shifted from photon to protons. And I'll just give an example. For example, still the high-grade gliomas, which also includes the diffuse midline gliomas, still, most of the patients are treated with photon. But as you can see, and chordoma, of course, is again a classic indication for proton. But again, now you can see craniopharyngioma and medulloblastomas, and also the optic pathway glioma. They are now a unique indication for proton. Whatever it takes, we must try to give them the proton, and we should try to do it in our country as well. And finally, it is absolutely critical not only to look at the temporal lobes, the optic pathway, the brainstem, the hippocampi. There is also increasing focus because a percentage of the patients may end up having a risk of cerebrovascular accidents in the middle cerebellar territory and the circle of Willis. And there is an increasing attention that this could also be possibly dose avoidance or conformal avoidance structure as to the vasculature, because some of these patients, as a late-term survivorship, we know there is a 3.5 to 4 times relative risk, increased risk of developing a cerebrovascular accident after this technology. So after the radiation, so this has to be borne in mind as well. So therefore, whenever we do any new intervention, whether it is surgery, whether it is chemotherapy, whether it is anything, same with radiation, you must have a clinically relevant endpoint, and the trial and the studies must have a statistical power to really gauge the benefit of the new intervention. So the medical endpoints of cognition, endocrine, stroke, vascular events, second medical neoplasms, growth of the child, psychological and psychiatric issues, very well known. But I must compliment again the St. Jude's, where Tom Merchant, along with Dr. Boop and others, they are running a clinical trial where they are not only looking at PFS and OS using the intensity modulated proton therapy, but they are also looking as an endpoint, as a necrosis and clinically significant vasculopathy and any permanent neurological condition or deficit. And this is amazing to my mind because these are all late-term effects, and this is what we need as a collaborative work. And this is again a compliment to the WFNS, particularly to the group which has organized this unbelievable, incredible meeting, that if we can put our hands together, whether it is surgical or radiation or whatever you may call it, and try with our colleagues, try to get this kind of data, and that would be awesome to really learn and to help our patients. And I go on to even provoke my colleagues to even further that it's not only just the medical endpoints or clinically late-term effects of vasculopathy and necrosis, but also perhaps social endpoints, that what is the probability of the craniopharyngioma child to be employed properly? What is the probability of having financial and social independence and long-term stability? And what is the probability of having a personal relationship And if we can do it right at the beginning when the child or any patient comes to us, and craniopharyngioma is a great example, I think in a prospective database, in a collaborative spirit, I probably think that is the way to go. In the end, I'd like to acknowledge all the patients and families who have contributed whatever data I have shown, all the members of neuro-oncology, both at the Tata Hospital and now at the Apollo Proton Cancer Center in Chennai. Huge gratitude to my neurosurgical colleagues, in particular from Tata Hospital, KEM Hospital, Dr. Goyal's group, Dr. Dev Pujari's group at Bombay Hospital, Dr. Vernon Vallos from JJ, and my colleagues here in Apollo, and all the other players that have helped us over a period of time to collect this data. And again, thank you all, and thank you organizing committee for giving me this opportunity to participate in this August gathering. Thank you.
Thank you, Dr. Rakesh, for that excellent presentation. We shall now move on to our next speaker, Dr. Manjul Tripathi, who's an associate professor, and he mostly specializes in gamma knife functional neurosurgery. He has also done fellowships, and his specialization is in functional neurosurgery, gamma knife, and neuro-oncology and neurotrauma. Over to you, Dr. Manjul.
Thank you, sir. Thank you for this wonderful introduction. And I'm sincerely thankful to the WFNS committee and especially to Professor Dev Pujari, sir, for providing me this opportunity to speak on the role of the stereotactic radiosurgery for the craniopharyngioma, which I believe that still is a Bayesian viewpoint. We have just heard leaders of this field, and I think we share the same kind of the frustration. So these are my disclaimers, and I'm sincerely thankful to my team members, Aman Sonik and Dr. Sandeep Mohindra. Interestingly, it was one of the first disorders for which I was asked to do a bedside as a naive neurosurgery resident. What I can summarize about the impression that I had on that long night, and which has not changed so far, is that it's a challenging and a mostly frustrating disease. Ironically, it's a benign disorder, but it's a wolf in the sheep's skin. I do not deny that the complete resection is a reasonable goal. I am a micro neurosurgeon, basically, so that's still true. But I also believe that it should be elegant, safe, without creating a deficit. If you went with plan for a gross total resection, have a residue, go again and resect the remaining if feasible, but not at the cost of giving the complications, as Dr. Boop told in the earlier meetings. The complete resection comes at a cost of visual deterioration in 19 to 35%, a serious endocrine dysfunction in majority of the patients. And the Prasad et al. Reviewed the surgical series of 28 years and found that only 35.5% could achieve a radical resection. And out of these, the tumor recurred in around 50% of these patients. Now we believe, which Dr. Jalali just told, that we should follow the middle path, subtotal resection followed by the postoperative radiation. That's a better management option. The goals of the strategy are initial surgery for the pathological conformation, surgical decompression. Long-term goal is improved neurocognitive, visual, and endocrine outcome coupled with the tumor control. And the smaller tumor volume improves long-term tumor control after radiosurgery. So the bottom line is to do maximum safe resection followed by the radiation. And often we follow the multimodal management to achieve the best treatment outcome in the different domains. But the literature is still short on the predictive markers. I am still looking for that eureka moment. The presence of the large chunky calcifications may indicate an inner tissue and may not warrant any further treatment. Despite its sometimes worrisome appearance of the large calcified, they just follow a very benign course. The biological behavior of the craniopharyngiomas varies from patient to patient. While some remain stable, others grow during an erratic period of time. Molecular behavior of these tumors may help guide adoption of the strategies based on the genetic profiling, as has been told by the previous speakers. But the long-term results of the gamma knife radiosurgery, which we have since 1960s, 70s now, which show that the tumor control rate, the progression-free survival, that can be achieved in around 65 to 95% of these patients. And in a systematic review, the Yang and colleague, they have found that although the gross total resection provided better tumor control in the long term than the subtotal resection alone, but there was no difference in the overall survival between patients who underwent gross total resection and patients who underwent subtotal resection followed by the radiation therapy. Menity et al. Reviewed the 8 published studies to evaluate the radiosurgery outcome in patients with the craniopharyngoma, and at a median follow-up of around 57 patients in 57 months in 252 patients, they reported a progression-free survival of 69%. With a 20-year experience of 135 patients with a median tumor volume of 5.5 cc and a marginal dose of 12 gray, The new hormonal deficits developed only in 8%. Progression-free survival was found 44% at 10 years, and the overall 10-year survival was 84%. The Nagoya group treated 98 patients with a mean tumor volume of 3.5 cc with a mean marginal dose of 11.5. Tumor control was achieved in 80% with a complete response in 19%. The complications, there were some, majority were the endocrine in 6% of these patients. As you can see, there was a tumor and it showed a beautiful reduction in some time. The same group updated their recommendations, and they, with the further 29 patients with a follow-up of 91 months, they told that the tumor dose of 11 to 12 gray was a good buy, with a complete response in 69% and 90% of the tumor control, with no new hormonal deficit in those patients. So despite so much of the literature, the prognostic factors pertaining to the progression-free survival remain poorly understood. And on this multivariate analysis, they could find that the factors which were actually significant were tumor volume at the time of radiosurgery less than or equal to 1.6 cc, absence of the visual field defect, and the marginal dose prescription more than 14.5 gray. With respect to the pituitary function, the response of gamma knife had been found pretty effective. There was no new onset hormonal deficit in more than 6 to 8% of the patients. The worsening was found only when you couldn't separate the pituitary stalk and there was more than 12 gray doses used and it was spilling over the pituitary stalk. If the patient was hormonal beforehand, then it would remain unchanged. This was a good study from India, which found that in the long term, there was a good endocrine outcome and the visual deficit was found in the later series when the tumor actually showed a long-term failure in those cases. There is a share of complication with a morbidity of 4%, mortality of 0.5%, and this is dependent on the patient's age, size, and the radiation doses. Tumor progression after gamma knife is a function of the enlargement of the cyst rather than the solid component, so that was another problem. And there are some practical questions with the gamma knife radiosurgery for these patients. When to apply, as Dr. Jalali just told, the radiation shouldn't be used as a primary treatment, and it can be used as a secondary treatment following a subtotal resection, following a cyst aspiration to the wall, following just a biopsy, or sometimes as a salvage in the recurrent diseases. There is a very little literature available on the natural history of a recurrent or a residual craniopharyngioma. A radiographic gross total resection in different series has been achieved in around 16 to 100% of the patients. And within 2 to 3 years, 35% of these patients after the primary surgery, they have shown a recurrent lesion. 80% of these patients needed a hormone supplementation because of the initial insults from the surgery or from the disease itself. So what if I have a residue? Because the subtotal resection, when you do, it results in the progression rate of 55 to 85%, and that happens in a very short period of time. That happens within few months to a few years. And the addition of the post-op radiotherapy can reduce the recurrence rate to 15 to 20%. There is no phase 3 data available over it. The Regine et al. Reported 78% survival rate at 20 years in children treated at the time of first diagnosis, as opposed to 25% of the patients which were treated at the time of the recurrence. However, this could not be observed in the adult subgroup, and in fact, several studies found no difference in the local control reported in the pediatric patients directly after the neurosurgical intervention after the primary diagnosis, as opposed to the patients who were treated when the tumor showed a recurrence on the follow-up imaging. So the recurrence rate after subtotal resection varies from 30 to 100% with an average of 65%, but if you add an SRS, it reduces to around 17%. Mazda et al. Published a beautiful paper in the long-term history, and they found that nearly 19% of the patients have no recurrence even at the 18-year follow-up. So I do not know which patient should receive it or which shouldn't if they just come with a single MRI after the surgery. So there is no predictive marker. The progression occurs early after STR within the months to few years. So I just get a 6-monthly MRI in those patients. Now, again, the question. There is one scenario when we attempted the gross total resection but resulted only in STR. So if the surgeon thinks that the gross total resection can be achieved again, it can be done. Yes, it can be done, but the chances of the complications again increases. I simply agree with the Rick Boop's opinion that we should avoid multiple procedures in these patients. And the subtotal resection followed by the SRS provides a superior endocrine outcome, and that has been proven in multiple of the studies, including this beautiful study by the Gopalan et al. And the Persa et al. So relatively modern series show effective salvage of the patients with the recurring disease, and it appears that the use of SRS at the time of recurrence or progression yields local control rates similar to those achieved when the SRS is used in the early, that is 1 to 3 months post-operative. Furthermore, overall survival remains high, that is 85 to 100% in the salvage groups, which show an increase in the tumor at the recurrent follow-up. And given a median time of progression of only 12 months in patients with the subtotal resection, there may not be any advantage gained with this approach, except for the young children who may benefit from a delay that allows further brain development. And these children should be followed closely with them are emerging and treated with SRS at the first sign of the radiographic progression. The rest of the parameters remain same, whether you give early or you give at the time of increase in the tumor volume. The cost of the delayed salvage therapy is the increased risk of the endocrinopathy and probably an increased risk of the radiation-induced optic neuropathy, because probably the lesion at the time of the progression when you give the radiosurgery later on has increased in size. It might be nearer to the optic apparatus or nearer to the hypothalamic pituitary axis. And in those cases, the chances of the collateral damage actually increase. The typical response to the radiosurgery is an initial progressive loss of the central enhancement, then the cystic changes, and finally the tumor regression. The question of how much dose is actually sufficient, there is no definite consensus over it. The mean radiation dose is 12 gray. The range has in the reported literature is 8 to 25 gray. The limitations are optic apparatus and the hypothalamic pituitary axis, because the optic apparatus in a single session should not be exposed to more than 8 gray of the radiation. It also depends on the consistency of the tumor. In the solid tumors, the long-term tumor control and the progression-free survival is 90%. With a mixed tumor, this has gone a little wrong. For the cystic tumors, it's 60%, and for the mixed, it's an 88%. The tumor control was found good in the tumors when the radiation given was more than 12 gray. If you have used less than 6 gray, which has been used in some of the literature because of the large size or because of the constraint of the optic apparatus, 85% patients recurred. So to show the effect of the dose, I can just give you two examples. Like the Pittsburgh group, they used a mean marginal dose of 16.4 gray, showing a progression-free survival of 80% with a complete resolution in 40%. They had a cyst enlargement in their cystic craniopharyngioma cohort of the 30%. Compared to this, Bordeaux-Lippitt's group gave 5 gray. So it was it was a significantly less progression-free survival of 36% with a complete resolution only in 23%. Ironically, they had high recurrence and high visual deficit also. The reason because they treated a tumor volume of 8 cc and above. So that was a relatively large tumor volume which they treated. Sometimes we just get a solid remnant like this one. And this becomes a tough call because it's a completely solid one. They are usually considered to be benign. And most of the literature suggests that we should just wait and watch and give a radiosurgery only when the tumor is progressing in size. If I have a cystic remnant, then I have to look what kind of a cyst is it? Is it predominantly solid, some cystic, or is it a mixed solid and cystic? Or if it is a completely cystic tumor. If it is a completely cystic tumor, it's a real challenge, as just in this particular session, we found that there is no consensus opinion and there is significant frustration in the treatment with the different options. These options can be given as a standalone treatment or as a concurrent therapy. The literature is not sure over it, and there is no definite answer to this question. As the response to the radiosurgery for solid versus cystic, the UPMC experience of the Pittsburgh group, they have found 46 patients with a tumor volume of 0.07 to 8 cc with a dose of 13 gray as a mean marginal dose. The solid tumors again had a very good response, while the cystic tumors had only 68% tumor volume reduction. Especially it becomes difficult with the larger and multicystic tumor. They have less satisfactory outcome with the radiosurgery. And the tumor progression post GKRS is often related to the further enlargement of the cystic component rather than the solid part. Does it make a difference if it is an adamantinomatous or a papillary? No literature evidence over it, but probably a less cystic one should give a better response. That's an indirect evidence. My patient has a residual lesion near the optic apparatus. What should I prefer, SRS or SRT? Well, with the hypofractionated SRS, with the current frameless gamma knife, with the Icon machine, we can give it in 5 fractions. So the radiation exposure to the optic apparatus would be less. And definitely we have other machines like Proton, Dr. Rakesh Jalali just told, and in those cases, we can take care of these patients with a high precision also. So there has been a comparative analysis of SRS versus SRT, and Lexel SRS is associated with the fewer complications when compared to the other treatment modalities. Most radiosurgery series report a lesser rate of new hormone deficiencies compared to the fractionated radiation therapy, which has been largely abandoned since 2000 because of the late neurocognitive dysfunction. Adjuvant SRS also helps patients avoid the immediate complications of the attempted gross total resection. A favorable quality of life outcome was most frequently demonstrated in patients who had tumor regression after radiosurgery, and the radiosurgery was most effective for the smaller tumors and those with a complete radiosurgical coverage. An important issue which, as a clinician, not only as a surgeon, we have to follow is that these patients should have a good quality of life. So the Pepys circuit, hippocampus, and the temporal lobes, they shouldn't be exposed to the radiation, and that's why we have to choose our radiosurgery machine in a way so that those areas are preserved and the life should be the worth living. Which is a better knife? Well, practically, whatever the knife your hospital has a better knife, because the literature is not showing any very great difference over the overall survival and the progression-free survival. Yes, there is difference in the endocrine outcome, hormonal outcome, and the neurocognitive outcome. So the proton and the photon, this debate is going on for a very long time. There is a significant body of literature now with a long-term series with the radiosurgery, and now with nearly around 2 decades experience with the proton, which is coming very significantly. But this article published in 2014 in that journal, there was no difference in the overall survival, and there was no difference in the toxicity profile. So what we follow, we just follow this approach similar to the John Varlotto, and primarily with the surgery with the maximum safe resection, followed by the radiation therapy. My experience with craniopharyngioma is limited to the 16 patients so far, and the progression-free survival in the patients which we could follow beyond 5 years, it was 76%. The combination therapies of the BRAF inhibitors, either as a standalone or with SRS as a concurrent therapy, the literature is not sure over it, because the earlier literature with the BRAF inhibitors was for the melanoma, and they used to withhold the SRS for a day to prevent the chances of the radiation toxicity. Would it be similar in a case of craniopharyngioma or not? The literature is yet to come up over it. So in conclusion, craniopharyngioma is a challenge in true sense, and because you need a holistic treatment for the patients, not just a good resection in this. Even a subtotal resection is acceptable if the patient remains satisfied in other domains. What remains important to monitor is tumor control, hormonal control, neuropsychiatric control, sexual well-being, and behavioral growth. And frequently, one or the other domain is compromised if you are overzealous on just a surgical front. Thank you very much.
Thank you, Dr. Manjul, for that wonderful presentation. So I think we have come to the last speaker, and we can have 2 or 3 questions if anybody from the panel wants to comment or ask a question. I think one question was asked by the audience, and Dr. Jalali has already answered it, if I'm not mistaken. I could start with a question for Dr. Tamburini. What is the average cost which is involved in interferon therapy?
So actually, alpha interferon, yeah, the alpha interferon 2A is not that expensive drug, at least in Western world. So I think absolutely transferable to other contexts. I would say that every cycle in mean would cost around 100 euros. So this is the cost that has been calculated for each cycle.
In our country also, it is fairly cheap, Vernon. It's available across the counter on a prescription, of course. And I think one cycle does not cost more than 8 to 10,000 rupees.
Can I ask the cost of craniopharyngioma treatment by proton from Dr. Jalali?
The cost of proton therapy, as you know, it's a new machine and technology is high. So currently the cost ranges between 20 lakhs to 30 lakhs in our center, depending upon different patients. The cost may come down over a period of time. And as you know, there are at least one more center. Tata Memorial will soon have proton as well by the end of the year or maybe next year. And hopefully some of the patients can have a better cost benefit ratio there, in terms of the spending.
Dr. Tejpal here to tell us the prospective cost which they're going to charge in Tata Memorial. Is Tejpal?
I have one short question.
Yes.
When we have a child with a recurrent craniopharyngioma, so the recommendation is now to have proton beam radiation. Is this correct?
If they are suitable for radiation, you should probably go for the most conformal and which happens to be the modern proton, which is the pencil beam IMPT technology. Yes, that's correct.
Okay.
So I think if there are no more questions, thank you. Thanks to all the speakers and all the audience for this wonderful session. And we shall now end the session. Thank you, Dr. Dev Pujari, and congratulations on a symposium well organized.
Thanks, Vernon, and thanks all the speakers and moderators. And we move on to the last session. We have still some very good lectures. So looking forward to that. Vikram, please.
Yeah, let me introduce the for the last session. We have Dr. Germanwala, who's an associate professor and program director, residency program director at Chicago. Dr. Sharat Chandra, Professor Sharat Chandra, professor of neurosurgery at the All India Institute of Medical Sciences. Professor N.K. Venkatramana from Bangalore, who has a varied interest, and endoscopic surgery is one of his forte. And Professor Ruli Dalan from Indonesia. May I request you to please conduct the session.
Can everybody hear me okay?
Yes, you are audible.
Perfect. Well, good morning, good afternoon to some, good evening to our colleagues in India. I'd like to start by thanking Dr. Deo Pujari, along with Dr. Shroff and Dr. Karmarkar, really in the WFNS leadership for the opportunity to share in this great event today. It's very nice to see so many friends. When Dr. Deo Pujari asked me to speak on skull-base reconstruction, I was a bit taken aback. Although this is something I utilize every day, we are increasingly subspecialized. I'm very fortunate to have such a good team here at Loyola Chicago. I'm lucky to have an ENT partner, Dr. Chirag Patel, who really does our approaches, which keeps my hands fresh for the dural opening and the tumor resection. And Dr. Patel also does the reconstruction after my hands are spent. So I thought it would be most appropriate to involve him in the presentation and really appreciate the WFNS understanding for that subspecialization. So I'd like to introduce my partner, Dr. Chirag Patel.
All right. Can everyone see my slides and hear me okay?
Yep.
Great. All right. Thank you, Anand, for the introduction. Sincere thank you to the WFNS and the program committee for allowing me to be a part of this incredible program. As Anand mentioned, my name is Chirag Patel. I'm an ENT. I did my skull-base training at Pittsburgh about 5 years ago, and then was fortunate to join Anand at Loyola, which is just outside of Chicago, where we built a pretty nice skull-base practice. Every practice is different, but as Anand said, in our practice, I do the majority of the reconstruction, and so that's why we're kind of doing this together. So today I'm going to try and talk about some of the newer frontiers in skull-base reconstruction. This is a bit of a challenging talk. I mean, there hasn't been a tremendous amount of what I would consider groundbreaking work in this area, but there are some newer things. So I'll go over kind of where we are, what's new, and where I think we might be going. Before going too far, again, this is what I know and what I learned. If I missed anyone's work, please, I apologize. Please let me know. I'd love to hear what anyone's doing. And of course, if we can collaborate, that would be great too. Before we get too far into what we're going to do in the future, I think it's always important to remember where we come from. It's important to keep in mind those fundamental concepts, the core understanding we have on reconstructive techniques, so that we don't get too far ahead of ourselves and repeat mistakes we might have made in the past. When we think about reconstructive, we often talk about the reconstructive ladder, which is this stepwise approach to reconstruction where you have a variety of different options to you. And you really want that whole reconstructive ladder available to you. If you only know or only have a few options, there's really only so far you'll be able to get. When we think about the reconstructive options, we think of them generally in terms of non-vascularized options and vascularized options. And how we decide which of those options we'll use is usually based on a variety of factors. In skull-base surgery, we primarily think about the CSF leak type, whether it's high flow or low flow, and the size of the defect that we have. But obviously, we have to take into account all the different patient variables as well. When we look at the body of work that's been done on this, especially initially, there are a few different things that we learn. So what do we know? Well, we know that there's no standards. There's no one way of doing it. Everyone kind of has their own preference and their own technique, but there are a few basic principles we should keep in mind. What we know so far is that smaller defects are pretty successfully closed with anything, but larger defects generally do better with vascularized repairs. High flow leaks tend to do better with vascularized repairs, but if it's small enough, you can get away with multiple layers of free grafts. I do think that the one thing we can all agree on is that being thoughtful, being careful, and being meticulous with how we do it, with the approach we use, and the materials we use will make the biggest impact on how successful you'll be. So let's talk about all the materials that we have available to us. Well, in terms of the free grafts, first in the allograft category, which is biologic tissues derived from human species, alloderm is kind of the king here. Alloderm is acellular human dermal matrix. It's been used for over 20 years, and it's been reported on in the skull-base literature, especially early on. It's been used, it's successful. There's nothing new with alloderm. The one thing we keep in mind here is that alloderm itself is not strictly FDA approved for duroplasty. In the xenograft category, we have a number of products. Xenografts being biologic tissues that are derived from non-human species. So Biodesign is one of the newer ones here. Biodesign is an extracellular matrix derived from pig small intestinal submucosa. I think this is a really nice product. I use this actually quite a bit in my practice. I think it handles well, it heals well, and it works really well for me. I really like using it. And then there's the standard kind of collagen matrix duroplasty grafts. These have been around for a while. I think most of us have probably used these. There's really nothing new here. In the fully synthetic graft category, that's where we have some of the newer materials that are available to us. NeuroPatch is actually not new. It's been around since the late 90s. It is essentially made from rubber, which is why I think it never really gained a lot of traction. In the last 5 to 6 years, there have been some newer technologies. So Redura and Serafix are these newer, fully synthetic, fully absorbable dural substitute materials that are made from electrospun nanofibers, which are made of this same material that comes from kind of absorbable suture. And then there's also this product called Synthacell. Synthacell is sheets of cellulose, and they're bioengineered by bacteria. All of these have been described in small case series. They've all been used successfully without any major concerns. But again, there's nothing here that has revolutionized or we suspect will dramatically change how we approach reconstruction. By and large, autologous grafts or the patient's own tissue is the most popular graft material to use, with fat and fascia lata being the most favorite. Rhinologists like myself really like to use mucosa when we can. I think it heals well. It speeds up the healing process in the nose. Cartilage and bone isn't used as much now, but certainly can have its role in certain situations. And muscle isn't really used much for dural reconstruction, but can come in handy for vascular injuries. We all know that you can't just take your grafts and put them up without knowing, anything or just hoping that they'll work. You should apply a meticulous technique. Again, there haven't been a tremendous amount of reports on new techniques on how we can be more successful. There have been a few things in the past, which I thought I would touch on. There's the idea of the gasket seal, which is basically you put your grafts and wedge them into the defect using some kind of rigid material. This has been, used in certain programs. There's also this idea of the bilayer button. This was out of the Jefferson group with Dr. Evans. They found early on in their series that the leaks that they did have seemed to be coming from graft migration. So they came up with this idea to suture 2 layers of graft material, typically fascia lata, together so that you can put one layer inside and one on the outside, and this kind of prevents that graft migration. And this has worked really well for many programs as well. Something that I personally, I really like this. I have not seen this reported much in the literature, so I don't know how many people are using this or how widely it's employed, but I really like this, especially for defects where you know, it's a large defect, it's a revision case, there's not a good intranasal flap maybe to use, and I think this can be really helpful. So this dermal fat graft is this idea, and it's not new to reconstruction. It's been used for soft tissue defects, especially in ophthalmology. You harvest the dermis and the fat together as a single unit, and you de-epithelialize the dermis. The way I use it in skull-base reconstruction is, if you see the outer edge of the dermis, I kind of go around the edges about 2 to 3 millimeters from the edge, and I undermine the fat. I release the fat from the outer 2 to 3 millimeters. So you still have a single construct. You still have fat attached to dermis centrally, but you've also created this bilobed, almost bilayer structure that you can use to kind of plug the defect. So here's a case where we used it with great success. This is a 39-year-old gentleman. He's had 2 prior endonasal surgeries, 15 years in the past, and he comes to us now with obstructive hydrocephalus and this recurrence. He has virtually no nasal septum. There's a lot of scarring, a lot of doubts about what I'm going to be able to use, and I thought this might be a good case to use it. So here's a brief video of kind of the surgery. So here you can see the dural defect that we made. You can use this as a standard, I think, 8 French Fukushima suction. And towards the end, you know, we're looking at the third ventricle, which is not surprising. We expected this. So here's the dermal fat graft. You can see how the edge of the dermis and the fat are separate, but they're still connected in the middle. And so what I'm going to do here is just spend some time carefully trying to get the fat inside the dural edge, which you can see, and make sure the dermis stays on the outside. Now, I've spared you the many different iterations of taking this out and putting it back in and trimming it and finding the right size. But once you get a nice size, you'll see in a minute how nicely it can fit. And so once we get it all sized up, you see it's wedged in there really well. It's pulsatile, and you don't see any CSF leaking around this. And ideally, I would have put something else on top of this. This is not, you know, really something where I feel like I should typically just leave this. But this patient was 39, otherwise pretty healthy. And I said, you know what, I'm going to take a chance. I don't have a lot of good options. So I packed this off really nicely for about 10 days. And he's now 3 months out. And so far, he's done well. No leak, really has done great. Here's an MRI of our resection. You can see you have a nice resection. And what you can see is here, you can see the fat and then the dermis, and you can see how they're nicely attached to each other and plugging the hole. And additionally, you know, I don't have to worry about the fat migrating and this patient possibly getting some kind of fat embolus up into the third ventricle. Obviously, if we could just use free grafts and be successful all the time, that would be ideal. That would be great. But we know from previous experience that's not the case. And so at first, when we started using free grafts, we had a lot of leaks. But so in 2006, when the septal flap came around, you know, that really changed reconstruction. I think the nasal septal flap is a seminal event in endoscopic skull-base surgery. If you watch Star Trek, if you like Star Trek like I do, I think it's synonymous with like invention of warp speed, because it created this way of expanding what we can do, going beyond the cella and doing much bigger things. Right after we start using the flap, we see a dramatic drop in CSF leak rates, and that really pioneers the ability to explore other areas of the skull base endoscopically. We all know the nasoseptal flap. There's nothing new, you know, with the flap. It's you raise the septum, and if you need the floor, you take that as well. But there have been variations on the flap that have been described. So here are a few of the variations. This group described using the septal flap, the floor, but also taking the inferior turbinate mucosa off. You can leave the turbinate and the flap attached to their vascular pedicles and rotate it to where you need it. Here's another group out of the US where they harvested the septal flap with the floor, but then went over the top of the nose to take the lateral nasal wall. And you can see here they use it to reconstruct the anterior skull base as well as the orbit. Sometimes the septal flap isn't long enough. We all know that when we try to put it on the anterior skull base, especially for bigger defects that go up into the frontal sinus, it can really struggle to reach. So the group out of Albany came up with an idea to release the vascular pedicle. You can dissect into the pterygopalatine fossa. You can even dissect out the internal maxillary artery, and that can give you significant more reach with the flap. And then there's another report here where if you had an anterior unilateral skull base defect, you could use a septal flap based on its superior anterior circulation off the ethmoid artery rather than the posterior circulation, and take the contralateral septum and flip it up to cover the that skull base defect and the other orbit. But what do we do when we don't have any intranasal flaps? I mean, any septal flap? So there have been a number of local flaps that have been described. The first one was, of course, the posterior pedicled inferior turbinate flap. And then more recently, there's been a description of using the mucosa with inferior turbinate. So you can take the floor and the lateral nasal wall along with the turbinate to get more mucosa for coverage. By and large, when we don't have intranasal flaps, the pericranial flap is kind of the first thing we turn to. You can raise a pericranial flap and tunnel it into the nasal cavity through a small bony opening at the root of the nasal bones. And then you can use this extracranially, so you don't need to do a craniotomy to use the nasal septal flap, the pericranial flap. And then, of course, this is ideal for anterior skull base defects. If you need further reach, you can always back elevate the flap and get more reach out of it to get to the posterior fossa even. There have been endoscopic variations of this described where you can raise the flap endoscopically and do minimal incisions and spare the patient a bicoronal incision. And then if you don't have a nasal septal flap or a pericranial flap, Dr. Liu's group here described a case where the patient had radiation necrosis and no other options, and they used a paramedian forehead flap tunneled similar to the pericranial flap to reconstruct that anterior skull base. The temporoparietal fascia flap has also been described. It's raised and tunneled through the pterygopalatine fossa into the nasal cavity to cover the posterior fossa and the sella. It typically didn't have reach for anterior skull base applications, but recently there was a group that described this cadaveric variation where instead of tunneling the temporoparietal fascia through the pterygopalatine fossa, you tunnel it through the orbit if the patient had an orbital exoneration, or you could do a pterional craniotomy and tunnel it along the floor of the anterior cranial fossa in the epidural plane and bring it into your anterior skull base defect that way. There have been also other flaps, oral cavity flaps, which have been described. These are also not new, and these are really last-ditch efforts to find vascular tissue. These are flaps that we really never want to do. There's a lot of morbidity associated with them, so we really try to avoid these. And of course, if nothing else is working, there's always a free flap, which has also been reported with success. The one thing none of us want to experience is a dead flap. We never want to see our flap go down. We looked at this when I was a fellow, and we found that we had about a 1% rate of flap death. That usually came with patients with prior intranasal surgery and if they had surgery at an outside hospital. So, typically, right now, the main way we assess vascularity is if it enhances on MRI. This is a case of ours where you can see, the flap enhances very nicely. And so we know it's vascular. But finding out after surgery is a little bit kind of after the fact, right? Because ideally we would know this during the surgery, so we would know if we should consider other options. So the Pittsburgh group recently has been doing work with ICG fluorescence, and they looked at, can we predict flap vascularity with ICG fluorescence and correlate it with MRI? And they found that yes, indeed, you can. And so this may be a way when it becomes more broadly available to be able to do that. There's no real new things in terms of closure. We all use sealants and things to a varying degree. If you believe in them, Dr. Liu certainly published data that shows that you didn't need a sealant, but there's again nothing new here. Laser tissue welding and fibrin-rich plasma hasn't really changed the game. It's been used and it's fine. Lumbar drains are a hot topic. We still all kind of debate whether a lumbar drain is necessary. There's one prospective controlled trial from Pittsburgh which showed that the lumbar drain did, in their group, help with anterior and posterior fossa defects, but it didn't help with suprasellar defects. There was a strong significance towards postoperative leak and the size of the defect, but this is the one thing that they did find. Reducing donor site morbidity is always something we're trying to do. So recently there have been a lot of reports on ways to reduce donor site morbidity. There have been studies showing using free grafts to cover the denuded septum, and that works well. There's also reports of using the contralateral septum, you kind of release it posteriorly and fold it forward. And that also works really well. People have used fascia lata, and more recently, again, they've used Biodesign, the product I talked about before, as a graft, and showed that the Biodesign reduces crusting, it increases healing, and reduces the healing time. So where does that leave us? Well, there's a couple things, I think. I mean, coming down the pipeline right now, there's 3D printing and tissue engineering, which I think will possibly introduce new materials. There's even 3D tissue printing or bioprinting and stem cell-based bioimplants, which may provide us different and interesting technologies. I think these are more fringe technologies and coming down the pipe, not immediate. More immediately, I think surgical simulation could have a role in improving reconstruction, educating the future better, and then planning and practicing, I think, can be helpful, so that we have a chance to see, is this flap going to reach? Is it going to be big enough? What's it going to take? And I think immediately what we can do is try putting out some more high quality studies, multi-institutional data, looking at what are different people doing and what's really working, because I think that's something that's really lacking. And maybe we can come up with some guidelines or some standards. Thank you again to the committee for letting me speak.
Thanks, Chirag and Anand. And it is my pleasure now to introduce Amin Kassam. I think everybody knows him, and he's going to talk to us about preservation of neuroendocrine function during these surgeries. Please, Amin.
Thank you very much, Chandra, Moody. Great to be with you. And just before we begin, we've lost some good friends and mentors over the last few years, and just want to take a minute. I wish Heinz and Wolfgram were here with us to see what an incredible accomplishment you put together virtually in this new world, Chandra. Most of us owe our careers to both. What I'd like to do is to just walk you quickly through some guiding principles around neuroendocrine surgery. Essentially, the more proximal you are, the greater the impact, the more diffuse the clinical manifestations. So they change from neuroendocrine to cognitive. There's less vascular tolerance and neural tissue tolerance, more difficult to image, and certainly more complex to replace. The natural planes, Wolfgang used to say that the diaphragma is nothing more than a herniation of the arachnoid, and the diaphragma is the arachnoid and should stay with the patient. So it's a great tool for us. I think as we think about working trajectories here, we need to develop algorithms to work in front of, behind, under, above, and beside the gland. And what I'll try and do is to give you some practical considerations and share some articles from our past for details where you can go look at things. From the perspective of the sequence, first you have to figure out where the gland is. The anterior commissure is a great clue looking at the axial. It'll take you to the tuber, which will identify the stalk. Stalk wraps around the perimeter, and the tumor, gland, and cavernous sinus interface become important. So walking down from top down, segmentation data now really is very valuable. So there's the anterior commissure, there's the stalk wrapped around the lateral aspect, there's the tumor and the cavernous interface. The gland almost always is pasted against one cavernous sinus and or superiorly against the diaphragma. Leila, who's an outstanding fellow who spent time with me and now in Spain, did a really nice review of 30 cases pre and intraoperatively and found that 24 of them we predicted that the gland would be intact and the diaphragma would be intact, and in fact that was the case. 5 weren't, of which the 5 we predicted 3 preoperatively. 1 was actually preserved and 1 we weren't sure. So you really do have pretty high accuracy. You take a lesion like this, and this would predict that this diaphragma is not intact and the gland is located on the left side. Knowing that, you can now design a pretty stepwise approach. So your standard opening that everybody's used to, in this case, I would do an expanded opening up to the planum. Really important on these cases to get out lateral for carotid mobilization and taking down the tuberculum. But we're all used to this. So let's jump to the part that matters. When you get intradural, there's a very specific sequence that you want to follow. After I've mobilized the carotids extradurally and I open the dura. I like opening it in a horseshoe fashion, just medial to the cavernous sinus. What I'm now going to look for is the side where I know that the cavernous sinus and tumor interfaces and the gland is not. So this horseshoe opening allows me a nice access into this space. I can take out the anterior face of the dura, which just completely lets me mobilize the gland now. I'm going to start at the bottom, find the interface, and this is what I'm now looking for. The cavernous wall lined up against the carotid. Here, there's going to be some bleeding, which is great. There's the cavernous wall, and that's all tumor. I can now start to peel the tumor, starting the planes bluntly, and then sharply dissecting the adhesions. I can open a little bit above, control the bleeding below, which is not really a problem. I don't want to use the bipolar above. And what I wind up with is this interface that I really want to see, the blue of the cavernous wall, the adhesions that are tightly stuck here. This is a great instrument, which is just a Q-tip on the back of a suction to mobilize it. Now I can start to see the diaphragma. The tumor starts to rupture, so I'm a little more conscious. By the end, what I want to see is this interface, the venous engorgement above the diaphragma, and then I can start to peel the tumor away. What I now want to do is to go find the gland. I know the gland is on the opposite side, so as I come to the opposite side, I can seal the cavernous wall, and here I can start to create an interface. There's tumor and there's healthy compressed gland. Once I see this gland, I now connect the dots. I've gone around the top over to the side to about 1 o'clock, and now I connect over from the other side. And that's really the key. So in the end, what you wind up with is there's the gland isolated, just as the MR predicted, sharp dissection to preserve it. That's all gland, this is tumor. I left this interface. I know this particular one has ruptured through the diaphragma. As I see the gland overhanging in sharp dissection, I can now open the diaphragma where it's ruptured. I can now peel this down, and there's the arachnoidal component of the tumor that's risen up top. That can now come out, and there's the gland left behind. You can see how easy it would be to take that gland with the tumor, which would be devastating. So once you're done, the rest is actually pretty easy. You can go through the diaphragma, leave this gland behind, and now look suprasellar and resect this opening. And then you get the view arachnoid with the gland staying in the front, and everybody's used to that. So that's pretty straightforward. The takeaway here, start on the side where the gland is not, find the cavernous tumor interface, let the diaphragma that's compressed do your work. Blunt and sharp dissection being the key, use the microcirculation, avoid penetrating the gland, and beware of the anterior face gland. Now, as you start to get supralateral, everything changes. When you get above the cavernous sinus, the superior hypophyseal now becomes a key issue. We didn't realize this until the early 2000s. And as you start to get into the medial supralateral compartment, mobilization of the carotid now becomes the key. So this is the zone that we're really interested in. Remember, the cavernous sinus is actually a diverticuli. There's a lateral component where you don't want to be in a medial component. You can actually take the carotid, mobilize it like the book on a page, and it gives you wide opening to this medial segment. So here you can see this diaphragma is intact all around it. I'm going to be able to use the diaphragma. Even this shows lateral spillage. Knowing that the diaphragma is intact, I can use the diaphragma to peel this component back in. And the axial really shows it. There's the pituitary stalk, the diaphragma on the backside. And then this perimeter diaphragma being intact allows me to figure out how to get access. To do this, you're really going to have to go lateral. And again, Layla published this nice paper on getting lateral access using a combination of the lamina papyracea, Vidian optic canal, to transect and locate the lateral OCR and medial OCR, which becomes key. So this is the segment I'm interested in, which requires for me to mobilize the carotid. So that's what I'm going to do here. Drill down the carotid canal. The key here is for me to take the tuberculum and resect the middle clinoid. Once I do that, that supralateral compartment is accessible, but more importantly, the shelf that was holding the tumor up will now be gone so the tumor can descend. I'm using an intact diaphragma to gain access. The interdural component is just as you've seen. So here I'm going to open up the dura in that horseshoe fashion that you saw. Around it, mobilize the anterior face. I like resecting the whole dura completely because it allows me to then mobilize the gland quite freely and nicely. Now I start on that left side. There's the carotid. The carotid is a beautiful tool. It actually almost always gives you a great plane to do dissection along, right along that plane. I've not seen a direct carotid invasion very often. So there's the carotid. Now I'll walk up the carotid just along with the cavernous siphon. I can coagulate the inferior intercavernous sinus. And when I'm done, I get this view. So there's that superior component starting to descend. This is gland over here, and there's the carotid, and I've peeled the segment. At the end, what you want to see is this quadrant really opened up. There's the diaphragma. And when it descends, this is the component, because I took out the OCR, that will now descend nicely. So that supracellular component in the lateral recess starts to descend. You've used a combination of the diaphragma and the planectomy to allow that to drop without having to open the intradural dura above. So in these particular cases, despite significant supracellular extension, the diaphragma may not be disrupted, and it becomes your friend. The ICA represents a great dissection plane. I generally restrict myself to the medial compartment of the cavernous sinus in the absence of pre-existing oculomotor injury, and then really avoid crossing that plane and let the diaphragma do the work. But in order for that to happen, the bony ridges have to be removed. So now we get into that real supralateral component, the superior hypophyseal artery. The best way to find it is actually to leave the arachnoid intact, use a combination of the ICA and optic, this relationship, to go find it. So here's a typical meningioma. We're all used to seeing this planectomy and opening. And now what you'll see here is a superior hypophyseal. See the carotid here? That's the key. I'm going to use the carotid to find the distal segment in the cave, past the ring, find the superior hypophyseal, chase it to the ipsilateral optic nerve, and then really sharp dissection along it. Then I'm going to peel this forward and do everything I can to leave the arachnoid intact, because it's not the superior hypophyseal that I'm interested in here. It's actually the descending infundibular branch that leads into the stalk. And by leaving the arachnoid intact posteriorly where that stalk is, this descending infundibular branch in the racemic subchiasmatic plexus now stays intact. Do not remove this arachnoid if you can avoid it. Intercisternal papaverin is really great for that kind of bleeding that sometimes can occur. The rest of the tumor now comes out quite straightforward, and your reconstruction just follows. And here is the pituitary left behind, and then the nasoseptal flap. Even in these complex vascular lesions with encasement, the same principles follow. So what I'm now going to do, you can see that there's a significant amount of invasion posteriorly between the carotids. The opening, I can't stress enough, really needs to be wide enough, high enough, laterally enough. But in particular, if you're going to do this and protect the superior hypophyseal artery, one of the things I've learned, particularly in the last few years, is to really focus on not just a standard planectomy, but to go above the optic canal. So I'm going to lift up, completely decompress the optic nerves. But in order for me to get that superior hypophyseal, this bone has to come out. So there's the optic nerve, and the bone directly above the optic nerve in that ridge is what will get me to that superior hypophyseal. So once I open the dura, at this point, the dural opening is actually straightforward. And now I can start working within the tumor. I'm petrified of bipolar ring in this base, along the base. So I'm going to really let it bleed. It's okay. As it starts to bleed, I'm going to sharply dissect and then use the bipolar very focally. What I'm now looking for is an optic nerve. If I can find the optic carotid junction, I can find the superior hypophyseal at this point. So I can start to see the arachnoid starting to breach here, get a little glimpse of that optic nerve, that left optic nerve. So I know behind here is the superior hypophyseal. I'm going to now do the same thing on the right. By doing it on the right, what I'm now really looking for is that key component where I can start to see the vessel. Okay, so I'm going to start to really pick away at this arachnoid one cut at a time. This is obviously the most critical component of the case. And eventually I'll peel this back, find the ipsilateral A1 on the right, peel that back, and there I can see the A1. And underneath it, leaving that arachnoid, there's the first peek at the superior hypophyseal. Once I've done that, I'm going to come over to the opposite side. There's a significant chunk of tumor here buried over the A1 and the recurrent artery of Heubner. I'm going to peel that back and dissect it. Now I'm looking for the ipsilateral carotid on the left side and the carotid optical interface. These perforators need to stay with the arachnoid because the superior hypophyseal will be a similar perforator, and keeping that arachnoid intact sharply is the key. As I start to open this arachnoid, the world will start coming into view. So here is the recurrent artery of Heubner, ipsilateral A1, A2. A bit nerve-wracking right now because I still haven't seen the superior hypophyseal. As I start to peel this back and I reach underneath this ipsilateral optic nerve, that's where it'll start to show up. So we start to dissect here. And, endoscopy, unfortunately, doesn't respect hands. And you can see you have to use your left hand coming across to keep that parallel plane. Eventually, you'll start to get underneath the optic apparatus here. And now I'm just past the cave where that superior hypophyseal will be. So this is one cut at a time, looking for that arachnoid interface until I find it. Once I find the carotid, then I can breathe a sigh of relief. This is because I took that bone off that I was referring to in that supraoptic recess. And at this point, now I can relax because I can start to peel the tumor interface, and there's the stalk through the blood in the arachnoid. I can see the stalk. This particular complex is where the superior hypophyseal and the descending hypophyseal arteries will sit. This now comes out pretty easily. So one of my fellows in Pittsburgh at the time published, I guess almost 15 years ago, my first series of meningiomas. And I had one patient in whom I lost the endocrine function. That was because I bipolar at the base and I'd taken the superior hypophyseal. And since then, I've used that technique of isolating it by finding the optic carotid recess early and really focusing on that and really focusing on leaving the stalk behind. Craniopharyngiomas, they're their own beast. As we heard today, I like to think of them in their positions relative to types 1, 2, and 3. We published this in 2007, tuberculum, superior intercavernous sinus, and posterior clinoids. I want to make sure that I caution you that beware of the cystic craniopharyngioma. In general, craniopharyngiomas, you really do need to peel that middle clinoid down because you have no idea what you're going to get. That really helps me get that carotid paraclinoidal control that we talked about. When I get into cystic cranios, I actually am a little more anxious than I am on solid cranios, and you'll see why here in a minute. So this inferior component of the cyst is really quite easy to take out, right? You open it up, this component of the cyst comes out easily, almost too quickly. There's that crankcase oil that comes out. Now I get into that wall. When I get into that wall, I don't really understand the diaphragmatic attachments that I'm looking for. This is where it becomes anxious. Now I'm going more proximal up to the level of the tuber and the anterior recess of the third, start to open it up. And these are all views that we just saw. Beautiful case on up here. So what do I do about this piece? Do I grab it? Do I cut it? Looks like it's low-hanging fruit. Pretty easy. There's the anterior commissure. So this is actually the tuber cinerarium. And you'll see here in a minute, as I reflect this little piece back, it's actually the wall of the hypothalamus and the tuber. If I take this out, an endocrine disorder will be the least of my problems. And you'll see why in a minute. So in this particular case, I've chosen to leave that component because it's actually fused to the wall. And there it is, stuck completely to the wall. Here it is on the back side, and on the axial, you really see it. So trying not to be overly aggressive. The pituitary transposition we've described multiple times. Great tool to get behind the gland directly. Chandra, we actually did this with you many years ago. And the key here is to find the wall and the face of the dura, and then the pituitary ligaments, the three branches, the superior hypophyseal, McConnell's, and inferior. You can take these, but you can't take this one. So you can see here, Chandra, I think, Chandra, that's you dissecting with Nihit, and I'm watching, heckling you. I'm pretty sure I was throwing tomatoes at you. But what a beautiful dissection that Chandra is doing here. And you can see the kinds of views you get. But when you get this intradural mobilization of the pituitary, there's nothing like it. People talk about extradural hemi, all of this stuff. To me, there's nothing like an intradural mobilization to give you that space that you're looking for. So here's a large chordoma, same idea, just a couple of quick steps. Open the planum up early, but do not open the suprasellar cistern. Open the aperture quickly. That's pretty easy. And now you can locate the stalk. Now you come down and open the two planes of the dura over the pituitary and the capsule, which is what I'm doing. Once you do that, you're going to get lateral. As soon as you get lateral, you're going to make a cut and you're going to get McConnell's. So don't worry about it. Just relax. It's okay. McConnell's is pretty easy to treat, and so is the inferior hypophyseal. What you want to do is to open this dura in between the two layers. This time, don't excise the dura, but leave it as a covering on it. And what you want to see are these ligaments, and they're actually quite pretty and really quite distinct. They're the equivalent of the dentate ligaments in the spinal cord, and these can be transected quite easily. And then the gland is totally mobile. It can be lifted really quite easily and give you access to the dorsum. Once you get up to the dorsum, often the posterior clinoid in and of itself is eroded. If it's not, then you can start to drill it out. And of course, the views we're all used to seeing, where you can see the basilar and the SCA. The power of this view is this maneuver. The ability to take that gland, lift it up, attach to the superior hypophyseal, which has a long pedicle. Once you release the gland completely, and in the case of a cranial, it'll be quite stuck to the third nerve and or the PCA, and you can make those cuts. And then that gives you extraordinary supra and infracellular access, particularly for those calcified cranials, where you have to work in front of the stalk and then the views that you're used to. What was the outcome? This paper was published, gosh, I can't remember, maybe a decade or more ago. And the outcome was an 87.5% gland preservation rate after pituitary transposition. So the transposition, you pick. I do intradurals routinely. I don't like doing extradurals and hemis because I find they don't give me the space that I need. The real key here is to get into the right layer and then that shoulder osteotomy. Craniopharyngiomas, I have an algorithm. If I can clear the chiasm, I keep going. If I can't, I just pursue cytoreduction. If I can clear the stalk, the tuber, and the hypothalamus, I'll get a total. If at any one point I can't clear each of these more distal to proximal segments, I'm just going to go for cytoreduction. And I heavily started to rely now on foundation one in molecular therapy. I do believe craniopharyngiomas will become a medical disease in the future. As we start to think about craniopharyngiomas, we should not forget that craniopharyngiomas, there's also a type 4. And in the interest of time, I'll spare you this, but our type 4s we do transcranially, and we do them with the patient fully awake. And so here you can see a type 4 using a transcranial approach. This patient is completely awake, and we're doing neuropsychiatric assessment at the time. The reason I stop on this case has nothing to do with endocrine. As I get to the lateral wall, this patient starts to lose memory, and that's why I'm stopping. So remember, it's not the neuroendocrine function into these intraventricular lesions, but it's really cognitive function. In everything you do, you've got to have an algorithm in your approach. So this was a redo pituitary that somebody sent to me where they biopsied it and got pituitary tissue. Same approach that you're used to seeing. I found the cavernous wall laterally, went around the top, found out where the gland was, identified the gland on the left side. As I started to resect, what I started to see was this extraordinary arterial bleeding all of a sudden. So every instinct you have now is to pack, right? Everything you want to do is to pack the sella off, which to me is probably the worst thing that I could have done at that point. In fact, what I'm going to do now is to start resecting. I have no idea, and at that time, that what I'm dealing with is a hemangioparasitoma, intracellular. But I know that the gland is located supralateral, so I'm going to now completely resect everything I can within the confines of the sella, despite the bleeding, to create room for myself and avoid packing. In fact, what I'm looking for is pulsations. Once I resect this multifocal arterial and venous bleeding now actually becomes quite manageable. I'm going to let anesthesia catch up at this point because the patient got quite hypotensive. And then the rest of it is just standard bipolaring that you're used to, segmentalized hemostasis. And then you can work your way around the perimeter and start to seal it. The gland is located on the left side near the cavernous wall, which I left intact. I left a little cap of hemangioparasitoma that you can either come back or radiate. Finally, before we end, what I've showed you are endonasal approaches. We should not forget transcranial approaches. They're very viable in this space. Alejandro really spearheaded an excellent book that just came out. Really one of the most gifted and honorable fellows I've ever trained. And in this particular case, a tumor like this is not going to come out through the nose. It spills into the middle cerebral and into the sylvian fissure, and you really require a transorbital approach in this particular case that we're doing. And what I'm going to do now is do the same thing. I'm going to isolate the stalk, leave it behind, and then enter that supra chiasmatic space, protecting and working in front of the stalk. And then the last thing I'll show you is craniopharyngiomas don't respect any tissue planes. So in a craniopharyngioma, you do have to come laterally very often. This extends into the sylvian fissure. I can excise the cystic component. And you can see here that the solid component really is quite adherent to the optic apparatus and lateral to the carotid. So this is going to require a lot of sharp dissection to peel that away from the carotid and the ipsilateral optic. Once I get that sharp dissection out, it actually extended all the way to M1, once I've gotten this sharply separated, I get a really great view. There's the stalk at this point. There's the carotid and the short segmental perforators behind the carotid I've separated. And when I'm done, what I want to see is a view of that stalk, lamina terminalis, and I can open the third ventricle from this lateral view as you're used to. So with all of that said, you know, it's interesting. We published our transcranial approach. Lior, who's now a fellow and works in Israel, done some beautiful work. Our first 200 cases had a 1.5% major neurological complication. Interestingly, when I went back and looked at my first 800 endoscopically, it was shocking how the numbers were almost the same. It was 1.8%. And what that told me was, it doesn't really matter what tool you use. It's the technique and the judgment at the end of the day that really make our decisions in the preoperative planning. So Moody, Chandra, thank you so much. Pray for everybody's good health and look forward to seeing everybody soon.
Thanks, Amin. It was you only dissecting that that dissection which you showed. I think I was just helping, but it was really very nice. And what we could do is that the other talks are going to be addressing some other pathologies. So if there are any questions on the closure technique and endocrine preservations, we can take them right now. There's nothing in the chat box as I can see, except for one question. Is it really possible to remove the pituitary or craniopharyngioma completely? Any comments on that, Amin?
Yeah, you know, the answer is yes, it is, because they're all different, and it really comes back to its adhesion. If I can separate it from the gland as I work from bottom up, Chandra, that's how I make my decision. So then I get to the stalk, I can separate it, I'll be more aggressive. But if I'm leaving residual on the chiasm because I don't want to blind the patient, why would I transect the stalk at that point? So it's a very algorithmic approach. Craniopharyngiomas are distinct diseases. They're not all the same. So I do believe it is possible.
Any other questions, Venkat?
Yeah, I mean, it's wonderful exercisecal techniques, really impressive. I'm only concerned about the mobilization of the carotid. How much you will try to mobilize? What is the technical point at which you will stop, decide not to go further when you are mobilizing the carotid?
You know, it's true, right? I as many of you know, I really believe in it because I like reading the book with the pages open. I don't like reading the book with the pages closed, and that's what the carotid represents to me. I've done it for 21 years consistently around it, so I do it on every macro, but I also do it on every micro as well, because you get into a Cushing's case, you do need that mobility to get that dissection, so you're not blindly. The line that I use is that a line from the Vidian canal drawn straight up to the posterior ethmoidal artery. That's about how much the carotid can move. That keeps me in the medial compartment. I'm not saying everybody should do it. It's just the way I've done it. My personal series in, I guess now almost a couple of thousand cases, is I've had 3 carotid injuries over 20 years in total.
One question I had for Anand and Chirag is that you talked about various ways of skull-base reconstruction. Many a times we remove a large tumor, and though we do not get any CSF, there is a large cavity. Is there any point in doing any kind of reconstruction in such cases? And is there, I mean, I think there are some reports that there could still be some CSF leak, which you did not observe at the time of surgery. So what special precautions you take in such patients?
So that's something that we do some sort of reconstruction on, Dr. Deopujari. That's a great question. You know, many times, as you alluded to, even if you don't see a CSF leak, there can be some sort of microscopic leakage. The other thing is it makes me a little bit nervous if there's no reconstruction. You know, if the patient is involved in a head trauma or sneezes really hard, you can get a leak of CSF. So we typically will put some sort of avascular graft at that point and really reserve vascularized tissue if there is an obvious large CSF leak and a high flow leak. So it really depends on what we see at the time of surgery. Chirag, you have anything to add?
Do you have any comments on this?
Yeah, Chandra, two things. One, I'd just like to caution people on Aladerm. Shirag, I know you talked about that. I've not used it for 16 years. It's an acellular dermis. I find experience with it is really scary, fungal infections in particular, and can really colonize. So I really encourage people to avoid Aladerm in general. Loved your idea of fascia and hybrid dermis graft. I'm older than you are. This is how we reconstructed open skull base all the time. One other thing I would point out is anything you put in intracellular, remember what layer you're reconstructing. You're reconstructing arachnoid. That's the goal. So really using a biosynthetic is a great way to reconstruct arachnoid. The next layer is dura, mucosal graft as you wish. I'm a flat person, and those 30% leak rates and 40% leak rate you pointed out, that was time away from my kids. For the first 10 years, I was in, 4 out of 10 times after I did the first case. The flap really changed that, so I'm very generous with the flap from that perspective. I do think that if you open the arachnoid, there is a leak by definition. There's no question around it. You may have drained the patient. You don't see it, it's visible at the time. To Anand's point, you're just going to wait for them to Valsalva. I think you're obligated to repair it at that point. And the last thing you pointed out, which I think the future will be, I think all of the fat that we use is a biological dressing and a tremendous source of stem cells, as you know. So I think by putting fat on, you're actually promoting your 14-day recovery as stem cell. Big believer in plasma-rich platelets as well.
Yeah.
Andre, any comments? I think Ashish wants to say something.
Yes.
Chirag, you have something to say?
Yeah. The question to, I mean, great talk. I really enjoyed it. The question is, how often do you need to mobilize the pituitary gland the way you did? That looks very fantastic, I know. And what are the sort of shortcomings you had after the mobilization of the pituitary gland? Just can you elaborate on that?
Yeah, not that often, Ashish. So I usually generally use it for retrodorsal interpeduncular cisternal lesions, right? Tuberosinium, mammillary body, upper midbrain, and babular apex. So not very often. Chordoma craniopharyngiomas are the most common, and meningiomas occasionally. I do them all intradurally because I think doing a hemi or an extradural, it's like tying your hands. You get the half of both, and it doesn't help. The biggest challenges that I find with it are patience because of bleeding. And it's actually not the cavernous sinus, it's actually the venous gulf, where the superior intracavernous sinus and inferior intracavernous sinus meet the basilar plexus. And that just, you need to pack it for 15 minutes and go have a cup of coffee and then come back. Gland preservation, as I showed you, is 87.5%. So bottom line is it's rare. Very few of my fellows have actually gone on to do true intradural mobilization, which means that it's probably not a generalizable procedure after 10 years. But I use it.
You don't believe?
A comment by Chirag before we go to the next speaker. Chirag,
yes, I'm sorry I had to step away. I'm on call right now, so you never know what comes up. All points well taken. I agree with Dr. Kassam wholeheartedly. You really have to be thoughtful about everything. Our general protocol is actually to use some kind of collagen-based matrix as arachnoid reconstruction. I like biodesign for dural reconstruction, and generally, if I agree, if you open arachnoid, if you're above the diaphragma or anything else, it's a flap almost always. So that's our standard, and that's what we usually go with. And it was this I would say the case I showed was definitely a very, very outlier where I took a chance on a young, healthy guy to see if it worked, and so far it has. And I agree. I think fat is great because of the stem cell kind of component, and that may be where we go to in the future. But yeah.
Thanks. I would now move on to introduce Walid. Dr. Walid Azab is a good friend, the Egyptian neurosurgeon working in Kuwait right now. And has been instrumental in starting a training program there, and he's going to talk to us about unusual cellular lesions in children. Please, Walid, go ahead.
Thank you very much. Just a second.
Are you able to share your screen?
I'm trying to do that. Can you see it now?
Yeah.
Great. Mr. Chairman, dear colleagues, ladies and gentlemen, good morning, good afternoon, and good evening to everybody. It's a real pleasure to be here today. And actually, I'm so delighted to be among this fantastic group of experts and colleagues. So nice to be here. My topic today will be on the endoscopic endonasal surgery for uncommon cellular and paracellular lesions. Actually, apart from the common pathological entities which are encountered in the cellular and the paracellular regions, another group of uncommon or rare pathologies are seen frequently in these areas, and they should be treated as the condition dictates. Actually, many research groups have tried to classify the pathologies, these pathologies, especially for the cellular non-adenomatous and rare diseases, but currently there is no consensus on that regard. So today I will be discussing a couple of these cases. I'll be sharing them with you, and also I will be touching on the issue of endoscopic endonasal surgery for these lesions. The first pathology that I will be describing today is giant cell tumor of the clivus. This is really a very rare entity, and it has been found in the most recent literature report on the topic, that the reported cases are just about 15 cases. The reported in the English literature so far. This patient was a 15-year-old young boy who presented with left abducens palsy, and the preoperative CT and MRIs revealed this large and expansile tumor that has eroded most of the clivus, and is, if you look carefully, it is surrounded by a thin shell of bone. The tumor has completely filled the sphenoid sinus here in this pre-contrast MRI, and also here avid enhancement with punctate pattern on gadolinium administration, and the T2 pattern is really hypointense with some faint areas of hypointensity. So this is the surgery for the tumor. Here is a partially debulked lesion. The mass was very firm in consistency. However, it held a good plane of cleavage from the surrounding structures. Now the tumor is mobilized, and then bipolar coagulation is used to control its vascularity. It was moderately vascular, and also to try to shrink it. Piecemeal fashion of resection was used during the procedure, removing some parts and gradually developing the plane between the dura and the tumor. It was adherent to the dura, but with a good plane, so that was possible to be utilized. And a large scissors is used to sequentially debulk the tumor, because actually the CUSA wouldn't work at all in this. Further exposure of the dura, and the tumor is more exposed and debulked. Dura below and dura above, and then removing this. Now the bony involvement and the tumor tissue in the clival recess is removed. Look at these venous lakes within the bone and the tumor. and then the tumor at the in the neighborhood of the paraclival carotid, and the inferior cavernous sinus is taken away and piecemeal removal. Some CSF leak has taken place. Kerrison was even needed at some points after developing the plane to cut into the hard bone and the tumor. This was easily treated, controlled later, and the final bits of the tumor here are being removed. Here are the post-operative MRIs. Almost a gross total resection was achieved. A very questionable small area was left alone, was left there, and it was not sure whether this is representing a true tumor. The boy received denosumab, which has recently been approved for the treatment of the giant cell tumors, instead of giving him stereotactic radiation in order to give him a good to preserve the pituitary function, and his neurological deficit has improved, has disappeared, and he is doing well. This is the histopathology of the tumor as it was seen in the surgery. This is the thin rim of bone surrounding the thing, and the tumor consisted of large multinucleated cells and also mononuclear cells with a richly vascular background. Those large multinucleated cells are described as osteoclast-like giant cells. The next case is renal cell carcinoma metastasis to the clivus. Actually, according to one review done by Zhang et al. In 2018, the cases of renal cell carcinoma metastasis to the clivus have been only 12 cases. And this patient was a 62-year-old guy with previously no medical history, who presented with a left abducens palsy and only some headache. The MRI revealed this large lesion that has replaced almost the whole clivus. And the notable thing is those very large vascular voids seen within the material of the tumor. Actually, one of the very well-known facts about the natural history is that renal cell carcinomas present very late and they are so silent. Anyhow, this is the video of the procedure. I'm sorry for the quality. It is a bit older video. However, the tumor was removed in a piecemeal fashion. The most notable fact was the horrible bleeding in this thing. It was bleeding like hell in everywhere. From every single bit of the tumor was keeping bleeding. Again, the CUSA did not work in that, and a bit by bit removal, some bleeding from the cavernous sinus was controlled with the standard way of Surgicel and packing. All the materials were used: Flucil, Surgicel, gel foam, head elevation, everything. So it never stopped until it was completely removed. Accurate is used to here to remove the lower part, and finally some clear dura in the clival recess and hemostasis in the standard fashion. These are on the left of the screen. These are the post-operative MRIs. He was referred after, of course, after the histopathology came, and he was referred to the oncology colleagues for further treatment, and he did well. The next case is a giant sphenoid mucocele. This is a recurrent case who has been operated 1 year before in another center, and then he had some persistent headaches, and also he was having already a TSH low level after the first surgery. So an MRI revealed recurrence of this thing. These are almost constituting 1 to 2% of all mucoceles. The giant sphenoid mucoceles are quietly rare pathology. So marsupialization of the mucocele into the nasal cavity is being done. And here is a view inside the mucocele with the 30 degrees scope, the cavernous sinus on the left, and the cella, the tuberculum, and so on. the bone was completely eroded. There was no bone at all. And here is the clival recess. This is characteristic of this type of lesion. And another similar case, but this was a fresh one. The patient presented with oculomotor palsy, and he was having a similar pathology. This is the post-operative MRI here, and the view inside the cavity of the mucocele after evacuation. Now we move into the cellular pathologies. The first thing is a pituitary xanthogranuloma. The upper panel here represents the MRI of one lady who was referred to us from the endocrinology. They did this initial MRI and they treated her with corticosteroids on the premise that this might be some sort of a granuloma or something. Anyhow, she did not improve. Her main presentation was severe headache, and she did not improve. A follow-up MRI revealed those in the lower panel, as you can see here. The lesion has relatively increased in size, and the hypointensity in the center has disappeared, and you can note how the pituitary stalk is getting larger. So this was an indication for surgery to obtain a pathological diagnosis and to know what was in there. When we operated this patient, a striking, very vivid yellow color was so clear in this lesion, and this is so characteristic of pituitary xanthogranuloma, or what is called xanthomatous hypophysitis. The difference between the two entities is the presence of hemosiderin and macrophages. Anyhow, here is the appearance of the interior of the cella. The pathological tissue was adherent to everywhere inside. However, it was peeled off, and this is after removing of this from the posterior cellular wall, looking around the corner here in the cavernous sinus at the right side. And this is the final view after the conclusion of the procedure. Some yellow color is on the descending cistern. However, I decided to leave that alone because it was very thin and adherent in order to preserve the pituitary function of this young lady. Post-operative MRIs are here, and a complete excision of the pathology is achieved. She did a good recovery. One of the important factors that should be mentioned here is that there is a lot of controversy regarding the pathogenesis of the xanthogranulomas, and the most of the consensus is that this is a change happening in some in a Rathke cyst. Look at the preoperative, very reminiscent of a Rathke cyst. However, nobody knows exactly what is going on, but this is the current opinion in that subject. The next thing is this lady, a 36-year-old, who presented to us as a case of non-functioning pituitary adenoma. It really looked like a pituitary adenoma. No hormonal alterations except for a very marginal hyperprolactinemia, and otherwise nothing else. Intraoperatively, the lesion was noted to be very white and very elastic and with low vascularity, and actually the histopathology came consistent with sarcoidosis. These are post-operative MRIs. The lesion is completely resected. A very small sphenoid mucocele, which is asymptomatic, is present, and she is doing very well. Another entity is the intracellular arachnoid cysts, which are not so common because the sella turcica is actually devoid of arachnoid tissue. So it is quite rare pathology. Here is a post-operative MRI of the after the anterior wall of the sella and the cyst was open. Actually, all the contents that were pushed up have come down, and her visual problem, she presented with bitemporal hemianopia. You can see the anterior cerebral complex here going down, and she did a very good visual recovery. The next case is a pituitary apoplexy after COVID-19 infection. Actually, these MRIs are of a patient who presented to us on an emergency basis from another hospital that is one of the central care centers for COVID-19 patients. He had a pituitary adenoma operated 10 years in another center before, and he was following the endocrinology colleagues, and he was pan-hypopituitaric. Recently, he developed a severe COVID infection and was admitted because of his chest problem. The day before admission to our center, he was having severe headache and a very severe visual impairment and left oculomotor palsy. Here is how it looked. We had to operate that under strict, of course, under strict infection control instructions of the hospital. It looked like the standard appearance of any pituitary apoplexy in a large tumor. I just put it here because we are in this era. And actually, the cause of the pituitary apoplexy is just speculative. Only one case has been published in pituitary in September 2020. And this, of course, this tumor is much more larger in size and different in the MRI appearance from the published case. The causes here might be just that he was having the stress of the infection has led to a relative hypocortisolemia that was associated with an apoplexy. And the second speculation is that now there are reports on microangiopathy that are caused by the SARS-CoV-2 infection, and these could be contributing to such a condition. And the third thing is that this patient, as a part of his treatment scheme for the chest problem, he was receiving an anticoagulant, which might have also resulted into this acute presentation. Here is the, here is the view after removing the tumor and now separating the last parts of the capsule from the arachnoid. Note the old fat that has been put by the previous surgeon. And two examples of TB of the pituitary. This is a pituitary tuberculous abscess, and the other case is a case of tuberculous hypophysitis. And the last final case that I will be discussing today is a 15-year-old boy who presented with severe gradual visual loss. His MRI was showing this bifocal pathology, which is mostly consistent with a germ cell tumor by the radiological appearance. Germinomas always do that. However, the oncology colleagues necessitated that we get a tissue biopsy, a tissue diagnosis. And actually, in such cases, there is some degree of hydrocephalus that an endoscopic intraventricular biopsy can be obtained easily, and you just finish the story. But here it was not possible because of this very small ventricular system and set third ventricle. So it was deemed necessary to approach this lesion in this way. Here how the tumor looks. Please compare it to the MRI here on the right side, just elevating the tumor to see the anatomy around, and peeling the anterior third ventricular membrane and those vessels on the tumor just to have a clearer view. A biopsy was taken, and here is the optic chiasm and proximal optic nerves, and maybe this is the superior hypophyseal. I'm not sure, but this is a close-up view of the anatomy, and this is the post-treatment MRI. So in conclusion, the endoscopic endonasal approach is very critical and important, and I think it is something that has been of great importance and significance in contributing to our patients' care. And let me finally quote Oscar Wilde when he once said, "The true mystery of the world is the visible, not the invisible." Thank you very much.
Thank you, Walid. Can I ask Dr. Ruli Dahlan to comment and ask any questions before we go to the last two talks?
Okay, Dr. Chandra, it was a nice presentation from Dr. Walid. Maybe I will not comment much, but I think we better go to the next session first, and we will continue. Yeah.
Thank you. Venkat,
Very nice
share the
collection.
last two papers.
Yeah, very nice collection.
Myself
We
and
also
Vikram
had
are
some,
not presenting because of time constraint, really.
Yeah, time very.
so we had some cavernous angiomas and hemangiomas also in the cella, which very interesting collection, Dr. Walid. Yeah,
Thank you very
we'll move
much.
on to
Yep.
the, yeah.
Yeah, I agree.
Yeah, Dr.
I
Pujari, you
agree,
wanna
and
speak?
I think everybody has so many of the. I don't think I have a very large number of cases like that, but interestingly enough, that some are worth further evaluation and insights, because they are not so common actually.
That's true. Correct. We'll move on to the next talk by Dr. Sarat Chandra. He's a professor of neurosurgery at the All India Institute of Neurosciences. He's primarily interested in epilepsy surgery and contributed a lot of new techniques. Other interests are cranial-vertebral junction surgery, minimally invasive surgery, neuroendoscopy, and neurosurgery, neuro-oncology. So Professor Sarat Chandra is a very good surgeon and a good teacher. So over to you, Dr. Sarat. Dr. Sarat, are you there? Can you?
Yes, sir. Good
Can
evening.
you share
Can
the
you hear
screen?
me? Yes.
Yeah, yeah. We can hear you. Can you share the screen?
Can
Yeah.
see.
Can you
We
see
can
my
hear you.
screen now? Are you able to see the screen?
Yes, Professor, we can see.
Yes, go ahead. Yes, go ahead.
So good evening, good afternoon, good morning from whichever part of the world you're from. It's indeed a great pleasure for me to be in this part of this very exciting workshop. And I thank Dr. Deo Pujari for having done this excellent job. So today I would be presenting something about hypothalamic hamartomas, which I consider it as quite an enigma because of the clinical semiology and the challenges associated with it. And before I proceed, I would like to acknowledge my very huge epilepsy surgery team, and we have a full team both for the clinical arms as well as for the research arm. And particularly for hypothalamic hamartomas, I would like to acknowledge my colleague, Dr. Ramesh, who has contributed a lot towards this series. So this study has been funded by Department of Biotechnology and is part of the Center of Excellence for Epilepsy and MEG Mapping. So we published this paper 2 years ago, and currently it's rated as one of the top 10 papers of NEGM for 2018 and has more than 200 citations. And what it has shown in the paper that in this, the first ever randomized controlled trial for children suffering from drug refractory epilepsy, it has shown that children who undergo surgery have a tenfold are likely to become seizure-free tenfold more than children who do not undergo surgery or undergo medical therapy. And not only that, it also showed that children are highly prone for cognitive encephalopathy, hence epileptic encephalopathy. Hence it's important to subject surgery to children for drug-resistant epilepsy as early as possible. Now, if you look at hematoma comes from the word hamartia, which means fault or defect. So basically, it's a tumor-like malformation which is made of abnormal mixture of cells and tissues found in various areas of the body where the growth occurs. So it's not a tumor, but actually it's mixture of all the components which could be found there. And typically and most commonly, it happens in the region of hypothalamus. But very uncommonly, like we have published some time ago, and there are about 8 to 9 cases published worldwide, it could also happen in cerebellum. And interestingly, this is the only lesion in the posterior fossa which may present with drug-resistant epilepsy. In fact, the case which we published presented with status epilepticus and was the youngest child we operated, was just about 4 weeks old. So if you look at the clinical presentation of hypothalamic hamartoma, basically it consists of dysmorphic cells and they are actively firing. So commonly they present with gelastic epilepsy, which happens in about 60 to 70% of the cases. Rarely they could also present with the dacrystic or crying seizures. And in about 30% of the cases, they present with precocious puberty. So they have all the components of precocious puberty. And older children could present with psychiatric and behavioral disturbances. 90% are obviously sporadic, but in about 5 to 10%, they present with Pallister-Hall syndrome, which is an autosomal dominant trait in which the children present with polydactyly as well as skin syndactyly, and they also have precocious puberty. So we had one case of Pallister-Hall syndrome. So here I would be discussing about the clinical semiology, the video EEG and the MRI using epileptic protocol and how it could be graded using the Delalande's grading. Now, among all the substrates presenting with drug-resistant epilepsy, hypothalamic hamartoma is something which could be easily diagnosed, and it's one of the pathologies where you do not require a bunch of investigations. For instance, in this very important paper published in Epilepsy, in which our center also participated in this, we have shown that for hypothalamic hamartoma, it's advanced investigations like 3D EEG or PET or SPECT or electrocardiography, these are least indicated. You don't require this. What actually required for investigating hypothalamic hamartoma is a very good video EEG and an MRI to ensure that you have a good localization. Now the EEG, what we see in hypothalamic hamartoma, inter-EEG could be normal or may demonstrate focal findings. An ictal pattern of background suppression may be followed by fast activity, and it is commonly encountered. However, EEG or both ictal and inter-ictal could be pseudolateralizing, because of which it's very important to correlate with the MRI. Now here you can see the example of a typical gelastic epilepsy. So they come out like bursts, automatic bursts of laughter. So you can see over here the child is kind of feeling as if the child has to forcefully laugh. And as soon as the episode of gelastic epilepsy is over, the child starts crying because the child realizes that something abnormal has happened. We have even operated kids who were about slightly older, 4 or 5 years of age, and because they were continuously laughing in school, they thought that this child was possessed by some evil spirit, and they were taken to some local witch doctor, and finally the child came to us for surgery. So even such a possibility can happen, especially in rural areas or in areas with low level of education, where people may start thinking that the child is possessed by evil spirits. So if you look at the various, obviously surgery is the only definitive method. There is no other method available. And if you see, there has been a whole range of evolution of surgical techniques. So obviously in the about 2 decades ago, the only thing we could speak was microsurgical treatment, which could be from various approaches. And as of today, microsurgical, I hardly think anybody practices microsurgical treatment because it's so invasive. You have to do a craniotomy. And then approaching the hamartoma from outside is really dangerous because it's covered by perforators. So one should always approach it from inside and then disconnect it. And obviously also one should not try to resect the hamartoma. I think the main revolution came with the introduction of endoscopic disconnection, especially from the Barrows Institute. And then of course there was some role of radiosurgery. And again, there has been a resurgence of laser ablation. And then finally we introduced, which I would be showing, a robotic guided radio frequency thermal ablation, which has now become the standard of treatment for our center. So this is the Delalande's grading, where you could have type 1, which is pedunculated, and then you could have type 2, which is inside. Type 3 is again a large hamartoma, and type 4 is a combination of all. So in this case, all the types could be treated very nicely with radiofrequency thermal coagulation. So this was a case which I treated several years ago, a child presenting with the precocious puberty and gelastic epilepsy. So you could see this is a large type 3 hamartoma. And in those days, I did the neuronavigation guided endoscopic disconnection, which was initially, as per the literature I found, was described by Choi et al. From Korea, but later on was taken up in a very large scale from Barrows Institute, especially by Dr. Raket. And in this, even though the ventricles are chinked, it's very important to approach it from the opposite side, as you can see from here, so that we approach the pedicle. And then once we approach the pedicle, we start the disconnection. So here we have identified the interface between the brain parenchyma and the hematoma, and then we start the disconnection. And it's a long procedure, especially for largest hematomas. For smaller hematomas, it becomes over very fast. But as you can see in the post-op MRI, we were able to achieve a very nice disconnection, and the child improved very well. And you can see this is just 1 week after the surgery, and you can see that all the precocious features have all disappeared and the hormones have also normalized. Now, but obviously one can see that the endoscopic approach is very difficult. It requires a lot of skill. And that's when we started approaching for alternative methods of treatment. And that's where I came across the study by Professor Kamiyama. And then when I met him in the Asian Epilepsy Surgery meeting, both Professor Kamiyama as well as his colleague, Dr. Shirozu, I discussed with them for quite some time, and then understood the method or the technique by which they do the radio frequency ablative disconnections. And they actually operate an hypothalamic hematoma institute in Japan. And they have done more than 200 cases now using a frame-based radio frequency thermocoagulative disconnection. And in their experience, they have found this to be extremely effective. Now, the same thing we came back, and for the first time, we combined it with a robotic system using ROSA. So in our technique, what we do is we take the robotic system along with the O-arm, and we use a Lexel radio frequency pulse generator. And these are the instruments which we use along with adapters. And this is how we do the planning. So we approach from both the sides, and we ensure that it goes quite deep inside, and we start burning at the depth and slowly withdraw from inward to outward so that we are able to create a nice plane of disconnection. So we don't plan to burn the entire hematoma. We kind of create a disconnective plane. And I believe it is much more better than laser, because in our institute, it just costs us about $30 US. That is it. Because rest of the equipment is provided free of cost by our university. And I think it's a very good technique, especially for areas where patients are financially challenged. And technically, it has an advantage because you could use the radio frequency thermocoagulative ablation multiple times using multiple trajectories, which is a limitation with laser, because in laser, you have to put one port inside and you have to keep on burning till the whole burn increases in size till it comes to the level of the interface. This is quite okay for small hematoma, laser ablation, but for bigger hematomas, it becomes a challenge. And I will show you some of the giant hematomas which you have done using this technique. So we produce a lesion for about 74 degrees for 60 seconds. And this is a brief video to show how it is done. So in this case, you can see we are using a giant hematoma. So we have this kind of setup where we take an O-arm as well as a robotic arm, which now performs a laser contouring. And then through the skin, we use a twist drill. And then we measure the electrode length once we go through the dura, and then introduce the electrode till the point where we have measured, which is the target. And then we co-register with the MRI. So this is the robotic trajectory as well as this is the trajectory by the navigation. So this has to completely superimpose with each other so that we know that we are directly on that. Then we produce a lesion for 60 seconds using a temperature of 74 degrees. And you can see at the end, we have a nice disconnective lesion. So till date, we have operated 16 patients using this technique with an age variation of 7 months to 20 years. Most of them presented with the gelastic epilepsy, and 4 patients presented with precocious puberty, and 1 with Pallister-Hall syndrome. And as you can see, we have done a 3 Tesla MRI epilepsy protocol for all the patients with the video EEG and a complete hormonal workup. We have rarely used PET. We have used PET and SPECT only in 2 cases where the neurologists have expressed a doubt in localization. They thought perhaps there is an additional lesion somewhere else. And as you can see, a majority of our patients had a type 3 kind of a hematoma. And this again, you could see the kind of grading what is there. And 4 patients presented with precocious puberty. CPP stands for central precocious puberty. The outcomes were quite encouraging. Most of them following the first surgery had a class 1 outcome. Those who had a class 4 outcomes had giant hematomas and have undergone surgery 2 times, after which they had a class 1 outcome. So the advantage of this technique is because it's minimally invasive, you could go on repeating as many times as you want. Now we have also repeated for the third time, and it gives you very good results. So again, you can see the outcomes, they increase as and when you go on repeating the surgical techniques. And in this case, it's not a challenge because it's not an open surgery. Hormones in puberty in all the 4 cases improved dramatically, as also demonstrated by the improvement of both the hormones like LH as well as FSH. These were the complications. The commonest complication was fever, but apart from that, we had other transient complications which improved over a period of time. So just to show you a few cases, this is a type 1 hypothalamic hamartoma having 15 seizures a day. So following post-op, you can see that there is a nice disconnection between the hamartoma and brain parenchyma. This is a type 2 presenting with 20 seizures a day. And again, following disconnection, we were able to achieve good outcome. This is a type 3 where we have produced as many as 20 lesions. And again, we were able to achieve a very nice disconnection and patient was seizure free. Now this giant hamartoma required as many as, I think, close to 44 lesions using 8 trajectories. And this is what gave me the idea of performing a hemispheric disconnection, which is now going to come up, has been accepted in Journal of Neurosurgery, and it's going to come up soon. And you can see here we repeated the surgery 3 times, after which we were able to produce a complete disconnection. And you can see this giant hamartoma. It's a challenge. I don't think it could be operated by microsurgical excision, but by using this minimally invasive technique, we were able to produce a complete disconnection. So I will skip the video for the giant hamartoma because I've already shown that. Now there could be residual pedicle left as shown here, but again, a repeat surgery is quite straightforward and one can always repeat the surgery. So I think the main advantages of our technique is that it's safe, it's accurate, it's effective. We've been able to achieve close to 90% class 1 outcome. It's faster, it's frameless, it's minimally invasive. It's inexpensive for universities who can invest into the hardware, which includes the O-arm as well as the radio frequency ablation. So the initial investment could be expensive, but because ours is a government funded agent hospital, we charge just $30 for the patient, which is the cost of a burroll. And the best part is it could be repeated. And you could as well as use a frame-based procedure also. There's no problem with that. Obviously, the limitations of a study is a short follow-up. We have follow-up up to 2 years. But overall, the long-term results seem to be quite encouraging. And definitely the advantage is that using the robotic system, it's faster, it's accurate, no human error. So these are the papers which we published. And these are other minimally invasive endoscopic techniques for epilepsy, which we developed and quite well published, which includes endoscopic hemispherotomy, endoscopic corpus callosotomy. And finally, a view of our Center of Excellence for Epilepsy, which includes both the clinical arms as well as the research arms. Thank you very much.
Thank you, Professor Sharad. It's a very nice presentation and an update on the latest technology that can be used. Now, after the endoscopic disconnection, good number of children complain that they're a little drowsy in the daytime. Did you have the similar experience for a while?
Yes. Now, endoscopic disconnection, even though it looks very attractive on paper, but when I tried it, I was always, not at all comfortable, especially for the larger hematomas, type 3 hematomas, because the ventricles are chinked. And when you put in an endoscope, the differentiation between the parenchyma and the hamartoma is not very clear. And when you start burning, you're always worrying whether you're going into the diencephalic nucleus. And that's the reason I gave it up ultimately. It looks very nice on video, but overall, I never liked the procedure. Now, when we switched over to this robotic guided radio frequency ablation, we really love it. At best, you may have to repeat it maybe once or twice, but the outcomes are fantastic. So once we do it, the patient is awake on the table itself, and it can be shifted to ICU. It looks as if and there are just a couple of stitches put. We don't even put a burr hole. We drill directly through the skin, and we have to apply 1 or 2 sutures on the skin.
Yeah, when you plan for multiple lesions, what happens after the CSF leak? Will there be any shift? How do you recalculate that? Are you completely plan with the robot?
When we use a twist drill directly from the skin into that, there is absolutely no CSF leak. So when we are withdrawing, we inject some glue into the twistril and then we put a suture. So there's absolutely no CSF leak. In burhole, you could have a CSF leak. That is a problem. But I believe even if you have a CSF leak, because the pathology is centrally placed, it's exactly in the middle of the brain, I don't think there is going to be too much of a shift here.
Sure. Okay. Thank you. It's a very nice presentation. I now invite Matthew Joseph, Professor and Head of Neurocritical Care Unit, CMC Vellore, to talk about his paper. Dr. Matthew.
Is my screen visible?
Yeah, yes, please go ahead.
Yes,
Okay. So I'm going to end this very exciting series of surgical lectures by doing something that is completely non-surgical. All right? Which is damage done to the hypothalamic-pituitary axis by head injury. We've known about this for a long time, more than 100 years. All right? And the deficiencies can be in any part of the anterior pituitary posterior axes. Any of the axes can be affected by trauma. The damage could be direct trauma to the gland, to the stalk, or to the hypothalamus, or it could be indirect, either by systemic insults to the body, and therefore damage to the pituitary as part of the systemic insult. Could be because compression of the portal veins, arterial vasospasm, and in chronic hypopituitarism, an autoimmune mechanism has also been postulated. There are not very many recent autopsy studies, but the older studies seem to show that the damage in the pituitary is mostly ischemic, whereas the damage in the hypothalamus is mostly hemorrhagic. Now, how common is it? It's a very difficult question to answer because it depends on which patients you choose, it depends on which axes you test, it depends on how hard you test, depends on when you test. About a quarter of the patients after significant head injury have some degree of hypothalamo-pituitary dysfunction. Seems to be a reasonable estimate. When I give this talk for a general neurosurgical audience, I presume that most of them would not have seen the literature related to this because it would mostly in endocrinology journals rather than neurosurgical journals. With the audience for this symposium, I presume more people will be aware of it, but actually there is a lot of literature on this, which does not make an impression on the general neurosurgical population that is managing head injury patients. I will be quoting this article fairly often since it's one of the few systemic guidelines that are available. It's basically a consensus group in the UK, which has put out guidelines for management of pituitary dysfunction following traumatic brain injury. Okay. This thing was put out in very early 2017. 1 year later, what they found is most people knew that the problem existed, but very few people did anything about it. Now, why does this happen? One problem is patients rarely present with typical features. The features are very often non-specific and difficult to diagnose. And the second is of convincing yourself that you need to do this, setting the priority for this. I first gave this talk in, I think, 2012. And I must admit, I still do not do routine checking. I have a separate trauma outpatient. And when my patients come with these non-specific features, I must admit, I also don't check. Okay, so I'm preaching, but I'm not practicing what I preach. Now, I'll go about the description of the dysfunction in 3 phases: acute, subacute, and the chronic. Acute is easy. Basically, what you see in the immediate post-traumatic phase is hypocortisolism, which you'll diagnose quite easily, and diabetes insipidus due to damage of the posterior pituitary. These 2 are fairly easy to diagnose, and the treatment is fairly straightforward. In the little bit subacute area, after the first 2 or 3 days, a lot of us encounter hyponatremia. Again, the incidence is very variable, and significant hyponatremia has causes a lot of problems for patients with head injury. Now, This is the classical teaching. I'm not going to go into this. Basically, I'm going to assume that our trauma patient was perfectly well before the trauma, before the head injury, and therefore endocrine dysfunction and the other two causes of hyponatremia commonly are either cerebral salt wasting or the syndrome of inappropriate ADH secretion. Okay. Now, if you look at the diagnosis, very summarized diagnostic criteria, cerebral salt wasting, SIADH. Cerebral salt wasting, SIADH. The only difference is the volume status of the patient. All right. Now, we had this beautiful, easy algorithm for treatment of hyponatremia in trauma, which is you had hyponatremia, you had a high urine spot sodium, you check the CVP low, treat cerebral salt wasting, CVP high, treat as SIADH. Easy, simple. Then what happened? Our critical care colleagues said CVP is not accurate. CVP cannot be relied on, and conveniently forgot to give us an alternative for measuring the volume status in an ambulant patient. All right, which means our algorithm fell apart. Now, I don't know how many of, I'm sure most of you will remember the scenario 30 years ago when a solitary enhancing lesion, a ring enhancing lesion in the brain was treated with antituberculous treatment, was given ATT. And with antituberculous treatment, the lesion disappeared. Therefore, the diagnosis was obviously tuberculosis. It's only in the last 30 years we've realized that it is not tuberculosis. Even if you did not give the patient antituberculous treatment, the lesion would resolve because it's a solitary circus granuloma. Similarly, hyponatremia post-trauma will resolve if you restrict fluids. Whether it is cerebral salt wasting or SIADH, the hyponatremia will resolve. And restricting fluids, especially in the warmer countries, is quite dangerous. So we came up with an alternative 3 years ago, which we find quite effective, which removes the need to differentiate between cerebral salt wasting and SIADH. So our protocol now goes like this. You have hyponatremia with high urine spot sodium, you start the patient with fluorocortisone. If the patient does not correct with fluorocortisone, check serum cortisol. By the way, serum cortisol in these patients, in an acutely ill patient with hyponatremia, if you find a lesion value of 20, please don't assume it's normal. That's a relative insufficiency. Okay? You would expect to find 50 or 60 or 70 micrograms as a value. And if after correcting the serum cortisol, the urine spot, the serum sodium still does not correct, at that point, you treat the patient as SIADH. And believe me, not even 1 in 20 patients gets this far. The vast majority of patients get corrected here or here. Very, very few need treatment as SIADH. Now, moving on to the chronic. The commonest dysfunction is growth hormone gonadotropins. The least common is thyroid. All of us know the clinical symptomatology of each of these things. But unfortunately, the patient does not present with typical syndromes. The patient comes with lethargy, memory impairment, can't walk, irritable, various problems like that. And our general reaction, at least my general reaction used to be, listen, basically get a grip on yourself. Okay, you're just, I wouldn't say to use the word malingering, but something very close. Basically, you insinuate that if the patient really tried, the patient could be well. Assuming the entire problem was, a psychological problem, without even thinking of the fact that this actually could be an organic problem which could be investigated and treated. Okay? Even the British Neurotrauma Group, which published those guidelines, say that the symptoms are quite difficult to diagnose. So what do? We can't test every head injury, that's too expensive. All right? The recommendations they made was any patient who was admitted for more than 48, who required admission for more than 48 hours, test at 6 months. And anybody at 6 months who was admitted for less than 48 but still had symptoms, test them as well. Which basically means what they're saying is anybody who's not okay at 6 months post-trauma, test them. Now, I am not going to recommend a testing regimen. It depends on where you work. It depends on how you work. But definitely, we need to do more for this problem than we're doing now. Right? We need to investigate it. We need to be aware of this problem. In my talk, I have not covered how to test or how to treat, and I have not covered a huge chapter which is on the same problem with children, which is obviously a much worse problem than a problem with the same thing with adults. So I'll stop here. I'll conclude that more than a quarter of the patients following significant head trauma have some amount of hypothalamic or pituitary dysfunction. It is difficult to diagnose. And because it is not in the forefront of our mind, very often we do not diagnose it. We never even think of looking for it, which is sad because if we treated them, we could actually make them much better. All right. So my request is please, and remember, the patients I'm talking about far outnumber pituitaries, craniopharyngiomas, and other weird paracellular lesions. All right. We're talking about a huge number of patients. So please, if you deal with head injuries and the patient comes to you with non-specific problems months after trauma, think of a hypothalamic pituitary dysfunction and test for it. Thank you.
Thank you very much, Dr. Matthew Joseph. Full talk, very, very important topic, but often remains theoretical, not in practice. So Indian Society of Pediatric Neurosurgery is coming up with the guidelines for the head injury. I would request you, I'll get in touch with you if you can contribute to this, add it on into the guidelines, which is going to be published very soon. So it will be a good contribution. So it's a very nice topic, and often we don't look into it. You are absolutely right that neurosurgeons, including critical care people in the ICUs, in the neuro ICUs, don't look at it in a very serious fashion. And I think this is something to be introduced as a routine practice. Any questions?
Yeah, Dr. Matthew, maybe I want to ask your opinion.
Yeah.
In our center, most of these case of hypopituitary dysfunction after head injury, so many head injury here, it's related with diffuse brain injury, and we try to do the comprehensive hemicraniectomy, very huge, and some of the patient is getting better. So I wonder if the abnormality of the dysfunction is due to the diffuse intracranial pressure or from the pituitary itself. I want to know your opinion, because some of the patient is getting better after you open all the fast craniectomy.
Okay.
I don't know.
Yeah. So one thing that makes this even more difficult is that the severity of the injury and the degree of pituitary dysfunction do not correlate. Severe have bad dysfunction, mild have bad dysfunction, the moderate don't have that much dysfunction. So it's very difficult to correlate between the severity of the injury and the likelihood of hypothalamic pituitary dysfunction. All right. And raised intracranial pressure in itself, as is evident from the autopsy data shows that most of the pituitary dysfunction is ischemic, which is quite likely caused by the raised ICP itself. So the very fact that the patient has raised ICP could be the cause of the pituitary dysfunction. So it's very difficult to sort them out and say, okay, this is because of pituitary, this is because of raised ICP.
Okay, thank you, sir.
Thanks, Matthew.
So thank you very much. You all agree with me that we had a wonderful session. I thank all the speakers. Unfortunately, due to lack of time, Dr. Dev Pujari could not give his talk. Now it's over to Dr. Dev Pujari. I would like to congratulate Dr. Dev Pujari and Dr. Moody for organizing this wonderful symposium, which has covered wide range of topics and really a true update, in fact. Dr. Dev Pujari, over to you.
I am sorry to drop out actually, but the logistics is really finding it very difficult to continue. And it is time for my pleasant duty to thank all the speakers, moderators, um, all my colleagues who have helped me, especially Vikram and Krishna, the neuroendocrine committee members of the WFNS, especially my co-chairperson, Dr. Qureshi, and I think the WFNS leadership also took an active role. I must thank Franco and Dave Adelson as well. Wama Events actually gave us the logistic support, a local company, and Sun Pharma, a local Indian multinational company, has given us some financial grant for this symposium. So I thank everybody. And I really had, I mean, though it was quite exhaustive, I think it has also been exhausting, but many of you stayed back, and I must thank everyone for their contributions, for their patience, and for their active interaction. Anybody would like to say something? I'm happy. We can be on for another 5 minutes, maybe.
I would like to say something. It's very beautifully structured symposium, and the first time we are doing this on online, and it gave us the freedom of staying at home, at the same time having the real update of the current state of the art of dealing with these neuroendocrine conditions. So I think we had a galaxy of speakers across the globe. Majority of them are real authorities in their own way, in their own subjects, and it was really beautifully done. And one great thing is that we had one of the best symposiums without any technical snags. We had a very smooth conference. It's a wonderful thing. So congratulations once again.
Thanks all the masters who agreed to participate and kept their word. To end with, I'm showing a slide for a webinar which starts with the Neuroanatomy Committee for the WFNS over the next 2 days, Tuesday and Wednesday. So those of you interested, please attend this. It will also be streamed like what this program has been done on YouTube on the Neurosurgical TV. And I thank John Bennett of Neurosurgical TV to take that up when our registration started overflowing. Thank you. And for Indians, good night. For others, a very good day.
Good night, everybody.
Bye.
Good night, everybody. Thank you so much.
Thank you, Dr. Chandra.
Congratulations. Congratulations.
Thanks, everyone. Thanks, Amin, for joining us. Thanks, Domenico, for being with us all the way through since yesterday. And I think our senior most colleague, Andre, is still with us, right?
Yes.
Yeah.
Also Roman.
And Roman, yes.
Yes. Nice to see Amin after a long time.
Yes, long
pleasure. Yeah, thank you. Chandra, amazing work, Modi. This is probably the easiest commute to Mumbai I've ever had. So sign me up.
It's been a new experience, and we have been, keeping busy with some programs. Initially, it was probably just to find something to do, but now it seems that it is becoming a way of life, and it is a good way to learn. Though I think this became too long a program, I think this is going to be our future, and we'll probably be, till we meet physically, I think this will continue. Thanks, James. Thanks, Hemant.
Thank you.
So we take your leave then.
Good night.
Thank you, Dr. Roman, and
Good night.
everybody.
Thank you.